So very warm welcome. I'm just going to pass straight over to Joanne. Joanne is our Director of Evaluation. Joanne has worked with the British Academy, who I forgot to say have supported this programme, so thank you very much to them for supporting today. Joanne has convened all of this, brought you all together. So without further ado, I'm going to pass over to Joanne, who definitely doesn't need a microphone.
Thank you, Michael. Thank you very much. It's working. Oh, I prefer without, actually. Okay. Thank you very much. So excited to see such a diverse audience, academics, policymakers, practitioners, I hope, in the mix. And hi to everybody online as well. You might be able to see what I'm saying if you can't hear me. Can they hear us online now? Oh, okay. Okay, I won't put you under. So, yeah, I was just speaking to Katie. I haven't done this all myself. A big thank you to Katie, Natasha and Irina and other colleagues like Mari in Socrates in NatSen for supporting pulling this together. It was about 18 months ago when we saw the call for the British Academy and thought, right, let's go for this. So we were so excited to be invited to put this conference on. And as Michael said, it's one of the major issues facing society today. I mean, I guess what's sad for me is having worked in mental health on and off over the last, I'm not going to say how long I've been working for. It's just really sad to see that we're in this situation today, that, you know, things frankly are not getting any better. Inequalities, the inequality gap is widening. So I think it's a really pivotal time for us all to come together, to look at the latest evidence, consider it, reflect, talk to each other, think about, you know, what is it that we collectively can do over the next 10 years to maybe hope that in 10 years' time when we come back together, we're in a different, better situation. So the plan for today was to be a very participatory conference. This venue is beautiful, but it doesn't really allow us to get you into groups and move you into side sessions. So our programme is packed. So there's a lot for you to listen to, but also what we really want is to feel that you can participate. As you've been told before, there's lots of sessions where you can get involved. We've got Menti up. Lucy's going to tell you a bit more about that when she gets up. But that's the point of today, is to have a conversation, to reflect together on all of the interesting evidence and policy updates that we hear about, and to think together what are our priorities for the next 10 years in terms of research and other actions that we can take to make some positive difference. And yeah, thank you. I'll hand over to Lucy Schoonahavel, who's going to chair the morning session.
Hello, everyone. Thank you, Joanne. We're going to be tag teaming quite a bit today. So I'm just going to move on to that and then explain a bit about this. So it's wonderful to be here today. Thank you for having me. And I'm really delighted to be chairing this absolutely jam-packed agenda on research, policy and practice. I want to start how we intend to go on today. We want there to be as much dialogue, discussion, conversation, questions and answers as possible. And there'll be loads of opportunities throughout the agenda, both in the room and also online as well. If they can hear us still, hopefully they can. And because we've got such a packed programme, we will be needing to keep to time, and so we thought we'd take the opportunity to have this Menti. And this is where you can share your thoughts, and we can then get them up on screen at regular points throughout the agenda. If you haven't used this before, it's basically an interactive tool where you can either take a picture of this QR code or log on using the details at the top there, so menti.com, and then putting in the code. And we'll be able to see, so we'll be asking questions. So when you get on there, have a look at what the questions are. I can see people are already taking part, which is amazing. So we'll be getting that up in a minute. And we'll then be able to share on screen what people are saying, and that can help generate a bit of a discussion as well. So to get warmed up, really like you to log on now, can see people are, start answering this question. In the meantime, I will just say a few words about the really impeccable timing of this conference. So what a time. on the coattails of the fascinating prevalence data that NatSem published a few weeks ago, which we're going to be hearing more about shortly. And then last week in Westminster, the Westminster government announced the 10-year health plan, where we understand now that mental health will have its own national service framework, or modern service framework, as it's now going to be called, and neighbourhood mental health centres will be rolled out around the country. Yet, on the other hand, commentators have said that governments around the UK really aren't going far enough, in particular around prevention and addressing inequalities. Quite rightly, we can see that mental health does remain at the top of government's agendas around the UK, but is it enough, and is it translating into practice everywhere? I think probably most people here would say no, and this is why this conference is so important. So we're going to be hearing from 18 distinguished speakers and experts on this very topic of policy and research into practice. I also know that there are plans to ensure that all conversations taking place here today are synthesised and shared afterwards by the wonderful NatSen team, and ensuring that the learnings that come out of this are then, from our amazing speakers, are then really able to live on and hopefully actually influence policy and practice on the ground. Finally, I just want to share an important trigger warning, because you might have seen on the agenda there are going to be some very sensitive topics discussed today, particularly around suicide. So please do take any time you need. As people have said already, there's a green room in there, or take some time out and you can go out where you came as well. So please do get involved, ask questions, share your thoughts, look out for the follow-up afterwards as well. And on that note, I think we can have a look at the first mentee, which is already up here. So we've asked, what do you think should be the key policy and research priorities for improving the UK's mental health? I think front and centre, we've got young people, which is amazing because we've got a whole section on that after lunch. We've also got prevention and social determinants and inequalities, all of which will be discussed today. And I think everything that has already been mentioned by Joanne and me already, but absolutely clearly not being done enough on by governments around the UK yet so far, and potentially more that can be done in research as well. So, without further ado, I'd really like to introduce our first keynote speaker, Mari Tombs-Smith, who's the Director of Health and Biomedical Surveys at the National Centre for Social Research. And Mari will be sharing the fascinating findings from the 5th Adult Psychiatric Morbidity Survey.
Right, thank you, Lucy. Welcome to everybody here, as we're really excited to have an opportunity to deliver this keynote presentation. And really what I'm trying to do with my talk is to provide context for today. So to share what the big picture of mental health in England is. And as has already been mentioned, I'm doing this by sharing findings from the Adult Psychiatric Morbidity Survey, or APMS, which is a gold standard survey of mental health conditions and service use. And I'm sure some people in this room will know this study intimately, and others might be hearing about this for the first time. So just a few kind of key features of this before I jump into the results. So it is a large-scale random variability survey of adults in England. It's carried out face-to-face, so our interviews go to people's homes and have really long, detailed conversations about their mental health. And it has been carried out in this format for over 30 years. So we have 5 surveys to compare, to look back to. It's carried out by us, NatSen, but we would not be able to do it with our collaborators from the University of Leicester and City St George's University of London, and the funding comes from NHS England and Department of Health and Social Care. So what is so special about APMS? APMS is something that really gets us closest to what we call truth about mental health, the big picture in England. And it does this by being representative of adults in England. As I said, it's a random probability survey, and it consists mainly of detailed, validated, condition-specific instruments that we ask people to go through, and that means that we are not dependent on self-assessment of what conditions people think they might have, and we're not dependent on whether the conditions have been diagnosed, undiagnosed, so NHS waiting lists don't affect what we're getting out from here. And for more complicated questions, we also have a second phase of the interview that consists of clinical semi-structured interviews for more complicated conditions, like autism and psychosis. And our time series, because we haven't really changed the way we do this survey, a lot of the questionnaire is the same, it means that we can confidently tell you what the time series are across the past 30 years. And it's really great timing as well, because we published the first part of APMS 2 weeks ago today. There is a second part to come, and I will tell you a bit more about what's in there. But in the first part, we have common mental health conditions, treatment and service use, suicidal thoughts, suicide attempts and self-harm, and then some more specific topics, gambling behaviours, PTSD, and ADHD. In my talk today, I'm going to be talking about the first two of those, but I'm sure that speakers later today will pick up on some of the other themes as well, so we'll hear more. Right, so what are the key findings then? So, as has already been mentioned by the people introducing me, the proportion of people with a common mental health condition has increased since last time we did this study. And now, 1 in 5 adults, so that's 20% of adults in England have a common mental health condition. So that actually refers to 23, 24. And I will have just a really quick methodological detour here, so it's more easier to understand my slides as I go. So how do we measure this? We measure this by using CIS-R, which is clinical interview schedule revised, which is a really detailed questionnaire about specific symptoms, behaviors, frequency, what has been happening. And what it allows us to do is to do 2 things. So we can classify people based on the severity of their conditions. So we talk about people who have a CIS score 12+, which means that they would benefit from some clinical recognition. And then we talk about people who score 18+, which means that it would warrant some medical intervention. And we also separately can classify people based on what kind of common mental health condition they have. So on the next chart, we can see what CIS scores 12+ and 18+ have been doing since the early 1990s. Here we're separating out between men and women, and between the moderate and the severe conditions. And what you can see, the key message is that all of them have been going up since last time we did the survey, which was in 2014. And why is this? Cross-sectional surveys such as APMS unfortunately cannot give us an answer, and precise answer to this question. What we can say is that in the society there have been quite a few changes, developments. For example, austerity, cost of living crisis, we've had COVID, and all of these things are known to be linked to mental health. So looking at the specific common mental health conditions and their prevalence, so as in previous APMSs, the most common condition is actually the general category of common mental health condition, otherwise not specified. So it's just where people's symptoms didn't allow us to classify them into a specific category. But looking at the specific conditions, the most common by far is anxiety. So 7 to 8% of adults fall into that group, followed by depression, 4%, phobias, OCD, and panic disorders. And focusing on anxiety, again, I'm not sure if I'm able to do that. So I think, again, one busy chart. I was reprimanded for having 2 busy charts. But the thing to look at here is that the mental health condition that has had by far the steepest increase is the anxiety related conditions. And depression, phobia, OCD also have seen an uptick, but nowhere near on the same scale. And so I've also asked people, what do they think they have? Do they think they have a common mental health condition, and whether they have been diagnosed? And the good news is that most people that we identified as having a common mental health condition, they also themselves thought that they had one. But what we can see, we were asked what it was, and actually the most common thing that came up was depression, both in terms of what people themselves thought they had and what they had been diagnosed with, and anxiety-related things actually far less common. So there's something interesting going on there. Right, so which population groups are most affected? So as already has been mentioned, definitely young people. So looking at the severity of mental health conditions by the age group, we can see that the youngest people have the highest proportion with 12 plus symptoms, and it only starts to fall in the old age groups. And the grey bars here, these are the symptoms that would benefit from the clinically significant level of symptoms, and here the blue ones are the severe symptoms. And we can see that this reduction actually is mostly happening through the reduction in the severe symptoms rather than this group here. And what has been going on over the years? So again, apologies for another busy chart, but I think the main thing just to look here is that all of the age groups are trending upwards, but particularly the youngest age group here, unfortunately. And again, reasons for this, it's probably some of it could be similar pressures that the overall society is facing, so around finances, etc. But also we're thinking about things like concerns about the environment. I don't think we can, with full confidence, to say what social media, what kind of role this is playing in this, but it's potentially one of the factors. So moving on to socioeconomic inequalities. So again, these were found throughout the PMS series, and they persist. It's something we very much found this year as well. So we are looking at it in a number of different ways. So first, we're breaking it down by looking separately at people who are employed and those, comparing them to those who are unemployed or economically inactive, and the differences are pretty stark. So the people who are not on the labour market and are working age, they are more than twice as likely to have a common mental health condition. We also asked about whether people have problem debt, and pretty much the same picture emerges. So we can see again that the proportion of people who have problem debt are more than twice as likely to have a common mental health condition compared to those who don't have problem debt. And finally, looking at the area level deprivation, we can see nearly linear increase from the least deprived areas to the most deprived areas of 10 percentage points. So again, with those things, it's well known that financial pressures are linked to mental health. Looking at those things, we can't say which way it necessarily goes. Relationships probably go both ways. More positive news to add to this, treatment access has definitely improved, but some gaps remain. Some population groups less likely to access treatment than others. So just to pull it out, nearly half of adults now with common mental health condition symptoms received mental health treatment. It was more likely to be in a form of medication than psychological therapy. But when we look again across the years, we can see that both of those forms of treatment have been going up. For medication in particular, the main increase was between 2007 2014, but the increase here is also significant. And how is it distributed between people depending on the severity of symptoms? So we can see here the people who have no or very mild symptoms, far less likely to be in receipt of treatment. That does not mean that there's over-treatment necessarily going on. This is not something that APMS can tell us. But it could be that, for example, they're responding well to treatment. But we can really see that the people with severe symptoms, more than half of them are receiving some form of treatment. However, this group, this proportion here, this 40% here, are not in receipt of treatment. So who is more likely to be in receipt of treatment? So the most significant finding that we had from this year's APMS is by age. So we can see that the proportion of people who are in receipt of some form of treatment really does start to fall for the older age groups. And it is for people only who have currently symptoms of common mental health conditions. And previously, actually, we found that the youngest age group was less likely to be in receipt, but that is no longer the case here. And here I will also tell you about the differences that we did not find. So we did not find any socioeconomic differences in access to treatment, which is great news. And we did not find any gender differences. So in previous APMS, men were less likely to be receiving treatment. This time, this is no longer the case. So there's definitely been some change there. And just to pull out one final fact from there is that 13% of people with severe symptoms had asked but not received mental health treatment in the past year. So it really kind of highlights still the issues that remain. So this is my highlights tour of APMS findings done, but there is so much more still in that data to come. So the report is available on the website. I'll give you a QR code just in a second. But we also have part 2 coming out in autumn, and that will focus on these topics here. So it will include alcohol and drug use and dependence, and the more specific disorders, bipolar, personality disorders, autism, psychosis, and eating disorders. And the last three of those are the ones that we're focusing on in part 2. And with eating disorders, we've done some really interesting methodological development work, and we're really, really excited to get that out there as soon as possible. As well, APMS data set itself, it has historically been really hard to get hold of. I'm really pleased to tell you today that there is no DAS process involved anymore. So it's going to be archived at UKDS under special user license, so you still have to apply, but it's a lot easier process. And it's expected to be in the archive by the end of this financial year, but fingers crossed it's going to be earlier. And what kind of things can you do with this data? There's just so much more compared to what I've been able to present or what we can report. You can really look in depth into specific mental health conditions. You can look how they overlap as well. So this is something that absolutely we were not able to do in this report. And to focus on specific population groups. And we've taken care to make sure that we are collecting information about people that we know is linked to mental health. So we know whether they've been to prison, whether they have been to armed forces, whether they have adverse childhood experiences of violence, of domestic violence, etc. So all of that information is there to analyse. And we at NatSen are also very excited to get into this. So if it feels like maybe something you would like to explore with us, then find me at the break, and I'll be very happy to have a chat about that as well. But before I go, here you go. So QR code for the report. And I wanted to say thank you to all of the people who have made it possible. So all of the almost 7,000 participants who sat down with our interviewers and had those really sometimes difficult interviews talking about very personal issues. All of the interviewers at NatSen and also at the University of Leicester, the research team, who at NatSen who have worked so hard over the past year to make this happen, all in the audience today. Say hello to them at the break as well. So it's Sarah Morris, Katie Rideau, Eleanor Young and Alicia Brown, the research team at Leicester who are leading on the phase 2 of the study, so Derry Berger, so Morgan and Sam Trummans, City St Joseph's University of London, Sally McManus, who absolutely lives and breathes APMS, and without whom we would not have been able to do it. And the team at NHS England, Fiona Daly, Walt Troller, and Mila Slavik, and all of the many co-authors that have helped with the various chapters, and of course the APMS steering group who have guided us all the way from the beginning to this point. So, thank you very much. And questions?
Thank you so much, Mari. So interesting. Does anyone have any questions? I do, to get us started, if that's all right.
Yeah, I do.
I don't know, well, we can tag team with this.
Yeah.
So I'm just thinking about the implications for policy and then the implications for practice as well. In terms of policy, I know this is something that we've probably all seen over the last decade. Like, we all have known that there has been an increase in prevalence, but not necessarily been able to demonstrate it in this way that we now can. And what we've seen happen is then political commentators commenting on, or even people in power like the Secretary of State saying that there is an overdiagnosis of mental ill health. I'm just wondering how we can really make the most of this data now, this one and then phase 2 as well, to show that that isn't the case, or does it show that that's not the case?
I mean, I think absolutely that's what it shows. If anything, it's the reverse that is the problem. That's what I see, where I see APMS being so valuable and having that impact, because we can't throw out like specific policy interventions that we might need to do. But this is now this gold standard set of facts to actually base this next stage on, so that it isn't based on someone's anecdotal evidence or something that they specifically have seen in their practice, but this is saying actually across England this is the picture, these are the groups that are most affected, and that should on the national level and on the local level very much guide the plans.
That's amazing, and exactly what a lot of us need who are working in policy at the moment, I think. And then practice implications for practice. Can this be broken down by geography? Is it something that then NHS and health and care commissioners can then look at in their populations and help to then plan care in their populations?
So we are breaking it down by regions, but I think that's probably a level higher than what you are thinking of, because that's the trouble with those surveys. Even though it's really big, you can't look at it on a very specific local levels.
But regional, still very
But regional
helpful.
you can, and we did find some quite big regional differences actually. I just didn't go into this here.
Are there any other questions from the audience?
Thank you. I'm Daksha Trivedi, Professor of Applied Health Research from the University of Hertfordshire. I've got 2 comments related to the presentation. Thank you for a very interesting presentation. So my first question is, I saw autism, and we're working with mental health inequalities, and we're finding an increasing problem with other neurodiverse conditions such as ADHD. Some of our work is trying to look at mental health access to people with ADHD. Again, we're working closely with Advance and charities, and yet the surveys seem to highlight autism. So do you gather data on ADHD? That's my first question. My second question is, you mentioned subgroups, so if you can give us an idea of what sort of subgroups you're looking at.
So in terms of autism, ADHD, so autism, yes, is in part 2, so I can't share any findings at this point, but ADHD results were published in the first part, so that information is out there. I just didn't focus on it at my talk.
Okay, thank you.
And sorry, can you remind me of the second question?
The second was the subgroups. What sort of subgroups? Because you mentioned specific population groups on your last slide.
Yeah, so it's everything that you would traditionally expect to have in a survey, but we, as I said, we also have things like military history and whether they've been in prison. We know what kind of household they live in, whether they're living by themselves or whether they're living with other people. We know education, we know about, we have information about the job, etc. So pretty much everything you can imagine that would be helpful to know that is collected.
Because mental health problems have been increasing in certain ethnically diverse communities.
Yes.
With very little access, so that was where I was coming from.
Oh, okay, yes. So in terms of ethnicity, that actually has been a really big focus when we've been carrying out APMS. And for the common mental health conditions, we didn't find any differences by ethnicity, but this information is there, and there are other conditions where we do find differences as well. Yeah.
Thank you.
Hello, my name is Martin Jones. Can I ask you a few questions about gambling harm, please? If I'm correct in remembering, I think the current survey suggests prevalence is 0.4%, which is up from 0.3 at the last survey, which if my fact packet maths are right, that means 300,000 or 400,000 people severely harmed by gambling, which in turn implies tens of thousands with suicidal thoughts, thousands attempting suicide, and many taking their own lives. Am I right in thinking, with that adverse trend from the last time, that the last 7 years of policy tinkering have not had much effect, with my first question? My second question is, there are other prevalence measures which are vastly different.
Yeah.
The gambling survey of Great Britain at 2.5% is contested certainly by industry, with the suspicion that there may be bias from Professor Sturgis's report. But if you look at other in-person surveys, such as Northern Ireland at 3%, I think Liverpool, Merseyside again around about 3%, I'm not so sure that the risk has actually materialised. So could you just comment on your sense of the disparity between the APMS and other stats in that area?
Thank you. Quite a specific methodological question. But very much aware there are different sources where you can get this information from, and it doesn't necessarily always agree. And this is largely driven by the methodological changes. So generally when we're looking at in a face-to-face service or APMS, but also HSC, we get a bit lower prevalences for problematic gambling, and if you look at the gambling survey of Great Britain, which is online, you get slightly higher prevalences for that. And very much the position has been that because the methodologies are so different, they probably shouldn't be compared to each other. It's possible that in a face-to-face situation we are underestimating, and some people, because it is a stigmatized behavior still, that they are not reporting it quite to the same extent. And at the moment, work is going on around looking exactly the kind of issues that Professor Sturgis did raise about the gambling survey, which hasn't been published yet, but it's something that is being looked at. So I do appreciate it's not necessarily helpful to have different estimates out there. But I guess our aim here is really to look at the people who have a potential problem, and then see are they accessing services, what kind of support they are getting, rather than necessarily try to establish that prevalence.
I think the beauty of this is, I think, should we do two questions at once and then we'll move on to the next one?
Yes.
Sure. I was just wondering if you could say more about the criteria for the group who didn't fall into a classified type of mental health disorder, and how you identified and classified that group.
So I think that's part of it, is a bit of a function of just how that specific measure works. But it means that people probably had symptoms from different conditions. So it's a combination of some depression symptoms and some anxiety symptoms, and not enough to classify them as having anxiety or as having depression. But yeah.
I'm Dan, I'm a research lead at Gamble Aware. I was just going to go back to Martin's point, just a potential theory of why the prevalence might differ, but I did notice in the, is it APMS, is that the right abbreviation? There is quite a smaller prevalence of young people measured in the survey compared to like a nationally representative outlook. So that could be one potential difference, because we know that young people are about 3 to 4 times more likely than the general population to experience harm. So if they're underrepresented in samples, then it's more likely to have an impact on the overall prevalence rates. My question was just about young people in general across a national statistic. I think a lot of people are struggling to engage with them, but is there like wider discourse on this issue and trying to get young people filling out these surveys?
Thank you, and that's a very fair point. And we did, obviously we have weighted the survey based on the age that should be dealing with the biases, but we did end up with relatively small numbers in those groups, and that might be having some of the effect here as well. It's definitely one of the areas that survey companies are looking at very, very closely indeed, and we are these days very focused on bringing in people who are less likely to take part, and you know, that could be people from ethnic minority backgrounds, etc., but definitely also that young groups are. Yeah, I agree.
Thank you so much, Murray. I think this has been absolutely fascinating. I'm sure there are many more questions as well. So there's the opportunity at the break. Also, if there's anyone online who's asked a question, then we'll probably be able to answer it afterwards, won't we? We'll be able to follow up with people. But I think, yeah, this shows just how important this data is, just how many implications it does have for practice as well. And I work at Rethink Mental Illness, where we work with people severely affected, so really looking forward to the data coming out later this year. And then hopefully we can not leave an 11-year gap next time, because I think it's just so important, isn't it? So
Absolutely, absolutely. Thank you so much.
Thank you so much. So I'd now like to introduce our next keynote speaker, Graham Morgan, who is speaker, activist, writer and engagement and participation officer at the Mental Welfare Commission for Scotland, who will be posing the question, what can we do for you, for and with you?
Hello, everyone. Just want to mention I'm speaking in a personal capacity today, not as part of the Mental Welfare Commission. And because I'm nervous, I'm reading my speech, so I'll hopefully put some emotion into it. So starting off, hello. It's lovely to be here, to be able to give my opinions and experiences and pass on those of the many people I meet all the time is a great privilege. The title of my talk is What Do We Really Want From You?, which is maybe a bit tongue-in-cheek, because of course it is pretty much impossible to define what people like me want from you. A couple of years ago in one of my workplaces, we as people with lived experience drew up a list of priorities which we thought people should be addressing. It was a huge list, but boiled down, the priorities that carried most weight were getting support on discharge from hospital, then the relationships people like me have with the professionals that are there to help us, having activities to do both in the community and hospital, and also the support our family and friends offer us. I was surprised that we chose discharge from hospital as a key priority, but a few weeks ago I was in a discussion about it and ended up in much broader territory. For me, when I've been discharged from hospital, I tend to be delighted. I will have been pleading to be let out as soon as possible, and when I get home I will revel in the freedom, the ability to go to bed whenever I want, to eat and drink what I want, and to do what I want, and ideally to get back to work as soon as I possibly can. For me, leaving hospital means no one is going to watch me have a shower or go to the toilet, and that I'll be able to turn the light off in my room when I want to sleep. To be free of that, it always feels like the sweetest blessing. It's only in later years that I've realized I was still very ill when I was back at work, and only much, much later that I've wondered about shame and the need to prove myself, and nowadays the need to be kind to myself and my family and to find space to regain some peace. I meet so many people who say discharge is like being thrown in a heap in the gutter. 1 minute your meals are made for you, you're relatively safe, you have people around you, you are, if you're lucky, getting peace from an awful situation to begin to see life afresh, and then you aren't. Instead, back to a cold house, possibly with the mouldy remains of food in the fridge, and an overworked nurse who might come by in the first week to check you're okay. And that really is so often not okay. For some of us, discharge from hospital, or for that matter, discharge from any service, means so much more than this and is so much worse. For some of us, home, in the true sense of the word, is a distant memory. We don't have a place of our own anymore. Friends and family may be a distant thing too. We can lose those connections. We may no longer have custody of our children. Our friends may say we put them under so much trauma with our determined to die and harm ourselves that they no longer have the strength to cope with us. Or with a new diagnosis in a world of prejudice, people see it as the modern equivalent of evil. Certainly nowadays, I find I'm nervous about those times when I disclose I have a diagnosis of paranoid schizophrenia and that I don't willingly take treatment. We may have only just survived the last few months of crisis, and though night is day, and although we struggle to even make a cup of tea or leave the house, we're meant to be searching for the holy grail of a workplace, which we're told is good for us, even if that is the very place that caused our fracturing to start with. Discharge for some of us means we enter a new world where the hope we had falls away, the services we were promised slip away from us with exhortations to be responsible or remember the skills we've been taught. We lose community, belonging, connection, wealth, and on top of that, we're shattered from the whole experience we've gone through, where our very identity and sense of place in the world is suspect. So yes, I would make this a subject for policymakers, not necessarily to check whether we're given support or if we continue to attend appointments or take our medication or to see how long it is before we relapse, as so many of us do, but to understand what our world is like and what would make a difference. I would look at identity, connection, friendships, hope or loss of hope. I would look at the web of those around us, the culture we were once part of and what we might now be a part of. I would look at loneliness and poverty. I would measure the ache in my heart that I've seen my son twice in the last 16 years and still don't know whether it was my illness or the toxic relation I used to be in, which means he doesn't want to meet me. And every day I realize that if I passed him in the street, I would probably no longer recognize him. I would measure the impact of old groupings turning away from you because you no longer fit in. You do not have the money, the confidence, the stability to be a part of them anymore. Or the realization that though you used to be the oldest child and that once had a status, that now you're the one to be protected and observed and shielded from any difficult situations. I would measure what it means when family and friends say, why do you mix with them? When your new community consists of other people with similar experience of hospital or illness to you. I would measure in a new way. I would measure those things that really matter to us in ways that bring people like me to life in academic and policy papers. The next priority people chose was the relationships we have with those that try to care for us. Sadly, some of us, far from finding comfort from our helpers, feel we are viewed as the enemy. We ask too much, question too much, and just generally do not behave or act in the way we're expected to, especially if we have a diagnosis that is socially unacceptable. And so we can be faced by what seem like punitive or patronizing actions when we encounter those paid to care for us. When services are stretched, sometimes it becomes easier to blame us because we stubbornly do not get well in our allotted time and do not recover as we should and do not act gratefully for the sparse services we receive. Speaking very personally, there's a lot of talk about boundaries and the need to protect us and our workers from unhealthy relationships. But for me, the most unhealthy relationships I've ever been have been when I'm expected to talk about the intensely personal or seek help when utterly vulnerable, and I know the person I'm speaking to has no knowledge of me as a real person at all. To me, kindness, compassion, and humanity are everything. In fact, I would go further. For years, I've said that if we're to be sectioned, it needs to be done with love. I'm so glad that the Promise in Scotland was founded on the research from thousands of young people in care who said what they needed most in their lives from professionals was love. I think that applies to all of us. I would research things like this too and embed them into policy. I would find out what difference genuine kindness and the ability to remain human in a corporate world makes to people like me, and make sure that every care professional has to ask their clients as part of their appraisal how they make the people they care for feel. Do we feel respected and valued? Do we feel we still keep our dignity when we enter the world of mental illness? And if not, why not? I would measure the difference of the CPN I saw for 3 years, who met with my partner and her children and got them all laughing and said she really looked forward to coming to see us, and who I learnt to trust and speak with, to someone who doesn't even know my family's names, doesn't know what I want in my life, and wouldn't ask me to say if I've been having any symptoms recently. I would measure the relief I felt when I was surrounded by nurses amid blaring alarms after I'd cut myself on the ward, and somehow the nurse managed to get me to pass my blade across. I would measure the tenderness with which he treated my wound and the cold, soothing saline solution and the calmness and lack of anger. In contrast to the time I was rebuked when I tried to hang myself and was told how difficult I was making it for the nurses to nurse me. I would also measure the humiliation of being stared at directly when I was on the toilet compared to being observed discreetly. The nurse who would sit on my bed and manage to get me to talk when I didn't think I could. My psychologist who I've waited 10 years to see and who makes me feel safe and yet gets me to work on my life in ways I never have before. I would also measure what it means when we meet the other workers, those in the third sector who, unlike statutory sector workers, share their phone numbers, email addresses, who give us lifts in their cars, who reply to our emails on the evenings and the weekends, who create a web of security for our community, and although they're paid, remain resolutely human, resolutely part of our community, happy to be flawed, happy to talk about their lives, not as a therapeutic tool, but because they live alongside us and value us as they value anyone else. And I would measure how that makes us feel compared to the impersonal voice of an answer machine and the likelihood that our cries for help initiate complicated processes to explain why we cannot get the help we crave. Activity sounds like a simple thing, maybe almost a petty thing, perhaps not too important in the context of health, but I would disagree. I constantly see people who are isolated and alone, people who live in a grey mist with no one to connect with, a world where there are no kisses, no cuddles, where laughter is only bitter and cynical. It's a desperately sad world, and to my mind, if the asylums of 40 years ago were one scandal, they've been replaced by the scandal of alienation and loneliness and the utter misery so many people I know now experience. The comment of a long-term patient over 40 years ago, when I was first admitted to an asylum, that you're scum here, scum, still resonates. Many of us still feel like scum. I would search what it does to us when we feel like this. I would measure what it feels like to live in a society where you feel worthless and where people in politics and elsewhere can now only talk of the burden we are to society. In contrast, I'd measure the value of places like Jean's Bothy, the wellbeing hub I go to, where when I walk through the door, I'm already smiling because I know I'm welcome and that I do not have to pretend to be anything other than myself. I would try to distill the essence of when we're all giggling in the photography group on a Saturday, which one of our members runs, and what it feels like when the Shadow Minister for Health attends our exhibition in Mental Health Week. Maybe we need to admit that some of us feel and need a sense of community where we can just be with each other and celebrate each other and support each other. And maybe it's time to recognize the effect when a community like this of respect and joy and value is ripped apart when funding stops. Activity is how we participate in our society. Many people do this through employment, but for many of us with a mental illness, employment is not a possibility. That with more support and less discrimination, some of us may get there. But there are different, just as valuable ways of contributing. Maybe taking a walk with another person. It might be being creative or cooking someone a meal or looking after our children. These are just some of the small ways we play a part in our community. I would measure the difference to our well-being when we feel we've made a difference, even if that's just a tiny difference. I would look at the things that would encourage us to do stuff and the things that make this so much harder for some of us to do. I've been treated for 40 years and for the last 15 years against my will. And in that time, I've avoided hospital. It may well be my mental health team and my fortnightly injections that keep me out of hospital. But for me, it's my family that makes the biggest difference. I lived in a toxic relationship for some years. I'm finding myself with a partner who I laugh with, who I kiss and hug and go on mini adventures with all the time, a heart partner who I don't argue with and who I'm not frightened of, with her daughter who hugs me every day and says she loves me when I drop her at school, and her brother who still says woof woof to me when I say I love him, because that's our strange way of communicating. Today, when I was writing this talk, I went to Jean's Bothy, where I had a wonderful lunch. We sat around a table and nattered, and it cost us £1 each. I left early and ate little because I was due to walk at Ardmore with Wendy and Dash the dog. We walked in a refreshing breeze and bright sunshine, passing herons in the shallows and terns diving into the sea. We sat on a grassy knoll above a beach amidst the smell of roses and gorse, and it felt wonderful. I had had a very anxious morning. I don't quite know why, partly because I'm going through CBT for psychosis, which is wonderful but shattering. But here we nattered and talked about getting the children from school later. Dash the dog wriggled on his back and walked in the sea. I smiled and smiled, so did Wendy. She's not working just now. The charity she managed lost its funding, and she's taken the opportunity to stop work for a while. We rely on my part-time wages, but we live pretty frugally, and so can manage for some months before Wendy will have to return to work. It suits us. We have a good life. Most people with an illness like mine have nothing like this. I would measure my pleasure at seeing a tern diving into the sea after I was exhausted from seeing my psychologist. I would measure what it means to me that wee Louie says she loves me despite my silence. But sometimes we need to remember the people who live around us. Sometimes my words dry up. Sometimes I hate myself and can't see anything to be pleased about. Sometimes I yearn to see my life in colour again, to have energy and spontaneity, and this can affect those who are part of our lives, now called our carers, even if they don't define themselves in that way. We need to look out for our friends and family, remember the pressure they can be under. I need to remember that when I'm in hospital, my family still wait for the call that will say I've finally killed myself, the pain this causes, and our children. Not so long ago, wee Louie spent an entire lesson at school being taught about the crimes that people with paranoid schizophrenia have committed. It hurt her. She cannot imagine me committing a crime, and yet her teachers were telling her the opposite. I would look at the complex web we live as families and the sometimes unexpressed and unnoticed needs our families have. Finally, I would ask us to look again at the past. I visited a hospital recently which is still on the same site as an old asylum. There is a gym room there that a patient goes to every morning at dawn. There he sits with a coffee and watches the deer and the badgers and the rabbits through the window as the day lightens. I would revisit places like that. Nature may not cure mental illness, but it does wonders for our souls. I would revisit concepts such as sanctuary for those who need it. I spoke to a friend the other day who talked about being given simple tasks when she was a patient and how still being able to do small things to contribute to the ward created a sense of belonging and ownership and value. And lastly, I would question pretty much everything, especially in the world of severe mental illness. What is realistic and what are we trying to achieve? Sometimes I worry we're doing the equivalent of insisting people with no legs get up and walk again. For some of us, mental illness lasts for decades. I would be so much happier if policymakers could recognise this and accept it. I would look at the dry, controlling urge to get us away from the system, the horror professionals feel when they say we become dependent on services, and I would question it all. We all depend on each other, and for some of us, you provide something we've never had. So why would we not become close and learn to trust you? And how do you think we feel when noticing this trust, you rip it away from us? Instead, I would ask what makes us feel safe and what makes us feel loved and respected and worthwhile. We live by mantras of autonomy and choice and will and preference and responsibility, such cold concepts. Only oligarchs and dictators have complete autonomy, and I do not want to be like one of them. I make my decisions with those I love and those I encounter, and they are a melding of all our wishes and needs. I do not seek the best deal for me. I do not seek only my own interest. Why would I? What a barren world that is. Sometimes I look after, and sometimes I gasp with the relief of being looked after. When I've been a patient, I've not had the slightest interest in care plans or risk assessments or the administration of the ward I'm on, but I've been acutely aware of the way we talk to each other as fellow patients and how the nurses behave with this. The atmosphere, that's it. How do you measure an atmosphere in a ward or a workplace or a wellbeing hub or a mental health team? because for me that's what I notice when I edge anxiously through the door, looking for acceptance and welcome. In conclusion, I would like to finish with a small plea. Of course, we need research to show trends in illness, to enhance treatment, to look at recovery or compulsory treatment. And we need the research that will allow a huge, complicated system to work efficiently and humanely. That's a given. Such things will drive policy and knowledge of the different communities we're all part of. But what I'd like is the knowledge that brings research to life. The reasons we provide support and what we want to help people like me and my peers ultimately achieve are numerous and need stats and figures and evidence to help people work out how to get there. But underneath there is so much we could learn which could make such a difference. I'll mention a very few small number of things that I think could help all of us, just a few among a multitude of possibilities. We need to know how sectioning happens and its trends and the communities most affected it. But maybe it would also be good to know why so many of us, when everyone knows we need help, withdraw entirely from services. Why do we do it? Yes to illness, yes to fear of services, but we also avoid the services we trust completely. Why is it when we suffer, so many of us avoid our friends and relatives? Why do we do the opposite of what people think we should do? And when we talk about participation and involvement, and when people like me say nothing about us without us, why do so many of us, when put in front of multidisciplinary team meetings, clam up, fidget, and refuse to participate at all? In fact, say we loathe those meetings. And what is it people want for us? Some of us may seem to function fine by most measures, but what is life like when it's bland and monotonous and grey? Is a twilight just about really not okay life what we should really aim for? I hope not. I would also like future research to have a human rights framework around it and a trauma-informed one. Simple things like putting people with terrible history of abuse in dormitories and getting male nurses to shine bright lights on them every hour of the night might become a bit of the past if we were just that little bit more aware. And now, having spoken for a very long time, I'll thank you for listening. Thank you.
Thank you so much, Graham. That was incredibly powerful, moving. I think it made every single one of us think about how we should be measuring research, policy, practice, care. You know, we talk all the time about safety, recovery, compassion, dignity, but that just entirely brought everything to life. And yeah, incredibly moving. Thank you. Really, really appreciate it. If anyone has any questions, then Graham is happy to take a few.
Hey Graham, Chris White from the Mental Health Foundation. I was reflecting, Graham, we've known each other for close to 25 years. And we were both in very, very different places 25 years ago. I come up to Inverness to speak at a hug group. Really, really early days for recovery for me, and still in touch with services. And then last night we went out for dinner, which was very nice. But one of the kind of things, thinking about our conversation last night and what you were saying today, is, you know, the reason that I'm still here 25 years later is because somehow in that period I found hope. But I'm not sure that services helped me find that hope. How do we instill that? You know, we talk about dignity and recovery and value and such, but actually, how do we instill that hope? And is hope important to us in our recovery?
I think it's hugely important. I also think being given false hope is a huge mistake sometimes too. I've no idea how we give it, but my current and long-time obsession has been the relationship we have with the people who provide care for us. And I would like to see some sort of transformation in that, a real challenge to professionals to provide a real sense of humanity and empathy and kindness. And when that happens, it's much easier to see hope. Like you, I think I got hope from my current family and the friends and people around me, and also from my work. That has been wonderful. But I have very rarely found that from nurses, especially nowadays when they are under so much pressure. Some of the professionals I see are absolutely wonderful, but they don't have the time or the knowledge of us to provide that. That's that key ingredient that's so important for our lives.
There's one over there, and then we'll do the mentor.
Hello, my name's Lauren. I'm a teacher of A-levels, and I sort of have a safeguarding and pastoral role at the college for about 3,000 young people. Thank you so much for your talk. I think it will stay with me for a really long time and really influence what I'm doing. And I just wondered if it's a little bit self-indulgent of me, really, but if there's one thing I can sort of take back, or any of us working with young people can take back in terms of one message of how we can help. Have you got any thoughts on that?
Oh, I don't know. I wish I did. My partner's child, Louis, she's for a long time last year, she had panic attacks going into school when she got exposed to drama and had to perform in front of people. And we would take her off of school, and that was dealt with really, really well by learning support who just made sure that she didn't go to drama anymore. That solved the situation really easily. And sometimes I think it's just common sense. But also, many, many years ago, with a group called Hug in the Highlands, we took dramas and plays around schools with young people, sometimes primary schools, but mainly high schools and secondary schools. And that was all about getting conversations going. I thought it was really good to start with. We sometimes had people, like 97% of people, saying that they felt differently and had learned about mental health hearing from us. And we worked with about 9,000 young people. Nowadays, I'm less sure what is the conversation we need to have, because learning to go and seek help if you're a young child is no use if that help is not there. And if the teachers don't know what to provide, and if the mental health services don't exist to provide it. So I'm giving you a really negative answer of saying I have no idea. But I wish that there were things for young people, because I think they're having the most horrendous time. And certainly looking at the children who are 14, who were 9 when COVID started, and how terrified they've been since then at the state of the world, I can certainly see why young people are so anxious, because it seems a really difficult world to exist in. So I'll give them some kindness. That's all.
I think that is the heart of everything you've said there. It is kindness, isn't it? So thank you.
Thank you.
Thank you so much, Graham. So we have another Menti, which I think what we'll do is people can answer this question around really kind of thinking about the first few presentations this morning, what values and or experiences should shape mental health research. Do that in the background, and I will now introduce our next speakers. I think we've got Andy, haven't we, at the back there? So we've got Andy Bell, who's the Chief Exec of the Centre for Mental Research, Centre for Mental Health, who will be talking about addressing inequalities in mental health, followed by Professor Stephanie Hatch, who's a Professor of Sociology and Epidemiology and Vice Dean for Culture, Equality, Diversity and Inclusion at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, also talking about accelerating equity in mental health. Thank you.
Thanks very much. I didn't realise when I agreed to do this I'd be following Graham. So that was a mistake. Thank you, Graham. That was extraordinary and beautiful and powerful. I really appreciate it. Am I going to completely ruin this by pressing a button here? Is it going to make something really terrible happening? Oh, yeah. Oh, there we go. Now I feel a great sense of relief. I can see our logo. That means it's our presentation. Phew. So thank you for the chance to be here today. My name's Andy. I work at Centre for Mental Health, and you get a double bonus today because my colleague Kadra is going to be speaking this afternoon on children and young people's mental health. Maybe some cute clues there for the really, really important question we heard a little while ago. If you know about Centre for Mental Health and you follow us already, well done. If you don't, please have a look at our work. We are a small but national charity dedicated to tackling inequalities in mental health, and I've got 10 minutes to tell you all about tackling inequalities in mental health. Well, that's not going to happen, but I'm going to cover quite a bit of territory quite quickly, and then hopefully that will create some conversations to come. It's really important we understand what we mean by mental health inequalities, because that covers a very wide range of things. But here's 3 really key areas. I'm sure if we thought about it, we could come up with another 12. But the first is that we know that inequalities in society, all the inequities that we see in other areas of life, are also mental health inequalities. So the things that drive social and economic inequality also drive mental health inequality. It's not separate, it's not different, it's all part and parcel of the same thing. The second is that we know, particularly for groups of people with the poorest mental health and the greatest risks and the greatest inequalities in society, face the poorest access to mental health services, often the worst experiences of them, and guess what, the poorest outcomes as well. So there's a double layering then. And then we also know that people living with mental health difficulties, particularly those with long-term mental health difficulties, face experiences of discrimination and disempowerment. You've heard about some of those already, on a daily, recurring, endlessly reoccurring basis. So what I'm going to do is talk to you a bit about that, and then a bit about some of the things that we think could make a difference. I don't know how I'm going to do that in what is probably now 8 minutes. Here's our lovely spectrum of mental health. I'm sure you've seen this before. 2 things I want you to take from this. First of all, mental health is an issue for 100% of the population, because we all have mental health. I know it's an incredibly trite thing to say, but we don't all have good mental health. And what the survey has shown us in adults, and the surveys of children show us, is that if around about 1 in 4 of us are in that bit which says unwell right now, today, but we tend to forget that there's a whole bunch of other people who are struggling with their mental health, who may not have a diagnosable illness, but they have the risk factors. It's really important, if we're going to take a public health approach to mental health, which I hope we can and will, that we think about the whole of the population and the things we can do for everyone, but we also remember that prevention and support to have a good life matters just as much if you're living with mental illness now as it does if you're not. So again, taking a public health approach to this, we know that our mental health is determined by our lives, our experiences, the things that are happening to us, the environments we're in. So here's a list of things that are good. These are protective factors, things that no matter what your mental health is today, can help to improve and enhance your mental health and well-being and give you a better chance of having good mental health. So these are things we need to boost. Rather than only focusing on the absence of mental health, let's focus on the things that can create good mental health as well. But we do need to be aware of the risk factors. Again, this is not an exhaustive list, but these are some things that the more of them you've got, the longer they last for, and the more severe they are, the greater your chances are of having poor mental health during your life. What we also know is that a number of groups of people experience greater risks to their mental health and therefore higher levels of mental ill health. The thing I want you to take from this is that these groups of people, first of all, there are many of them, and many of us will belong to more than one of these groups. It's not inevitable, it's not inherent. Being a member of a group of people is not a risk factor. Being from a minoritized community, being gay, being trans, being neurodiverse, does not mean you are more likely to have a mental health problem by itself. It's the protective factors that are taken away from you by society and the risks that society creates that makes that risk greater. It's not inherent, it's not about you, it's not your personal character, your weakness, your grit, or all this other nonsense we hear. It's about social processes. We all love a fancy map, right? Here are 4 fancy maps, wow. 4 for the price of 1 PowerPoint slide. What this tells you is that 2 of the maps show levels of poverty and deprivation. 2 of them show levels of mental ill health. This is based on previous surveys, but it won't be much different. The only thing I want you to notice is that the maps look identical. It's a simple fact that particularly poverty and economic deprivation are massive drivers of mental ill health for both adults and for children. But here's the rub. If you're living with a mental illness or a mental health difficulty, you experience numerous inequalities in your everyday life. Again, we've heard about many of those already, But I think one of the most stark facts we've learned over the last year or so is that one in two of people living with a severe mental illness in England today are also in food poverty. And that's quite a severe level of deprivation. That means you can't afford to feed yourself or your family. That's a half. That's not like a few. This is vastly in excess of the rates for the general population. And we wonder why people with mental illness experience poorer physical health and have a life expectancy that is cut dramatically short. We need to understand the social and the economic drivers of these inequalities. And again, look beyond trying to find the solutions about the individual somehow doing something better, eating better, smoking less, all the other things. So again, we need to understand how these things really kind of cause multiple difficulties for people. I think it's time to speak a bit more positively, so I'm going to share with you some ideas, and I'm hoping I'm not using too much of my time, for what a system designed for equality could look like. The first, here's another trite phrase, mental health is made in communities. So it's communities we need to invest in to create better chances of good mental health for the people that live in them. And communities are very varied. They can be our family, our neighbourhood, our school, our workplace, the people we hang out with, the people we identify, our faith groups, or online communities even. And what we know is that they often offset some of the harm that can be caused by wider social and economic inequalities. But we also know that community organisations are often living on threadbare bits of funding from here or there. There is still a class system, as somebody described it to me a few years ago, in the charity sector. Philanthropy largely goes to big, wealthy organisations. And we need to think about how we are really creating an equitable system and ensure that community organisations really get the right support to help create mental health for the people that they represent, that they are. We also need to change mental health services. We need more money in mental health services, we know that. We've seen that we need more mental health services, but we also need them to change. We need very different mental health services. And here are some of the different ways in which those services need to change and develop over the next few years. I think one concept which is really important that could underlie all mental health support is that notion of citizenship, of being an equal citizen, of having an equal life, of being treated with equal regard, being listened to as an equal, and having the right support in the right place, and yes, at the right time, and not being told you have to wait and wait and wait for mental health support. Many examples are now out there of services that do work in these ways or begin to show these ways. The early support hubs for young people, for example, that are now providing really holistic approaches to mental health on the high street for young people without an appointment, without a referral, without all that nonsense, just providing people with help and support there and then. Services that help people with their welfare rights so that they're not being discriminated against by systems which try to take people's benefits away, which cause people to lose their homes when they go into hospital. How absurd is that people lose their homes when they go into hospital for their mental health? That we have evidence-based employment support using the individual placement and support model. There is no greater rights-based approach than allowing someone the right to work when they want to work, when that's right for them. And crucially, the patient and carer race equality framework, our best ever chance in the NHS of tackling the deeply entrenched racial inequalities, the discrimination, the institutional racism that still exists in our mental health system. We can also think about how councils and local areas can be more mentally healthy. Here's a lovely fancy diagram that gives you some examples of how taking a systemic approach to mental health, you can begin to really look at all the ways in which you can create equality across a whole range of different dimensions. I'm hoping these slides will be available to you afterwards. Everything here is on our website. And of course, wouldn't it be helpful if national policy worked in the right direction too? Wouldn't it be good if we had a national mental health plan, like a good one? Wouldn't it be good if we had mental health in all policies, so no matter what government was thinking about, whether it was policies around schooling, whether it was policies around benefits, whether it was policies around prisons and the criminal justice system, that they embedded mental health in that thinking from the get-go. And we think it would be rather wonderful also to have a mental health commissioner, like the Children's Commissioner, who really stood up for mental health across the whole of government. I think that's probably enough from me, so I shall pass on to Stephanie.
Great, thank you. Thank you, Andy, for setting the context so clearly. So I'm Stephanie Hatch. Let's see if I can get to me. There we go. I'm at King's College London, where I lead the Health Inequalities Research Group and do a lot of work on identifying inequalities, looking at inequities, both in mental health, but also in health services. But what I want to talk to you about today is taking a step back. I want us to first start with how we build equity into our research cultures and our ways of working. So I want us to hold the mirror up to ourselves. So wherever you are, what sector you are involved in, I want us to start with this question: what if we chose to do things differently? So we get up here, and I've been at this a really long time. And if we don't want to continue to talk about inequities and these inequalities that we've identified, I think we first need to think differently and do things differently. And so that, for me, starts with working right across the system. So Andy talked about the systems approach, and I think this is really inherent in this, is us thinking about more inclusive practice. So more inclusive partnership, really thinking more critically about how we conduct the work that we do and how we may, as researchers and as educators and as those providing services, how are we contributing to generating and perpetuating inequities? So today I'm going to talk about research culture, and I want to give you a sense of what that means for me. So for my group, we have an ethos which is focused around three things: equity, reciprocity, and sustainability. So the way in which we conduct ourselves, thinking about not just what we're taking away, because the participants for APMS we haven't really talked about. They have given their narratives, their information, valuable information that we all need to try and make things better, to understand problems. But what are we giving back? So in all of the research that you're doing, really thinking about that, thinking about these co-developed guiding principles, taking the time to be more reflective about what we're doing. And, I see a lot of early career researchers in this room. You are our future, and so it's really about what are we doing to enable you to become the inclusive leaders that we need in this area. And two key underpinning principles, just in mental health research, I think we need to agree on and put into practice more readily. One is around cultural humility, and that is that self-reflection, not just always, pointing the finger at other people about their biases, but really being more upfront about our own biases in the work. And also cultural safety. So this I really like. So Ramsden took a social justice approach. Really, it's trying to instill this idea of cultural safety, in which we have these things that we've been talking about this morning, the shared respect, really looking at the meaning, the knowledge, and how we're working together with dignity, and truly, truly listening to each other. I also want to address the elephant in the room. So in a lot of this, we've talked about, what impacts mental health. What we haven't talked about is how within and right across sectors, I'm not just talking about academia, right? And in a lot of workplaces, and I hear a lot of this, we see, those conducting mental health research themselves being exposed to bullying and harassment. We don't do enough to identify it in the way that we work. And I think it, as was pointed out, it is one of the most negative influences on research integrity. And there's this really, persistent problem that is also contributing to the mental health problems of those who are actually conducting mental health research. And it's something that needs to be addressed, and here's why. Because we know from our research, when we're looking again outward in our health inequalities research, we know that this is an exposure to adversity that is unnecessary, and it does have a life course narrative. We know that it's shaped by multiple statuses and identities, and within social context. It limits our life chances. So if we think about people's ability to achieve in the occupations that they're setting out to achieve in. And it's also interrelated with discrimination. We see that from our research. And I'm not just talking about experiencing bullying and harassment. we've shown in our research that even witnessing it and also anticipating it, so thinking that you're not going to be treated the same as, those who you're working alongside of. So let's, again, we understand these problems. We see the robust associations in terms of how these things impact mental health, right? We see how it impacts help seeking, but we're not addressing this in our own sector within research. And so I think that there have been these institutional level initiatives, but there are a lot of questions still remain. And one that I want to raise is, what is the role of funders in this? What is the role of funders when they are not monitoring these behaviors and avoiding the unintended consequences? So continuing to support those who are contributing to the problem. And what is the role of funders in terms of helping us to, navigate where you've got very complex situations, whether that's between sectors, so between, for example, the third sector and academia, what is their roles? I think they do have a role. And now I want to turn to how we actually do our work. So we've heard about the value of centering lived experience and expertise, but we've got to make space for those voices. It has to be a constant effort to bring those voices and also to identify who's being kept silent. I also want to promote this idea of creating leadership opportunities at all levels. So I stand before you and I greatly take on the role of leader, but in my group, I try to find leadership right, whether you're an academic, not an academic, whatever level you're at. It's a really important thing. And really ensuring that we think about the mental health and well-being of our participants and our researchers, and really thinking about how this needs to be adequately funded. So Andy talked about sort of equity and who conducts research. I make myself a little bit unpopular with other academics because I don't think that the expertise only lies in academia. I think that there is a tremendous expertise, but first and foremost, we have a more fundamental problem, and that is who is actually conducting the work. So we still have these underrepresented groups and who's actually conducting the mental health research, whether that be by gender, by disability, and certainly by ethnicity. The list goes on. So we need to do more of embedding the types of principles that we have more broadly in institutions to directly think about what impact does it have and what questions get asked when we don't have the diversity of people conducting this work. So we know that we talked about, academic outputs and, I want to see greater parity between academic institutions and non-academic institutions. So this is about identifying and recognizing all forms of power, sharing resources, making sure things are transparent, and as I've said, properly acknowledging the expertise outside of academia. And one of the ways that we can do, a very simple way, is to make sure that our ethics, our methods, our processes are more transparent. So this is an example of what my group and my colleagues have done in our ESRC Center for Society and Mental Health, where we've have this online, freely available 10-week course anyone can participate in. You can visit the website. For us, when we're working with communities, when we have community and peer researchers, everyone gets an opportunity to have the same level of basic knowledge so that when we're sitting at the table, people don't feel like they're not being included because we're using all this jargon, we're using all these technical terms. And then I want to bring us on to equity and data availability, quality, and access. And I want to say, first and foremost, I understand how difficult it has been to make sure that we have an inclusive sample. But I want us to keep this question in mind. Do we have the data necessary to identify and understand the mental health inequities for groups with the greatest levels of need? I say we don't. The question was asked earlier about different subgroups, and I'm going to use this platform today to talk about the importance of, for example, ethnicity boosts. we do not have the data that will allow us to disaggregate. We are still in a situation with population mental health data where we have to aggregate these very heterogeneous groups of people. And it's not good enough. We're now at almost 20 years since we've been able to disaggregate this information. So yes, there are some clues in terms of ethnic differences in APMS, but we were not able to go as far. And part of the reasons for that is not about who doesn't want to participate, or, the onus should be on us as mental health researchers to increase the trust, to work with communities, because as we found out during COVID, they have very good reason not to trust us. So the onus is on us. So I've put this here just to give some steps about how, we might start to think, and also what implications this have, because we're talking about policies that are being created without that fine-grained information. So it doesn't help us with our lack of knowledge in these areas that I've listed here, which Andy touched on, before, so I won't go through. But, especially when we get down to the fact of not wanting to just hold or think about someone with a single identity. We're beyond that. So we really do need the data that allows us to do that. So these are some basic questions that I want everyone to ask of the work that they're doing. At the moment at which you're starting, where you're thinking about these questions, I've heard, especially quantitative researchers say to me, well, I don't know if I can embed any sort of thinking around equity or any sort of EDI principles. I'm like, you gotta think about it when you're thinking about the questions that you're asking, understanding, how these mechanisms work, and how do we actually fill the knowledge gap. So I'm especially putting that out to the ECRs, the early career researchers in the room. And we want to see more equity in funding practices. I mean, this is fundamental. We need something that structures that allow for this work to be truly co-produced, for there to be participatory action, for this to be translational. So when we think about how this moves into policy and practice, this should be done together across sectors, jointly at work, but it's got to be properly resourced. So I'm going to put this plea out to, policymakers making these decisions, as well as to funders. We've got to remove barriers like caps on, the amount of funds that can be allocated to community partners and things like that. I know I'm running short on time, so I'm going to finally come to this last bit about policy. As was mentioned, our best hope right now, particularly for these persistent racial and ethnic inequities in mental health and health services, is the Patient and Care Race Equity Framework. It is now mandatory across mental health trusts in England, and it is a brilliant piece of work. And to watch the pilot sites and the early adopter sites and what they've been able to do, and to see this being rolled out, and very mindful of context and of these inclusive partnerships, is just brilliant. But we need people to back this, because people are afraid of having this kind of movement. But this is the kind of systemic action that we need to see. And then finally, I am going to plug some of the things that are going on in my own group. So we've got the work that we're doing around looking at, working with communities and trying to understand their thriving, looking at the more, shifting the narrative, from a negative sort of deficit approach to thinking more about how, communities care for each other. Also, the Health and Social Equity Collective, which you're all welcome to join. We, have a number of members. We came together across sectors to really think about how we might do things differently. And then we heard a lot today about those providing care. So we're really fortunate the Wellcome has funded our Discovery Award to take collective action specifically for race equity and health and social care, both looking at the paid workforce that we've talked about a lot today, and not just what the care they're providing, but their own mental health needs, which are great, but also informal unpaid carers, which we haven't yet heard about today, who are often invisible in a lot of these conversations. And then finally, our UKRI-funded population mental health consortium, where we're starting to see a sort of shift and change around the way that this work is done through, more attention to equity in partnerships, data, and policy. For us, I'm just going to end here. We've got I put up some collective next steps that I'd like everyone to just commit to and really think about. Really start to question what evidence is valued, how we can make data more accessible and transparent, how we distribute power in the work that we're doing, and what voices are heard in the research that we're conducting. So I would like everyone to just please commit to more transparent, inclusive, equitable expectations of policies and practices, and think about having real accountability embedded in the system. Thank you.
We might just do it on here. That's all right. Thank you so much, everyone. Such interesting, but also very practical thoughts on what everyone can do here. We've got about 5 minutes for some questions, and I wonder if there's any online, because we haven't been to any online yet. Does anyone know if there are any questions online?
We can take a question here first, and then the next one will be online.
Has anyone got any questions in the room?
Hiya, thank you so much for your talk. I'm a master's student at UCL studying global health and development. And my question is, there's been a lot of papers recently on decolonizing global mental health. And I wanted to ask, what are your thoughts and what does that mean to you?
I'm happy to say that I'm happy to see the movement, especially in global mental health. I think it's long overdue. I think it means addressing some of the things that I listed there. So if I just go back to that slide, that's it, right? And it's the acknowledgement, as I said earlier about cultural humility, that those who have participated in generating and perpetuating the problem, really acknowledging that and having some humility around it. And also acknowledging that there is, expertise that has been undervalued, has been missing from this conversation, that has systemically been erased, that needs to be brought to the fore. So that's what it means for me.
Yeah, go for it, Andy.
Yeah, thank you. Really great question. And I guess it's important that we see it global, but also local. A lot of the things we think we know are based on research which was carried out in principles which I hope we would reject now. So I think it's really important we ask those questions. How do we know the things we think we know? On what basis was that knowledge produced? And just be a little bit more questioning and a little bit more open to finding different ways of building knowledge. It starts with us.
Thank you. Are there any questions online? No? Okay, I've got one more question, which is a bit of a sense as to where we are right now. I think we definitely got that from your presentation, Stephanie. Just wondering about the kind of wider political context and with the 10-year health plan published last week. Andy, where do you think we are right now in addressing inequity in mental health provision?
Gosh. Well, I'd be interested in what colleagues here think, actually. That'd be an interesting test, wouldn't it? I kind of feel like when I looked at the 10-year plan, and I looked at it in some hope and some trepidation, it didn't give me a lot of hope. If this is a 10-year plan for the next decade, that's until, what, 2035? If that's as ambitious as we are, then really we need to try again and have another go. It's not ambitious. There's very little in there that would give me hope for equity, even basic things. Where are the access and waiting time standards for mental health services? Why are mental health waits second class? Where is the focus on improving equity across our systems? Why on earth was the patient and carer race equality framework, one of the biggest achievements of the last 10 years, not mentioned in that plan? So I think we've got a lot of rebuilding to do. We've got to ask some really difficult questions. But the patient and carer race equality framework is still happening. People are doing the work. Whenever I go to talk and hear about what's happening in local areas, then I get hope. So things are happening, people are building, people are doing it anyway. So actually, I think we've got to keep on doing it against the grain. And we've got to try a little bit harder, because it's easier to go with the grain, isn't it? But if we're going to do this, we're just going to have to go against it, and we're just going to have to keep on pushing.
Thank you. Thank you so much, both. I think there is something about, really trying to push forward, really focusing. I think everyone should print this out and have it on their desk. I definitely will be sharing it with my whole team. And any other questions, we're going to go to a break now, so we'll be able to answer them in person. Yeah. So thank you. We are running a little bit behind, so I'm going to say 10 minutes for a break now. Sorry for clipping that a bit shorter. But if everyone can be back here by 25 past, then we've got some other amazing speakers. Hello, everybody. Thank you so much for a slightly shortened break there. For those of you who've just joined us, I'm Lucy. I'm the Director of Policy and Practice at Rethink Mental Illness. And I'd now like to introduce two speakers on the very topical but very challenging issue of violence, abuse and mental health, who need to make their way up here. We've got Professor Sally McManus, who's the Director of Violence and Society Centre at City St George's, University of London. And then we'll have Dr. Olumide Adisa, from the Mayor's Office for Policing and Crime, but also wears many hats, as I've also just been hearing.
And sorry to cut that break short, because it's like so many meetings of, there's greetings, I haven't said hello to you yet. There's so many, how do we go ahead? Is it one of these? Lovely. Okay, so I'm feeling bad because we've had these amazing sessions so far, which have been very much about not taking a deficit model, and now I'm going to dive in briefly into a deficit model, but I'm going to go through it quite quickly, but it's really just to put another thing on the picture when we're talking about violence and abuse, and also actually just as a sort of demonstration for how you can use APMS data. APMS data is a community research resource, and we're here to support Sarah Morris and Eleanor here as well in the audience know the data set inside out. So any questions you have about what's in there, they will absolutely be able to say for you. So the report that came out just recently did have a chapter on suicide and self-harm, that's suicide attempts and thoughts and self-harming behaviours. So I'm also in this session, I will talk a bit about some quite specific types of violence and abuse, so just so you've got a bit of a heads up on that. And it's continued to increase with that upward trajectory. So this shows past year suicidal thoughts and suicide attempts in 16 to 74-year-olds. And so I was quite, I actually had thought, after the steep increase in self-harming between 2007 and the 2014 survey, I thought we would have plateaued just a little bit. And I just remember us being in a meeting and then seeing how much that it had increased again, and thinking that there's real shift here. So that's 1 in 10 in the population saying that there's engaged in self-harm, and this is self-harm without suicidal intention, and there's lots of differences amongst researchers about separating out suicide attempts and self-harming without suicidal intent. But that's the way which APMS has always been structured, and one of the key things that we do is we try to keep things as consistent as possible over time so we can look at change. But most people who reported self-harming described doing so because they felt that it was helping them to relieve feelings of anger, tension, anxiety or depression, so that they were describing it as being used as a coping type strategy. So we're seeing this increase not just in one group, we're seeing this increase in both women and in men. We're seeing this increase across every age group. So it's not just an increase amongst young people, we're seeing an increase in every age group. However, amongst young people, we're seeing the highest rates. So there is something very much happening there. And when asked if you'd ever made a suicide attempt, for example, amongst 16 to 24-year-olds, 1 in 10 were saying that they had. Now, the survey, as Mari said, covers loads and loads of different topics. And I'm just going to pull out what can be done if you want to look at one particular sort of area, so looking at violence and abuse. If we look at the population as a whole, about 1 person in 20 has experienced domestic abuse in the last year. If we just focus on those people who report having made a suicide attempt in the last year, about 1 in 4, it's about 1 in 3 amongst women, report having experienced domestic abuse just in the last year, so either currently or recently. We know that our data is cross-sectional, but there's all sorts of ways in which you can use that data to explore potential mechanisms and potential, the extent to which we might be able to support a causal kind of hypothesis. So first of all, we can adjust. So this is one regression analysis where if we look at having experienced intimate partner violence and we look at suicide attempt as an outcome, and we adjust for all the different sorts of adversities that people might have experienced, bereavement, poverty, and other aspects in their life, we still see a strong association. We see an association in models where we look at different types of violence and abuse. So we see it for physical violence, for sexual violence, for emotional violence, for economic abuse as well, but particularly for sexual. We see a recency effect. So this is another way of us having confidence that this is a meaningful, strong association. So where people have experienced intimate partner violence in the past year, the strength of association with having made a suicide attempt is that much stronger. And we also see a dose effect. So for those people who've experienced more types of violence, we tend to see a stronger association with having made a suicide attempt. Now, it's really important to remember, and I really valued that in Stephanie's presentation this morning, that these are individual people who take part in our survey, and they come with nuanced, specific, multidimensional experiences. So each of those people will have had a different kind of experience in their life of a whole range of different types of indicators of violence and abuse. So one way in which, from an analytical perspective, if you're looking to work with the data, you can work with these sorts of indicators is by taking a more typology-focused approach, because we know that the types of violence people have experienced impacts their mental health in different ways, the number of types, the timing of the types. So with a latent class analysis, we can start to group people together. It's a data-driven approach rather than a top-down one. And we can produce a population typology where people can be aligned with others with a similar profile of experiences to themselves. And with an approach like this, we find about 3/4 of the population have experienced relatively little violence and abuse. And then we identified 2 key groups whose experiences were primarily characterized by physical violence from a partner and coercive control, and 2 groups whose experiences of violence and abuse were primarily characterized by sexual violence, be it in adulthood or in childhood. But there's one group in particular I just wanted to highlight, and this is a group who'd experienced extensive physical and sexual violence and coercive control, both as a child and in adulthood. Now, producing a typology like this gives us a sense of the population as a whole. We can then look at the characteristics of the people in these different groups. And just going to finish up with this. So if we look at that group, that 3/4 of the population who'd experienced relatively little violence and abuse, about 2% reported that they'd ever made a suicide attempt. Now, in those 4 groups that was characterized by particular experiences of physical or coercive control from a partner, or who'd experienced sexual abuse or violence, about the likelihood of having made a suicide attempt was about 5 times higher. But that group who reported childhood experiences and adulthood experiences of physical and sexual violence, 15 times more likely to have made a suicide attempt at some point in their life. The suicide prevention strategy that came out 2023 recognises this group for the first time, people who've experienced violence and abuse, and that we can discuss ways in which I'm looking. Louise has got, you want to? Oh no, you look like you were going to say something. But there's much that can be done there about the ways in which we respond. We ask questions with curiosity in different clinical settings, but professionals need to know that when they are asking people who might be presenting in suicidal distress or who have self-harmed, they need to be aware that there are referral pathways that they can use and be confident that those are there. I just wanted to mention finally as well that Vish Bavsa at King's has also used the APMS data to really explore people who have used harmful behaviours. And what he shows very nicely with this data is that, yes, they have worse mental health, they're more likely to have made a suicide attempt and self-harmed. However, they're no less likely than people with similar experiences to use mental health services, which suggests that mental health services really can offer a non-punitive and constructive point of contact for people who might be using harmful behaviours in their life. The data is going to be available, as Mari said, by the spring, and we are there to support people who are applying for it. It's much easier to get hold of. It can be used in many different ways. This was just an example of how the data can be used. You can get hold of the 2014 data set now. Go get it, go get it. And finally, just my final little plug, we're part of the Vision Consortium that's working with data from police, from specialist domestic and sexual violence services, from a variety of sources to explore the intersections between violence, health and society.
Thank you, Sally. So, for those that don't know me, I'm Olumide Adisa, and I primarily actually do a lot of work around violence against women and girls and domestic abuse research particularly. And yeah, essentially you've let the Vogue researcher in. So one of the things I want to share today really is how a whole systems approach can actually help in terms of the integration. But before I start, I just wanted to say thank you to Joe and Irina and Natasha, the team at NatSen, who have just been incredible in terms of the organization here, British Academy as well. And I also wanted to also pay tribute to Graham. Thank you for sharing your lived experience. And I took away a lot of interesting stuff. One thing I would say is that for me, I could pick out the a greater understanding for complexity of our complex lives, but that is much more that actually unites us and holds us together. And I also picked, really importantly, the importance of community and really valuing that experience, lived experience. So thank you for sharing that. I also want to pay tribute to Andy, who obviously shared a lot around the fact that actually all of the systems around mental inequalities, violence against women and girls, he didn't mention that, but he talked about different types of inequalities. They are not separate, they're interconnected. And for me, it really is a really nice foundation for the sort of ideas I want to share today. I also want to pay tribute to Stephanie, who incredibly has made what I'm going to say very easy. She introduced systems approach already in her talk. I cannot honestly overstate that we do need to work in a coordinated and joined up way. Much more than ever, we cannot afford to continue to have fragmentation of services and mental health services. And we cannot continue to, in so many ways, silence voices that we need to center at the forefront of this work. So why should we care about violence against women and girls? The End Violence Against Women and Girls Coalition stated that about 3,000 crimes are reported every day to the police.
every 30 seconds, a domestic abuse victim is making a 999 call for help. If you imagine that 30 seconds, but by the time I finish my call, how many calls have already been made to the police? And that's just to the police. So the scale of the problem, for me, already lends itself to the idea that there will be a massive link to mental health, mental issues as well. So, and obviously, as Sally has already shared a lot with the data, you can already see that there is a correlation. I mean, not going to go into the causality debate, but there is definitely a link between those two issues. So I guess for me, my task today is to say the whole systems approach might just help us do that. Before I start my talk, because I'm wearing the Mayor's Office for Police and Crime hat today, because I'm what you might call an academic policy researcher, it's important to state that my talk is very much my personal perspective, rather than those of an elected official or even MOPAC's position. So now that we've got that out of the way, I will now share some of my own insights. I think the best way to really perhaps understand my talk is that, for me, I see, let me not forget the clicker. So I've called this a breath of fresh air, translating academic work into policy using a whole systems approach. Why did I put a breath of fresh air? Because when I joined MOPAC about 6 months ago, a senior government official said to me, as I was waxing lyrical about whole systems approach, as I will hopefully not be too self-indulgent to do today, and she then said to me when I paused, she said, "Oh, wow, you are just a breath of fresh air." Now, I said to myself, there are two ways to interpret this. One, she's saying, you have not yet been institutionalized. You just wait. Or the second bit is, wow, you're a positive energy for innovation and change. I've decided to take the second interpretation just because I think that perhaps that is where she was leaning to, because it was said in such a positive way. But I say this because for me, when I say a breath of fresh air, if anyone was expecting breath work, sorry. But we will, if I get time, I will share my poetic reflection, and perhaps in that we might do some breath work. But I'm definitely not a CBT practitioner. But it's perhaps the only place I might be able to get away with actually using breath as a metaphor for energy, for change, for continuity, and for growth. All of this is something that I've been reflecting on as I've been collaborating with poets in the last 1 year in my work, to really understand some of those tensions and contradictions of bringing some of these ideas, these academic ideas, into policy spaces. I hope I have time. I'll keep an eye on the time, but let's see how we get on. So I guess in a way, I've kind of already talked about the multiple lenses through which I see the world. In a way, I'm a trained economist and sociologist. I did an interdisciplinary PhD, which I won't bore you about. This is like a long time ago. But some of the frustrations I felt around the silos and the disciplinary silos is kind of what led me to this journey of really trying to ensure that we are very much thinking in a very systemic way. And so I kind of found myself in the world of evaluation, really evaluating a lot of domestic abuse, violence against women and girls evaluations, and then developed a complex systems change framework, which I will share with you. I won't be able to go deeply into that, but there is a book which I've brought, and I hope to give somebody, if you want, we'll see at the end. You can just come find me. The first person could have a copy. Oh, you're very keen. Thank you. Just come find me at the end. And also, you know, just also say that, you know, for our online friends as well, you know, if you want to really kind of find out more, you know, you're more than welcome to reach out to me as well. So I think I wanted to also talk about the value of complex systems thinking, and obviously kind of thinking about this framework. And I have been asked also to think about the challenges, opportunities, and role for research. And as I said, if I do have time, I hope I do, I will be sharing some of that poetic reflection. The beauty of this poem, that hopefully I will share, is that it means I don't get to name anybody, or that I don't get to, like, it's really subject to your interpretation. But it's really something that's come from my own lived experience, even around mental health, but also some of the everyday grappling of trying to really convey, one, the value of systems thinking. It sounds great on paper. In practice, it's very difficult sometimes in policy spaces for a lot of reasons. But I think that grappling and that labor is something that I've been trying to find language and meaning to. So it's a very much work in progress, and I've actually not shared that bit with anyone in this space yet, so we'll see. Okay, so talked about this. What is a whole system approach? If you're only hearing about that for the first time, essentially it's really thinking about what is a system first. A system really comprises of actors, elements, interconnections, but what unites us really is a shared purpose. And this is a definition actually that I really would ascribe to the late Donella Meadows, who really was this foremost systems thinker, and I think there's a lot of people that have talked about and tried to define systems. There is no universalized definition, but just to say that it means it is really talking about actors, so people, individuals, organizations, and then different types of structures as well, hopefully around a certain issue or purpose or really key problem. There is something that I think really makes systems approach very challenging to do, and that's the fact that complexity sometimes throws in a lot of complexities, but it's really what makes it difficult to really implement in practice. And again, we've covered a lot of this in the book as well, so I won't really go into that. Just to think about three elements, which is that there is a need to think about interconnectedness. When we recognize that we are connected, the issues that we care about, whether mental health inequalities, violence against women and girls are connected, then really we might be able to begin to find solutions that are really sustainable and that really tackle the complex societal issues at the root, not just on a surface level. We will also then, or when we talk about system level engagement, we will be looking at also, as Stephanie already said, who is still missing from the table. I cannot even stress enough how, even for me, standing here today must be probably a rare thing. I was saying to Sally as I walked in, and I was like really stoked, and I got there and I was like, my badge, and I didn't have my badge. And it threw me because I thought, oh, okay, but it just says a lot. I'm not saying it was intentional. I'm just trying to say that those things tend to really have a deeper meaning in terms of who is welcome and who is not welcome. So just to put it out there. So this is the Complex Systems Change Framework, and it's really smaller than I thought. Sorry about that. But basically one of the things, I'm not going to talk through everything. I think one of the things I want to draw on here is that this was initially designed for an evaluation, so I led on the systems change evaluation for a national rollout of a perpetrator program, really looking at working with those who use harmful behaviors. And this came out of that in relation to understanding the systems, and they work with mental health a lot, actually. That was one of the key problems. But particularly for domestic abuse, one of the things I would say is that because, we try not to assign that mental health is what's causing the abuse. However, we know that it is very much a risk factor. We also know that there is a lot that we can do when we really address those issues, particularly for the perpetration side of the equation. So there is something to be said about what are the workable frameworks, and some of these principles is what I've been bringing into really more PAC, trying to really, obviously, as you know, I'm co-leading the Vogue strategy refresh, for the Mayor of London, and I think there is something there, not to say that all of the principles have been adopted, but there is an appreciation for a whole systems approach in a lot of police and crime commission areas. And actually London is one, right? So I've been writing this piece to read. If you don't know what PCCs are elected officials, and they really hold a lot of portfolio and power in relation to commissioning violence against women and girls services in local areas. And there is an opportunity there for mental health as well, by the way, because with the Victims and Prisoners Act, there will be a duty to collaborate, which means the PCCs, integrated care bodies, local authorities now have to commission together. And there is a lot of opportunities there for mental health coordination, mental health service coordination. So that's what I want to say there. So value and translating, why is this important? I think that for me, we need to be thinking about systems approaches because it helps us to recognize complexity, to acknowledge the multifaceted nature of violence and its root causes, and the links to mental health. We also then need to look at systems coordination as well. And also, as I said, tackling the fragmental support systems for practice level and systems level change. There is also something about accountability, which was mentioned as well. I very much see outcomes as a really key way to really build accountability in the system. What are we measuring? Who is measuring it? And what is that really saying about the change that we want to see happen? And I think, Graham already talks about this reimagining in relation to what types of outcomes we probably even need to be expanding our understandings of, not just, of course, some of those that we already have in our surveys, even though they're very, very, important and helpful as well. Just to say, as a quick plug, obviously some of the ways that I'm applying this is obviously in policy spaces, MOPAC. I'm also trying to track all the other police and crime commissioner areas that are using all systems approach. I currently hold a fellowship with CCAN, which is the Center for Complexity across the Nexus. So we've been doing a lot of work bringing systems thinking to government spaces. And what I'm doing there is to try to really develop a complexity-aware theory of change, which integrates both violence prevention and mental health as well. I'm currently developing an NIHR bid as well, which really is going to be looking at a systems level evaluation in terms of improving outcomes, social care outcomes for children and young people, but I also want to try to inform mental health pathways through that. So if you're interested, if there's something that maybe you think actually your organization could be part of that, please reach out to me as well. I'm just about kind of putting that together, which is quite a lot of work. Okay, so really quickly, I don't know who's doing time. Sorry, how much time have I got? Time check? Okay, I'll just assume I'm fine. Value in translating. So I've actually talked about a lot of these bits, really, in terms of really strategy development. These are all applications, but I think it's worth thinking about what would an integrated strategy for both mental health and violence prevention look like? And also then thinking about some of the spaces we are in and really what does policy design mean for those spaces. I will say for me, in terms of my own work and also really navigating the policy arena, that there is a lot of, let me be careful with this word, I think mental health doesn't always seems to be the afterthought, if that makes sense. So I think that we're seeing a growing absence of mental health discussions within those policy spaces. And I'll just leave it there. But I think it is such a critical component. But when there is room to look at a lot of the violence against women and girls strategies and really see what role mental health is playing within that in terms of the positioning of mental health as a very important issue within those types of strategies. I don't need to say a lot about public health approaches. I think already Andy's talked about what that would mean. But I just wanted to say something about the systems approach, which already aligns itself very much with looking at structural issues. So what that means is that we now need to be looking at more upstream approaches, which is not just looking at individualized interventions, but looking at what will tackle the structures that continue to hold the problems in place. I think Steffi has already talked about systems of oppression. I think that is a really key part of the puzzle, and we need to really begin to address that. So these are the three questions that I've sort of come up with, which is like, what is the key challenge for us, I think, that we need to address? I don't have the answers. I don't think one person can have the answers, but I've put these questions as probably food for thought, particularly for those that might be wanting to do more research in this area, which is to really think about what systemic barriers prevent effective responses through both a vogue and a mental health lens. And then really in terms of opportunities, I kind of have talked about a few, which is around looking at vogue strategies. How can we get mental health more in there and much more visible within those spaces? And then also where can whole systems approaches create those breakthrough solutions and working with different people across the room, literally convening in this same way, uniting academics, survivors, policymakers, lived experience, and living experience people to continue to have these conversations and dialogue. That's the only way we can move forward. And then with research, thinking more about how can evidence inform and strengthen systems change and what works at a systems level. Okay. So I've put some of the further readings here. A lot of what I've said, we're already practicalizing that. And actually, if you want to know more about the ways that this is being sort of integrated within mental health spaces, I've just kind of put some of the pieces of work that I've been doing with different people. One opportunity I will say, and that's because we're seeing a lot of domestic abuse-related suicides. I think we're calling it domestic abuse-related deaths now instead of domestic homicides. But there is a massive gap in understanding the patterns and what's going on there. And one of my colleagues, actually Aisha, she's just about to begin a PhD actually looking at this particular area, but specifically for Black and racialized communities, because again, they're missing from the data, they're missing from, we don't even have a lot of insights, but we know that they're very overrepresented, and there's massive disproportionality as well within the criminal justice system and a lot of the systems. So there is a massive gap there in terms of understanding the implications for mental health as well. Okay, so I think we've got 1 minute, so I'm going to read this breath poem. I feel like I've built so much momentum about this poem. So I work with a lot of victims and survivors in my work, and this whole piece of work around trying to create a dialogue between really, I would say, accessible understandings of change, but what does change mean for someone that's experienced both violence and abuse, and also has experienced mental health or mental health inequalities in the same way? It's not sometimes a very straightforward answer. And so I've been trying to see what ways can we do this using art-based methods. Well, and also poetry has been really incredible, and the Vision Consortium kind of pumped some funding to kind of help me do this collaboration. So I kind of encourage a lot of them to write their own pieces. And so I've sort of decided to swallow my own medicine and written this piece on that basis. So hopefully if they're listening online, they won't be too, they'll be kind in terms of really, because I do feel like I'm kind enough when I listen to what they say. But I think this is my own way of really somehow saying that when we talk about collective bravery, we all have the power to be part of that change and to really start doing it one step at a time. If I can find the poem. Okay, so here it goes. So breath as a metaphor for energy and change. Breath, simple yet profound. A rhythm where life is found. Inhale brings vitality's light. Exhale, clear space, sees things right. A cycle internal, a flow unbroken, energy shifts, a truth unspoken. Breath in labor, effort recalls, complexity in its rise and falls. A grounding force, the present secured, a guide through peaceful and stormy weather. Resilience shines in each breath. In challenges, hope begins anew. A pause, a recalibration, a view. Like change in systems, a purposeful will, breath inspires a journey uphill. More than an act, it feels transformation. Endurance, strength, a quiet foundation. Breath, a life's rhythm, and a heart's refrain. Thank you.
Thank you so much. Thank you, Olumide. I'm so glad you did give the people what they wanted and did the poem. Have you got a microphone? So really, really challenging issues, really important to talk about, to see the prevalence, and then to understand what I think at the heart of what you were saying, Olumide, around this whole system working together, the barriers that can be part of that, but how we have to do that in order to address the issues. Does anybody have any questions? Graham.
I hope this adds to the conversation. In one of my hospital admissions, the nurses found out the reason I was limping was because my wife was hitting me. And the psychiatrist did nothing other than say I was a complex individual and then discharged me to her care, where she carried on hitting me and doing many other things to me. And although I know domestic violence is primarily against women and children, I think, and I'm not an academic, about 30% of it is against men. Are there any moves to maybe look at vulnerable men who may be subject to this too?
Okay, well, I'll take that. I think if you just...
Okay, cool. Thank you so much. And that's a really important point. Obviously, recognizing that domestic abuse and violence against women and girls is very gendered. However, one of the reasons why I talked about strategies is because for me, I think that's where it needs to start. If we recognize, and a lot of strategists do, by the way, they do try to put a position out in terms of what the support is for male victims of domestic abuse. We think things are changing. We are seeing more recognition for the issue and the gap in the issue as well. I mean, the organizations like Mankind Initiative, I don't know if you've heard of them, have really been trying to push that forward in relation to the experiences and of male victims of domestic abuse. But there's a lot to still do. What I will also say about the complexity side of it is, when I talk about complex systems, people tend to say, and I think we have this conversation because in gambling and a lot of the, when you talk about commercial, so-called commercial determinants, you see how for some really big organizations and industries, they actually use complexity as the excuse to not do anything. Because they'll say, oh, that's too complex, ooh, regulation, you know. So it's a bit of a double-edged sword in a sense that whereas in some spaces where we know we need to grapple with complexity, we have to be careful that it's context-specific and that, you know, we don't use complexity as an excuse for inaction. I think we need to find our way through the noise and really be very clear about what we want to achieve from that whole, you know, I guess, intervention or program or even policy. But I guess the roundabout way to say what to say is, you know, I hear you because your experience was valid, but there is a lot of still a gap in the knowledge. I think we need to do more training. I know training is not a magic bullet, but we are seeing the context of domestic abuse and even violence against women and girls changing because of technology, because of digital. You know, so there is more and more. We need to keep abreast of some of those changes, and we need to be really expanding and really supporting professionals to really be professionally curious and not have those stereotypes about different people, especially male victims, if that makes sense. Because we still hear when they're like, oh, they're not going to believe me. So we have a lot of work to still do, I think, in that area. But thanks for highlighting that.
I think you covered that beautifully.
Yeah, thank you, Graham. We've got time for one more question, if anyone has. Oh, there is actually one online, which we haven't gone to anyone online yet.
Hello. Yes, there's an online question. They're asking, I wonder if you'd be able to give an example of what the whole systems approach would look like for an individual experiencing domestic abuse, an example of what their support journey and touch points might look like if the systems approach was working well.
Okay, so that's my question. I know, and I'm trying to find, I need to be succinct about this answer because that question relates to levels, right? So on an individual perspective, you know, if you as someone that has experienced domestic abuse, you want to get support and seek help, one thing we need to see, and we think, and I've seen this actually, the power of this, is that we need to make sure our services are more coordinated. I think we need a more joined-up approach. So if someone's really choosing not to go to the police, what is the system of support for them? What's the journey they need to take? So we do need to, first we need to obviously build trust in the police. There's no doubt about that. But there is also something about also trying to reinforce community-based services, right? They're such an important puzzle, and I think Graham talked about some of the work charities and third sector organizations that have been so pivotal to, you know, your journey, Graham. And I think that everyone, even with a lot of victim survivors, we hear how they would go to someone in the community or their neighbors, a friend, they wouldn't go to the police for. So I think for that survivor is ensuring that first there is a greater awareness about domestic abuse across society, so that it doesn't matter where you go to, you would always get somebody that has that understanding. What does the whole system look like for, I think, a survivor? I think that is a very individual question, but I think that for me, a whole systems approach in relation to how it works is a coordinated system, one that really means that they get the help they need, regardless of who they are, their backgrounds, whether or not they're coming from whatever environment or whatever background, that they will get the help they need. And also to probably say that through the journey that they get, if you're a victim survivor, you might want justice. So what is their journey through that system, the criminal justice system, for instance? We don't want them to be waiting 3-4 years for them to get justice. So really understanding that, one, we don't have cut backlogs anymore, right, if they're already in that system. We also need to look at the family courts as well, because there is, again, a lot of problems there. So whole systems approach really is a very improved system where and a joined up system as well, well, where this victim survivor doesn't have to be telling their story over and over again because of wherever they're going to. I'll let you say something because I know you might have something, and I'll answer the second one about workforce system.
Yeah, I'm not sure I've got a lot to add. I'm very glad you brought up commercial determinants, because I think when we're thinking about a whole systems response, that needs to be a part of it. And I'm very pleased that Andy described the importance of welfare systems, because without socioeconomic security and housing security, then that needs to be part of a whole wider system, as well as the immediate interpersonal, so all of those levels.
Thank you. I love Sally because she gave me the moment to be able to find my notes. Thank you for that. So to answer the second part of the question, which is to say, what does that look like how would we know a system is working? I'm going to draw on the evaluation I mentioned, which is the systems change evaluation, which it was a very complex one because it really was multi-site, different areas, different geographical areas. So place-based approaches, sometimes we're seeing that come back. And that's important because we know that there's a lot of insight and knowledge within communities that we need to be drawing on. It should not be feeling top-down policy. We need to really encourage and value bottom-up. And I think we need to do that much more. So some of the things that I think really matters for really improving systems, one, of course, is to generate evidence. You should also value the role and have a pathway for influencing and convening. I think that you cannot, honestly, I think the value of bringing of these types of safe spaces and bringing that together is so valuable. I mean, much more even at different levels. Whether or not it's in a therapeutic environment or in a community-based sort of environment, we need to really try to encourage that. We need to celebrate good practice, promote systems leadership, strengthen systems through workforce development. I mean, I think last time I counted, I was looking at some of the data. There are about 2.4 million people that have been affected by domestic abuse in the workforce. And when you think about the experiences they might have around bullying, harassment, and sexual violence in the workplace, that is another layer of trauma and adversity that we need to be looking at. So workforce, again, would be one I would say we need to do something around. And most importantly, to continue to embed an equity-oriented approach. It can never be a one-size-fits-all. So the answer I would give to you on the call is, it's a very context and very much rooted in lived experience. We need to return back to that and understand that the way to really solve the problems that we have, what we see, is to really have all of us playing a part wherever system we might find ourselves, whether education, NHS, policing, policy, we all have a role to play. So, and even for the survivor as well, because that story is what can bring about an improvement in the system and a change as well.
Thank you, Olumide and Sally. I feel like we could talk for so long about this. There's so many important policy considerations. We have slightly, but it's really, really important. So thank you. Thank you to Sally and Olumide. So I'm now going to just give a trigger warning for the next session as well, where we'll be talking about suicide and suicide ideation. So please do leave the room if needed at any point. So I'd like to introduce Professor Rory O'Connor, who's from the University of Glasgow, to present on understanding the psychology of suicide risk, followed by Dr. Socrates Dinos, who's the Director of Health at NatSen, who'll be talking about the association between suicidal ideation and behavioural addictions. Do you want to come up?
Brilliant, thanks. Is this working? Yeah. Delighted to be here. In the short space of time that I have, because we're running, I think, 45 minutes behind schedule, I've just counted, I'm going to talk about some of the work we've been doing. Three things I'm going to try and do in this short time. One is to tell you about a model of suicide that I've developed to help us understand suicide risk. We've talked a lot about statistics today, but those statistics are not very helpful on their own. We need to have a framework to understand them. I'm going to talk about two examples of two factors that are important in the context of suicide risk in a couple of studies, and then I'm going to end with some optimism on a couple of intervention-based studies that I've been involved in, which hopefully will shape some of our innovations as we move forward. So, a good way to begin is, of course, a quote from a now dead English philosopher. A lot of us will know this quote, that no man is an island entire of itself. Every man is a piece of a the continent a part of the main. Now, of course, irrespective of the man language stuff, it's a really important message. And we're trying to think about understanding and preventing suicide. We should recognise the importance of seeing an individual within their broader context. And for too long, we haven't done that. And I'll try and touch on how we do that in the work that I've been doing over the last 30 years, is trying to understand why it is some people become suicidal and some people cross a precipice from thinking about suicide to attempting suicide or dying by suicide. So that brings me then to the model of suicide I developed a few years ago in 2011, and then I updated it with my colleague Olivia Kirtley in 2018. So again, in the interest of brevity, the model, the integrated motivational volitional model, is what my attempt to understand why people become suicidal, why people cross a precipice from suicidal thoughts to suicidal acts. The model is in 3 parts. On the left-hand part of the model, we've got the pre-motivational phase, which I'll return to shortly, but that's the background context in which suicide risk may emerge. And then parts 2 and 3, part 2 is the motivational phase, and that's trying to understand the emergence of suicidal thoughts. And then the 3rd phase is the volitional phase, and that's trying to understand this transition from thoughts to action. And in a very sort of truncated way, the key message behind the model is that people become suicidal, they experience suicidal thoughts when they feel defeated and humiliated from which they cannot escape. And it's that co-presence of defeat and entrapment which are the key drivers to suicidal risk. Now, indeed, defeat and humiliation can be triggered by loss, by shame, and by rejection. But my argument is, though, although there's a whole load of complexity, and the individual pathways for each individual to a sense of entrapment is unique, right? So it's very different for every one of us. The process is the same. And so if you're asking, why do people become suicidal? It's not necessarily that they're depressed, or that they've an awful history of abuse, or that they're unemployed, or the relationship has broken down. Of course, they can all be part of the context, but you're trying to understand it through the eyes of the individual. You're trying to understand why it is that they view their future so bleak and so unbearable that suicide is a way of ending that pain. And the key message is that suicide isn't often about wanting to die, it's about wanting that unbearable pain to end. And we've done lots of work, and other groups have done lots of work to support many parts of that model. And then, again, it's beyond the scope of today, but the other key message from the model is the difference between people who think about suicide and those who act on their thoughts is governed by a group of factors called volitional phase factors. So if you're feeling suicidal and you've got ready access to the means of suicide, or you're impulsive, or you've had exposure to somebody close to you who's died by suicide, they're the key factors that drive that transition. The defeat and entrapment drive the emergence of suicidal thoughts. Okay, and again, if you go to our website, suicideresearch.info, loads of free resources and information on what we do. But what I want to do now is move on to the policy implications and give you 2 examples. So Scotland, which is a great nation, I'm Irish, but I live in Scotland. I have done for 25 or 27 years. The Scottish National Suicide Prevention Strategy was published in 2022. And the underpinning framework is the IMV model. So the questions we're asking now at a policy level is that policy initiative, does it contribute to defeat? Does it contribute to entrapment, or does it alleviate it? And look at social welfare, look at contact with mental health services, look at education sector. So it's a different lens by which we can try and think about suicide and suicide prevention. But moving on then to what might convey sort of vulnerability for defeat and entrapment. And I'm going to just touch briefly on two examples of studies we've been doing at the minute recently. One's looking at perfectionism as a personality factor, and I'll illustrate what that is what I mean by that in a second. And the second is childhood trauma and the devastating impact of childhood trauma. So this brings us to the first bit of my model, the pre-motivational phase. So perfectionism is a personality variable which conveys, as you'll see, this vulnerability to defeat and entrapment that you'll see shortly. So it's a diathesis or a vulnerability factor. And of course, very clearly, childhood trauma fits within our life events phase of understanding the person in their context. There's lots of work, really lots of work, which has shown the importance of a particular type of perfectionism called socially prescribed or social perfectionism. And what it is a personality type which is it's characterized by having excessive, often unrealistic expectations that we think important people in our lives have of us. It could be our parents, our friends, our colleagues, whoever, right? But the point is, it's tapping these beliefs, these ingrained beliefs that actually you're continually letting these other people down. And the reason it's so pernicious is because it's outside your control. It's not what these people actually think, but it's what you think they think. It's a metacognition. And there's lots of work. We've done work with now tens of thousands of people across all age groups, clinical and non-clinical populations, and people who score high in this socio-prescribed perfectionism are vulnerable, as you'll see in a second, to defeat and entrapment and suicidal thoughts and behaviour. And the key driver in that is trying to understand how does perfectionism develop. We're not 100% certain. In part it's to do with inconsistent parenting. It's in part to do with society's expectations that are imposed on us. It's in part to do with trauma in early life. We don't know for certain. We're trying to understand that. And then, of course, the relationship between childhood trauma and suicide risk is really well established. Here's just one slide from one of our studies. This is a sample of people who have attempted suicide. And 80% of the sample reported a history of not just trauma, but moderate to severe trauma. And we've replicated that in such a devastating statistic. But in a recent study, we're trying to understand this relationship between perfectionism and trauma and defeat and entrapment in more detail. And I'll just highlight the key messages here. So we know there's lots of evidence, as I said, that trauma and perfectionism convey this vulnerability to defeat. But what this study, this is a series of 3 studies. One's a survey-based study. The other 2 are intensive longitudinal studies. We're doing diary-based studies over 7 days, and we're monitoring people's defeat and people's entrapment daily, how it fluctuates. And what's really clear from this study is that basically predicting levels of entrapment, childhood trauma and perfectionism are important, but it says daily change. They predict daily change in entrapment and is mediated or accounted for by daily changes in defeat. So although the trauma can be very long-standing in a history in your past, the impact on day-to-day is also evident. Okay, so that's the 2 of the 3 things I was hoping to do. The IMV model, I give you an example then of a couple of studies we've been doing, looking at, in this case, trauma and perfectionism. But what I want to end in is a question we were asked to address is, well, how can the research agenda support wider goals for policy and practice? And I'm just going to illustrate my answer to that using 2 studies that we've been involved in. But both of those studies are looking at developing innovative ways to reach the people when they need them. Suicidal thoughts don't wait for a waiting list. They don't wait for the 12 months. If you're a child and a young person, you might get an assessment, but my God, you'll be waiting much, much longer before you get treatment. So we've been involved in 2 trials. One is the RAPID trial, which is led by Tony Morrison in Manchester and is across the UK study. I'll give you details of that in a second. And the second is a brand new innovation in Scotland called the distress brief intervention. So the RAPID trial is based on one of the arms of the trial is based on safety planning, and it's based on a feasibility study that we did in Scotland, looking at embedding safety planning with telephone support in the context of the NHS. And it was clearly feasible, but it was only a feasibility study. So although safety planning is widely used clinically, if you look at the evidence base, there's no evidence yet which demonstrates in an RCT that safety planning in this context with telephone support is effective, right? There's no RCT shown that there's a case cohort study, but we still need to develop the evidence base and understand the mechanisms by which it may be effective. And so this is the RAPID trial. We won't know until next year whether it's effective. So my slides have all gone hunky, whatever, a bit skew-whiff, I can see. But basically, one of the arms is a safety planning arm. And we use an adaptive trial. And actually, using an adaptive trial, the only 2 arms that are remaining in the trial are safety planning with telephone support and treatment as usual. And this is delivered entirely remotely, 12 sessions of safety planning compared to treatment as usual. And we'll find out next year whether it's effective. And the last thing before I draw it to a close is an innovation in Scotland which began in 2016 and 2017. And it's what's known as a distress brief intervention. And what it is, it's a 2-level intervention. So if anybody rocks up in distress to the emergency department, to their GP, to the police, phones NHS 24 in Scotland, they can be referred into this DBI service. And what it is no waiting list. We guarantee you that within 24 hours, we will contact you. And if you want to take part in DBI, which is a 14-day, non-clinical psychosocial intervention, which is based around a distress management plan and a range of other sort of problem-solving and action planning type tools. But the key message is helping people navigate those challenges which are often associated with distress, to act as an early intervention to hopefully equip people with the skills and resources to manage their distress moving forward. An independent evaluation was conducted and supports a national rollout. So now DBI, we've developed all the materials, we've developed the intervention, and DBI is now 85,000 people, it's probably 88,000 people have now been through DBI. 88,000 people, almost 4,000 people trained in delivering DBI. It's now available across the whole of Scotland. There's a pilot in England, and it's been piloted across Australia at the minute. And we're also piloting a children and young people version as well. And we've just published all the development work earlier this year. But the reason for highlighting DBI, because it's novel, it's person-centered, it's about driving compassionate, connected support when people need it. And often, although it's not designed as a suicide prevention intervention in and of itself, lots of people do have suicidal thoughts and self-harm. And for that reason, led by Joanne, who's sitting wherever Joanne's sitting, Joanne McLean, we're doing the DIMES project, which is trying to evaluate whether actually it does have suicide preventative properties. And we'll know again next year whether it does or not. Okay, so I want to bring it to a close. I've tried to illustrate the importance of defeating entrapment and the IMV model and ways in which we may be able to intervene using a bit of innovation. What I want to end with is a quote, though. I was very fortunate, along with Nav Kapoor, Helen Christensen, and Paul Moran, to lead the Lancet Commission, or co-lead the Lancet Commission on self-harm, which was published last year. And we had an amazing set of commissioners from across the globe, including amazing commissioners who had lived and living experience. So I want to end with a quote from one of our lived experience commissioners. Hope is complicated. I have had extreme rumination about a hopeful future whilst having thoughts of death at the same time. How my mind would transform hopelessness to hope is difficult to explain. I think in moments of complete distress and hopelessness, our survival may still try to search the grounds for even a pinch of salt of hope. Because deep down we know that life is beautiful even though living is hard. And days like today are helping us remind ourselves we can all help to search for those pinches of hope. And that salt, those moments of clarity in moments of darkness. Thank you.
So I'll try and keep it to 10 minutes. I think it will not be difficult because a lot of what I was going to say has already been what? Sorry? Can you not hear me? I have to stand here. That's fine, I'll stay here. So yeah, a lot of what I was going to say has already been discussed by others here, so hopefully I won't have to go into detail. So yeah, I just want to synthesize the evidence across some addictive behaviors, some addictions, and how they relate to suicide and also to mental health. I have synthesized data that we have at NatCen from our data sets, from the Adult Psychiatric Comorbidity Survey, the Health Survey for England, the survey, the Gambling Survey for Great Britain, and so on. And we all know how suicide and addiction, they are deeply interlinked public health issues. We do know that they are leading causes of premature mortality. They do affect the vulnerable populations, and I'll show you who are the populations that are at risk across these addictions. And I'm also going to talk about how there are commonalities amongst addictions and how there are a number of things that are interlinked. What I wanted to say here is that, firstly, I'm going to be using language used in clinical practice as opposed to language used perhaps by charities and so on, so I can be more concise. So I may be saying gambling addiction, but we have kind of moved on from this, and we use terms like experiencing gambling harms and so on. But in order to be concise, because I only have 10 minutes, and because I'm using the sources here, the clinical sources, I'm just going to be using the clinical terminology. And also, as I'm setting the scene here, let us not get stuck on whether these prevalence rates that I'm showing here are truly correct or whether they're underreported or overreported. There may be some overreporting here, there may be some underreporting. And for alcohol, for example, we have 20% of UK adults that drink hazardously. 3 to 4% of them have alcohol dependence. 2% of adults show signs of drug dependence. That is in the UK. And for gambling, up to 1% meet criteria for gambling disorder or experiencing gambling harm. And I have to say that the gambling one, is 10%, if not more, amongst people who gamble. If we look at suicidal ideation in relation to addiction, there is between 40 and 60% ideation in relation to addiction in people who have an addiction. The highest we tend to see in gambling and polysubstance use, as in people have, having an alcohol problem and a drug problem. And of course, let's not forget, but I didn't have the data. We do have the data. I haven't looked into the data that there are people who have a problem with gambling, and they also drink, and they may also be using drugs. So you can imagine there how the risk gets even more elevated. I'm not going to go into detail. If you look at the higher risk groups, sadly, it's the usual suspects that most of you who presented today have talked about, like people from disadvantaged groups, LGBTQ, individuals, young adults, women that have experienced trauma, perhaps domestic violence, ethnic minorities, sadly the usual suspects. And these groups also tend to be from lower socioeconomic backgrounds. Some notable appearances there are middle-aged men when it comes to alcohol, and young men when it comes to gambling. These groups kind of feature more heavily when they're actually not necessarily disadvantaged in terms of their group identity. They may be disadvantaged in other ways, as in from lower socioeconomic backgrounds and so on, or may have experienced trauma and so on. And I have there also the social economic factors. Again, nothing surprising there, similar stories. Andy, I don't know if Andy is still here, talked about all these very clearly about the inequalities that we're facing here and people, and how these kind of shape also the picture, not only on mental health, but also on addictive behavior. Just very briefly, that all sorts of addictions, they do share some common underlying mechanisms, apart from obviously impulsivity and disinhibition, which can be elevated if someone is under the influence of substances. People who do show signs of these addictions, they also tend to have a co-occurring psychiatric conditions or mental health problems, especially major depression, PTSD, and borderline personality disorder. They have shown to significantly amplify risk. But generally speaking, people with common mental disorders, especially anxiety disorders, may be more at risk of addictive behaviors. You have all, for example, experienced, you can all relate a little bit to repetitive behaviors that you hate about yourselves, but you cannot stop, I don't know, eating, overeating, or doom scrolling on your mobiles, or, smoking, drinking. I think we can all relate to behaviors that we would like to not engage in, but we perhaps do engage in as a way of distraction for those of us that have kind of tried to be a bit more self-aware and trace when actually do they engage mostly in these behaviors. Neurobiological changes, of course, associated especially when it comes to taking alcohol or using drugs, and the whole cycle of mood changes when people take substances. Stigma, social isolation, shame, stigma. And I have to say that again for gambling, we have seen the highest levels of stigma, maybe because for mental health and for alcohol, it's been discussed, campaigned for years and years and years in order to dispel the stigma. I'm not saying that we have dispelled the stigma. There's still a lot of stigma attached. But for gambling, we are a few decades behind when it comes to stigma. And currently, actually, we're doing a research project on suicide and gambling. And it's a clear finding that people with elevated feelings of stigma are more likely to experience suicidal ideation. I've already talked about it, how, mental health distress, anxiety, common mental disorders, they could actually, can lead us to get into repetitive behaviors in order to distract ourselves. Of course, and going back to Mari's perhaps presentation, there is also something behind these mental health issues. Why are they there? There are some social risk factors there. But once we have these sort of mental health conditions, then we may be, using a number of behaviors, engaging in a number of behaviors in order to cope with this distress. And of course, if we get then caught into a cycle of addiction, especially addictions like drugs, alcohol, that they do influence your brain, you have come downs, gambling, you lose all your money, you are in a dire situation, then of course suicidal ideation or suicide attempts can be an escape route to that. I think all the people who spoke today, they've spoken about these things, about something that Sally, you mentioned around the systems talking to each other. I can't remember the term you used. So, that is the cross-sector collaboration, public health campaigns. I know Gamble Aware does a lot in the space of gambling around campaigning. We do need to continue the campaigning. I'm also, I was going to say we need to continue campaigning about mental health and so on. I'm also, to be honest with you, a bit bored about all this. I've been researching that for 30 years now. In 2001, I was working at UCL in the Department of Psychiatry. We were researching stigma of mental illness. If I read something today about stigma of mental illness, a research piece, it feels like it was the research I was doing like in 2001. I'm bored as a way of saying that I'm not sure that it's, we're getting somewhere. And we also are at these conferences talking about inequalities and, what are we going to do? I'm not sure we're going to do something. Nothing. I cannot see how our way out of it, especially in a system, a political system, because all these things are also political. Our behavior is political. Our beliefs are political. This is all political. We are trying to help who here and how and in what, under what system, societal system. So, you know, how can we treat addiction if we don't address existential despair? Existential despair as in people's everyday lives. They relate, you know, a sick society. That then throws the blame and the responsibility on the individual to deal with it, and if they cannot deal with it, they are weak, and so on. They have failed. So yeah, I may be sounding a bit pessimistic here. I don't mean to. I'm just, you know, perhaps you can put it down as sarcasm, that it's great for us to research and talk about these things and know about these things and keep trying in our own individual ways to do something about these things. But at a societal level, I really am not sure that we're going to go anywhere anytime soon, you know, because of where we're at, politically speaking, in the UK, in the West in general, and under a capitalist system. There I am. All my manifesto. Sorry, I decided to go off script because a lot of what I was planning to say had been covered by other people, which was great. Therefore, it gave me the freedom and the time to go a bit off script and just throw a piece of my mind as well into it. So thank you for listening.
Thank you, Socrates. I think we can definitely relate to those feelings of the lack of hope in some cases. The only thing I will say is someone said to me the other day that it's when you start to get bored, that's when perhaps you start to get a bit of cut through, because you've been saying it so many times and everyone's been saying it so many times. But anyway, we will see. We are, as everyone knows, running a bit behind. Luckily, the amazing NatSem team did put in a bit of time for extra reflections that we won't have right now. We'll go to lunch in about 4 minutes. We'll go to lunch in 4 minutes, but did just want to give the audience the opportunity to ask one question, if that's all right.
Thank you. Just a bit of context that we've probably gathered by now. Martin Jones will respond to that again. In terms of scale, you know, best estimates are between 2% and 11% of all England Wales suicides are gambling related, which PHE/OHID estimate to be 117 to 496. Since they came out with that, there have been a couple of other benchmarks. Victoria in Australia has come out with 4%, and Nevada in the States has come out with 4%, although some caution about that. The data set's not very good. A comment on public health messaging and advertising. You mentioned that Gamble Aware do some of that. They do, and they get better, but I think their budget is of the order of 5 million last time I looked, compared to 1.5 billion from the industry. So I can see there's a big disconnect when we come to suicide prevention policy. You know, with those numbers of harm, they're acknowledged in suicide prevention strategies, but the biggest mechanism to prevent suicide there would be in legislation and regulation, and that's not even on the agenda. So there's a suicide prevention policy saying, well, here's how we can look at individuals to do this, while the other half of government is telling me that gambling is safe, harmless fun and carry on. Whereas if they want to stop suicides, they could start with regulation.
Do we have a 1 minute answer from both of you before lunch?
Unfortunately, I'm gonna have to be sarcastic here again, because yes, you're absolutely right. will they do something? Gambling is a multi-billion-dollar pound industry. You are asking, and rightly so, for a lot of regulation that for this to come, we would have also to accept that they will, all these tax will be lost, all the lobbying from the gambling companies, from alcohol companies, and so on, we have to go against all these. Is that going to, do you really think any government is happy to do that? I don't think so. To go against such a big industry with such massive lobbying. And of course, it all comes down to us saying we are a free society and people should be allowed to gamble. People should be allowed to drink alcohol. However, we don't say that about drugs. People are not allowed to take drugs. So, we haven't thought things through really. What I'm just saying is that there is this, and that's where, for example, at the moment, it's a bit complicated for us as we were discussing outside. We are evaluating at the moment the Gambling Act review, which is the most comprehensive set of measures to, prevent problem gambling and all that. And you were saying, well, have they done enough and all that? It remains to be seen. We are going to have our results next year. But the message we are getting while we're doing this evaluation is that we have to be balanced here. We cannot focus on people who have a problem with gambling. We have to focus on the entire population and respect people's freedoms to gamble as and when they wish. So we are supposed to be able to find this balance. Where this balance lies is, perhaps there is somewhere about the balance, but I am not sure where it is. Did you want to say something?
Oh, just very briefly, no, Martin. We need to do more. I think we need to be making the case loudly, continue to make a case loudly. Gambling kills. We know it kills. We need to do much more. We need to continue, fight the industry, and can always fight the industry.
Thank you, everyone. Thank you so much to everyone this morning, all the incredible speakers. Thank you so much to this audience, to everyone online as well. We've now got 40 minutes for lunch. We'll be back here at 1:30, where we've got some more amazing speakers this afternoon. So have a great lunch. Thank you.
Hi everyone, can I please have your attention? If you could begin to make your way into the shape room. Yeah.
Hello everyone, if we could have your attention, if we could make our way back to the shape room, please and thank you.
Do start having a look at this Menti question, which we'll start with. Welcome back, everyone. Do start having a look at this Menti question, which we'll start off with. Oh, is it not working? The Menti question isn't working, apparently. It says it's out of time, someone says. This isn't working, apparently. Is it working for anyone else? No, not for you. Not for anyone else. Got no answers yet.
You should put your name before you're gonna.
We could just do a show of hands, to be honest. Should we start by doing that? Welcome back, everyone. I hope you all had a lovely lunch. We've got some really amazing speakers this afternoon. Apparently the Menti is working now, so have a look, see if it is. If not, we'll just do hands up. So we're just going to start, before I introduce the next speaker, we're going to be looking at the question, do you think physical and mental health are treated equally in policy? I think I might take a wild guess at what people are going to say here, but I can't see the answers yet. When does it come up? So while we're waiting, I'm going to introduce our next keynote speech from Chris White, who is Citizenship and Participation Officer at the brilliant Mental Health Foundation, who's going to talk to us about the right to good physical health. And very quickly, before we start, we've got a countdown to look at what the results are going to be.
So now we can vote.
Oh, now everyone can vote. Sorry for that. Is it working? Yeah. Okay. 35, no. Be very interested to hear from the person who does think that it is. Genuinely interested, because I think there is definitely some nuance in it, but maybe we'll come to that in the questions. So for now, over to you, Chris.
And I'm just waiting for the presentation to come on. If we... There we go. So yeah, my name's Chris White. I work for the Mental Health Foundation. I don't know how the next 15, 20 minutes are going to go. Thanks to the conference organisers, let's put the person on straight after lunch to lift the mood, who 12 months ago was still in stroke rehab. So we're kind of into that part of the day where I'm supposed to kind of get your minds back engaged at the point where my brain is about to disengage. So we'll just kind of see how that goes. One of the things that I got as part of my rehab, I was quite insistent on this, was I got my rehab team to build in public speaking. So if today goes well, that's because of my hard work. If it's a complete failure, we can just put that down to another NHS failing. It'll be fine. When I was walking down here today as well, I was thinking about the historical context of where I was walking by and this building. So I walked down past the National Portrait Gallery, and I was reminded of two really big social and philosophical questions in the 1830s Victorian England. One is an 1829 essay called Sign of the Times, which was an essay by Scottish essayist Thomas Carlyle, who's a bit of a controversial character. But actually also the British Academy are cataloguing all Thomas Carlyle's letters, Thomas and Jane Carlyle's letters. I actually own the cottage next door to where Thomas Carlyle was born, which is quite interesting. But one of the other big philosophical concepts that occurred in the 1830s was the conditions of England question. Now, we might not be familiar with that term, but we're certainly familiar with a lot of the works that come from that term. Charles Dickens, George Eliot, Charlotte Bronte, a lot of their novels contained a lot of the social and economic discussion of the conditions of England question. When I was thinking today, and I was kind of thinking, have we really moved that far on from the conditions of England question? So I'll pause that thought with you. But what I want to cover today is a little bit of my lived experiences. I use experiences because there are many. Health disparities and social inequalities that come from that, and then, what are the opportunities for creating change? So when I was thinking, poor physical health is a major human rights issue, a major social justice issue for those people who have experienced a significant mental health episode, illness in their life. Andy Bell earlier on spoke about life expectancy for people with a serious mental health condition can be reduced by 15 to 20 years. Now, that's not because of suicide, which is a major factor that we have to consider, which the speakers before lunch did very, very well. But the major cause of that 15 to 20 years is physical health conditions that should be preventable but are not being prevented for people with a serious long-term mental health condition. some of the figures there for the general population. 5 times more likely to have for liver disease to be the cause of death. Almost 5 times higher chances of dying through a respiratory disease. 3 times higher for cardiovascular disease, and twice as high for cancer. All of these things we should be able to reduce and impact, and have done in the rest of the population. So just starting off with that to focus our minds. I was born in 1966 in a northern town in England, where people were used to low wages throughout the 1970s, strikes, unemployment. My childhood was really challenging for a lot of reasons that I won't go into. I went to a school that didn't see any expectations of any of its pupils going to university. And I don't know anyone at my high school who went to university. That was the expectation that we were brought into. As a young adult, I was struggling. I didn't have those life skills that we're supposed to have as we move into adulthood. So smoking and drinking became habitual, became problematic, became my sources of hope. Those kind of things that momentarily gave me a good feeling that has a really, really steep cliff afterwards. By my mid-20s, I had my first psychiatric hospital admission, following a suicide attempt. And that was the pattern for the next few years. I will say, for the last 25 years, I've been in recovery and have a good recovery. I am married. I have a daughter who's just turned 18. And in terms of mental health, that's a really positive story to hear. And we could finish on that point. And often when we talk about recovery, we do finish on that point. However, for people like myself that experienced a mental health condition, that can lead to significant differences in later life in terms of our physical health. My mental health journey has been positive, but it's crucial to recognize the connection between that journey and some of the physical health concerns that I had once I turned 50. In 2016, I was diagnosed with type 2 diabetes. In 2020, I was diagnosed with a heart condition and needed open heart surgery. Quite quickly after that, I lost a right. This is a bit of a disaster. Shortly after my heart surgery, I lost a right kidney. It's fine, you've got 2 of those, you can lose one. Losing the other one's going to be problematic. And then 12 months ago, I had a major stroke. Thankfully, I was in work. I was back at work at the time, and colleagues recognized, and we were close to a hospital. We were within 10 minutes of a hospital that had a major stroke unit, which really, really kind of helped in terms of recovery. But we all have this access to quality physical and mental health care. Interestingly, people felt that there was a disparity between how physical health is treated and how mental health is treated. Just a show of hands on this one. Are people with a mental health history given the same access to physical health care as the rest of the population? If you think yes, can I have a show of hands? Okay, so can I have a show of hands for people who feel that if you have a significant mental health condition, your access to physical health care is limited in some way? So for those who haven't looked around the room, nobody put their hand up to the first question. About 2/3 of the room put their hand up to the second question. People with a mental health condition are not given the same access to physical health care as the general population, which maybe explains that 15 to 20 years difference in life expectancy. Having a mental health condition can have significant impacts on our health. It can affect how our bodies function, how physiologically we process things. Fatigue is quite common, and fatigue, digestive issues, sleep disturbance are common symptoms with a whole range of mental health conditions. And again, that can affect how our body reacts. Medication, certain types of medication can cause weight gain, giving an increased risk of diabetes or cardiovascular disease. Depression has been linked to higher levels of inflammatory markers in patients' blood. And anxiety can significantly impact our gastrointestinal health. We know those things to be fact. However, there are also systemic factors that we have to consider. We know that there are differences in healthcare quality, meaning that some people lack access to basic services, making it hard to find treatments or understand next steps. Others may face delays in diagnosis or have symptoms ignored, overlooked, dismissed because of their mental health issues. Mental health and physical health services are often treated in separate areas, and there are no clear pathways, particularly if you're in a psychiatric hospital and needing physical health care. The physical health care pathways are difficult to navigate for healthcare professionals, let alone you as the patient. And there are challenges in managing coexisting conditions. There's the fear and judgment, stigma impact, fear and judgment of others, and those negative feelings that we can have about ourselves. They can cause delays in how we access or how we approach help-seeking services. And then there is the socioeconomic impacts of living in poverty, having inadequate housing. It can make it much harder to have access to cheap, healthy food. It can make it difficult to stay active. When the slide was on earlier on about protective factors around mental health, and it said access to green spaces and nature, I wanted to add the word access to safe green spaces. People living with inequalities don't always have access to safe green spaces. Some of our green spaces are extremely threatening and violent for people living with inequalities. when there isn't enough money for resources, that creates an unfairness in the system. I was looking at Glasgow, and the same is true of lots of major cities. The richest areas of Glasgow are within 15 minutes of major physical healthcare health settings, A&E units, hospitals. The poorest areas are at least 35 minutes away if you had access to a car from those same facilities. The way that we allocate resources, there is a misaligned resource allocation. We also tend to build our interventions around what works for people who are relatively engaged with healthcare systems, generally white and middle class. And then we wonder why those interventions don't translate to marginalised communities. Again, just coming back to 15 to 20 years fewer life, and for people living in the most deprived areas, 10 to 15 years earlier than people living in those most affluent areas. Again, remind people of that conditions of England question. Have we really changed in how we address those social determinants? For too many people with mental health conditions, experiencing preventable long-term physical health conditions is often described as a lifestyle choice. I have an issue with describing health conditions as lifestyle privilege, as being around lifestyle. For some people, if you are affluent and have access to resources and funds, then you can make lifestyle choices. For people living in adversity, those choices don't exist. I've got just under 1 minute left, so just creating some of those opportunities, looking at what accessibility, holistic approaches to healthcare look like. How do we build trust for people who have lost trust with the healthcare system? What does co-design, delivery and implementation look like? And how do we improve health information and literacy so that it doesn't feel as though I'm being preached to and told what to do by someone who has a level of privilege that I didn't have access to? And how do we activate public health interventions and policies that address the underlying social determinants of health? We too often blame individuals when actually we live in a system that doesn't support good health care for people with mental health conditions.
Thank you, Chris. I'm always so shocked at how often people are sort of told to choose between their mental and their physical health, and just how much of an inequality it really is. So thank you for talking us through that. I've been told I absolutely have to keep to time this afternoon. So we have 2 minutes to ask one question. If there is one person who would like to ask you one question. Sorry, Chris.
Yeah.
I've scared everyone. Sorry about that. Amazing.
Thank you so much, Chris. That was really interesting. I guess for me the question is, and particularly for children and young people, because we know that there is there are coordination issues with children and young people's mental health services and primary care as it relates to, and it won't surprise you if I say those affected by domestic abuse. I guess my question is, when there is so much complexity around that, where it sort of interfaces both mental and physical health, how do you cut through that? Where should we begin in terms of really resolving these coordination issues?
I think for me, and you kind of raised one of the points around this earlier on today, of our standard answer to complex issues is let's do nothing. And I think it comes to that issue of we generally design interventions around using people who are engaged with the healthcare system. We need to start looking at how we better engage communities who are not engaged, who have lost faith, who do not see interventions that are appropriate to them, whether that's economic, whether that's cultural, whether that's for other reasons. Communities hold solutions, and we often try to impose solutions on communities that don't work.
Here. Thank you so much, Chris. Really interesting speech. Thank you.
Thank you.
So we're now going to move on to looking at eating disorders. What we'll do is, for everyone who is speaking, there'll be someone either at the back or me at the front just flagging when there's 1 minute to go, just so we do keep to time. So, can I now introduce our speakers, Dhriti Mandalia, who's the Senior Researcher at NatSen, to talk about prevalence trends, and then Professor Tamsin Ford, who's Professor of Child and Adult Psychiatry at University of Cambridge.
Hi everyone, I'm Dhriti. I'm a Senior Researcher in the Health and Biomedical Surveys Group at the National Centre for Social Research. In collaboration with the Office for National Statistics, the University of Cambridge, the University of Cambridge, we conduct the Mental Health of Children and Young People survey series, which some of you may be familiar with. So today I'll be presenting findings on the prevalence and trends of eating problems and eating disorders from the latest published report, so that's the 2023 report. And I'll also provide a very brief snapshot of how the survey worked and just focus on a couple of the key findings in the 10 minutes that I have. So as an introduction, the Mental Health of Children and Young People survey series is England's official statistics on mental health of children and young people. The follow-up surveys are part of a series of surveys which were where the data was first published in 1999, 2004 and 2017. These surveys were national surveys conducted face-to-face in participants' homes. The 2017 survey, which is considered the baseline survey, achieved a sample size of over 9,000 children and young people aged between 2 and 19. And this sample group was subsequently followed up in a series of online and telephone surveys in 2020 and 2021, where we examined the lives of children and young people during the pandemic. The follow-up surveys continued in 2022 and 2023 to assess life after the pandemic and its impacts. The follow-up surveys are quite unique in that they utilise consistent, reliable and robust methodologies to measure the prevalence of mental health disorders among this population group. And just to say here that all our survey findings are weighted and calibrated to ensure that the results are representative of this population group. So let's take a brief look at the survey series. So this is just a very quick snapshot of what we did during the surveys. So to ensure representativeness, the baseline survey in 2017 was drawn from the NHS patient register, which is held by NHS England. So all our participants that took part in the 2017 survey were asked whether they would like to take part in future research projects. So those who continued to agree to be recontacted for the follow-up surveys were invited to take part. And data for the follow-up surveys were collected online or over the telephone. In 2017, the mental disorders were identified using a tool called the Development and Wellbeing Assessment, or DORBA. And across all the surveys, our main measure of mental health was the Strengths and Difficulties Questionnaire, or SDQ, which my colleague Ziska will be giving some details on that. These measures provided a consistent, robust measure of mental disorders in the population across all the surveys. It's also worth noting that as the children and young people in our sample have aged each year, the age groups analysed in the reports have also changed. So what this means that in the 2022 report, we looked at 7 to 10-year-olds, and as this sample has aged a year on, in the 2023 report, we are looking at 8 to 10-year-olds. And just to flag, over the course of all 5 surveys, just over 1,200 children and young people have taken part in all of the surveys, enabling the potential for valuable longitudinal analyses. So I'll now move on and talk through the survey findings. So this is from the latest published report in 2023. I'll firstly start off with possible eating problems in children and young people. So how did the survey actually measure a possible eating problem? How do we actually define this in the survey? So the survey took a multi-informant approach in that we approached young people aged 11 to 25, parents of children aged 8 to 16, who then went on to complete 5 screening questions from the Development and Wellbeing Assessment Tool, or DORBA, Eating Disorders module. And screening positive for a possible eating problem was defined as answering yes to 2 or more items in the DORBA where a parent was reporting on behalf of the child, or answering yes to 1 or more items where the young person was reporting on themselves. And I just have to flag here and stress that screening positive on the DORBA Eating Disorders module does not mean that the child or young person had a clinically impairing eating disorder such as anorexia or bulimia. It kind of just indicates the increased likelihood of broader problems or difficulties with eating, which we refer here to as an eating problem. So just moving on to a couple of the findings. So this chart shows data on children and young people screening positive for a possible eating problem from 2017 to 2023, and each of the survey years are represented by a different colour on the bar chart, with estimates for secondary age school children shown on your left and for young people shown on your right. And what this chart clearly shows us is that for all age groups, as you can see, girls and young women were more likely to have a possible eating problem than boys or young men. And also we can see that the prevalence of a possible eating problem rose between 2017 and 2021, with rates remaining pretty much stable between 22 and 23. And if you now look at the responses to the 5 individual screening items in the DORBA eating disorder module, this chart shows estimates for 2017 and 2023. And what we found in 2023 was that 27.9% of children had parents who said that their child had ever thought they were fat when others said they were thin, compared to around 23% in 2017. We also found that children in 2023 were more than twice as likely as children in 2017 to have parents who said that worries about eating really interfered with their lives. So moving on to young people, so that's young people aged 17 to 19, we found that young women were 3 times as likely as young men to say that they had ever thought they were fat when others thought they were thin. And young women were also 3 times as likely as young men to say that if they ate too much, they blamed themselves a lot. So this is about 54.9% compared with 17.9%. And we also found that young people in 2023 were more likely than those in 2017 to say that if they ate too much, they blame themselves, and also worries about eating really interfered with their lives. So moving on to eating disorders. So when we refer to an eating disorder in the survey, what we mean by that is an eating disorder is a clinically impairing, diagnosable condition such as anorexia or bulimia, which is classified in this survey under the International Classification of Diseases version 10 we used in the survey. So children aged 11 to 16, their parents, and young people aged 17 to 25 who screened positive on the DORBA were invited to complete the rest of the DORBA eating disorders module. And responses to those questions were reviewed independently by a small team of clinical raters who then assigned diagnoses based on the ICD-10 criteria. And just a couple of findings to show you around eating disorders. So this chart shows the prevalence of any eating disorder for boys and young men and girls and young women, and it's split by the different age groups. And what we found in 2023 was that 2.6% of 11 to 16-year-olds and 12.5% of 17 to 19-year-olds had a clinically impairing eating disorder, with prevalence 4 times higher among girls than boys, and also more common in young women than in young men. And in the oldest age group, so that's those aged 20 to 25, rates of eating disorders were around 5.9%, with no significant differences between young women and men. And you may be wondering about the types of eating disorders found in our 2023 survey. So just to give you an idea, for 11 to 16-year-olds, less than 1% met the criteria for anorexia and bulimia. For 17 to 19-year-olds, this was 3.3% and 1.7%. And for the older age group, so that's those aged 20 to 25, the equivalent estimates were 0.3% for anorexia and 1.8% for bulimia. Okay. So that's just a very brief snapshot of some of the findings from the latest 2023 published report. There are many more findings and information available about the methodology of how we did things to assess eating disorders in the published report, which we've linked on the slide there. If you would like to access the data, currently you can access the 2017 to the 2022 data sets, which are available via the UK Data Service under special license, so they're available and you can access the data. We are in progress with putting the 2023 data set together, and that should be available very shortly. So please do have a look at the reports and data. Thank you very much.
So, hello. I'm going to reprise and expand a bit of this work on eating disorders. And as earlier, I'm Tamsin Ford. I'm a child and adolescent psychiatrist from the University of Cambridge. So there was a sudden increase that was global in presentations of children with eating disorders across the world. But presentations don't necessarily mean a change in prevalence. So when we set out to do this systematic review, which was led by Clara Farrier, who is a junior doctor also training in research with me in Cambridge, we were hoping to be able to stratify our findings pre and post-COVID. In fact, the only post-COVID survey is the one that you've just heard of. So that's not terribly helpful. Anyway, there is a preprint available of this systematic review, and I'm quite happy for people to have the slides to get a link to it. So we searched Ovid, Embase, PsycInfo, and Lilacs for papers in English that reported the population level prevalence of eating disorders in children and young people from January 2013 up to the end of February in 2024. Our primary outcome was the overall prevalence of any eating disorders, but if there were subtypes like, say, anorexia or bulimia reported, we extracted those. We did a random effects model for the meta-analysis, and we assessed quality as well. And we found 15 studies, including over 68,000 children and young people from 11 countries that went into the systematic review. We were only able to meta-analyse data from 12 studies, and that was nearly 57,000 young people. In terms of quality, I have seen worse, but only 9 studies were low risk of bias. 1 was moderate risk of bias, and there were 5 that were high risk of bias. And in fact, the heterogeneity between studies was extremely high, and that's probably about the way samples were taken, the age ranges, different diagnostic systems, and different diagnostic assessments. Coming to the crunch point, the global point prevalence of eating disorders was approximately 5%. Confidence interval went from 0.4 to just over 10%, so it shows it's fairly imprecise. And the commonest type of eating disorder, I think is really interesting, is the other category, which actually made up 90% of the cases reported. So we really need to think about how we describe different types of eating disorders. I'm not an eating disorder expert, but if you speak to people who are, they will say that kids and adults change through different types of eating disorders. But bottom line, these people had very disordered eating, and it was impairing their lives. So coming back, you've already seen this diagram, but I've added on this bit. So in 2021, because the screening items you've just seen reported, those 5 items, they are designed to scoop up anyone who might have a problem for more detailed questioning. So they do a really good job of that when we've got screen negatives and screen positives. The diagnostic accuracy is very good. But as a measure of who has an eating disorder, it's not very good because it's scooping up everyone who's got a problem, be it really severe and impairing eating disorder or not a problem at all. So we wanted to put on the rest of the Dorber module, but we didn't know whether we'd be able to do it. When we first did the first follow-up during COVID, actually, there were 2 routes of financing that. One was a grant that I led with NatSen, ONS, and NHS Digital, as then were as partners. And the other was the more traditional way these surveys are funded, which was through the government. So this was part of the research funding. It sort of became a feasibility study. For various reasons, it took about a year before we could contact people, but in a way that was a happy accident because it meant we could look at the persistence, if you like. Of course, it's not persistence because we got 2 time points and we don't know what happened in between. But actually, I think it's very telling that 77% of those who screened positive in 2021 screened positive again in 2022. So these are not necessarily trivial, even though some of the questions might seem trivial, and I'll come back to them. The other really interesting thing is there were many more young people reports of screening positive than parents at this follow-up. So we had parents reporting on the under 10s, and there were just too few of them to report here without risking disclosure. Young people reporting from age 11 up, so that group in the middle, the 11 to 16s, we often had both reports. The proportion of screen positives increased with age, which is what you'd expect. The incidence of eating disorders increases into the mid-teens. But to give a handle on the numbers that you've just seen presented beautifully by Driti, only 16% of these people who screened positive had an eating disorders. Now, that's not a prevalence, that's of this sample that we were able to follow up. You've seen these questions. The reason I'm putting this slide up again, so this was between 2017 and 2023, is to highlight the questions. I would argue that if someone reports that they've made themselves vomit, that is always a problem. And that is rather different in nature from reporting that you feel fat when other people say you're thin. That's still not necessarily healthy, but it's actually so common, particularly amongst young women, that it's almost no use. The green circles are to remind me that those are the symptoms or screening items that were statistically increased. So young parents were more likely to report their child felt fat, that they had worries with eating that interfered with their life. Again, I think that's serious. And that if they eat too much, they blame themselves. With the older teenagers who are now reporting on themselves, in fact, all but the one symptom of feeling fat increased significantly. So we wanted to be able to take these rather small samples. I mean, I'm tremendously proud of MHCYP, all three of the surveys, and we should be, actually. In terms of epidemiological studies, they are some of the best in the world. They are single phase with a multi-informant diagnostic assessment that's clinically rated. So they're really high quality data, but they weren't set up to be longitudinal. And because of that, inevitably, there was quite a lot of attrition, and that doesn't give you much data to be able to look at small and marginalised groups like those who are gender diverse or people from ethnic minorities. So some of you may have heard of the Oxwell survey led by Mina Fazal from the University of Oxford. It's a series of cross-sectional surveys that are completely anonymous. They do ask youngsters, did you do it last year? But there's no way of tracking back to individuals, so you can't follow people longitudinally. And she has schools pretty much all over England, but often in clusters. So there's a big cluster around Liverpool and the Midlands because she's in Oxford. There's a huge cluster around Oxford that join in. So we put the Dorber items into Oxwell, the Oxwell survey, and as you'll see, the numbers with usable data were huge, 23,000 children, of whom more than half endorsed at least one item, and approaching half endorsed two difficulties with eating. We then use how the screening items function in terms of predicting to having a disorder in the 2017 survey to try and get a population estimate which we have weighted up. So this is mathematical, this is not a precise diagnosis. To estimate that the diagnosis was 1.7 of the 11 to 17-year-olds. Now, that might not sound very dramatic, but the 2017 estimate for the population was under 1%. So it's kind of a doubling, and a doubling of children who need help. And eating disorders kill. People can and do recover from them, but they can be very severe, and they're nasty, and they often persist. That is very worrying. I won't go into details about that, but just to say, transgender or gender diverse young people and girls have much higher difficulties with eating than boys, and I have similar data from Oxford showing the same for self-harm. That's a different way of presenting the same thing, but also there are some interesting things with ethnicity. Now we've got a sample that's big enough, and some of these areas are very diverse where the data comes from, to be able to look at it. And I'll just say thank you for your attention.
Thank you so much, Tamsin and Driti. So much data in there showing some really, really important statistics. I'm wondering if anyone has any questions, because I definitely do. So while we wait, oh, we've got one. Thank you.
Yeah, in your slides, Druti, I saw that 17, 18 and 19-year-olds were kind of picked out as a particular group as opposed to the two groups either side that had bigger ranges. I just wondered if you could say more about kind of perhaps why those 3 years were picked, and if possible, about perhaps why there's a higher prevalence in that age group of the particular issues.
Can you hear me? Yeah, thank you. Tamsin, you might want to add to this, but because we were comparing back to the 2017 survey, the 2017 survey the sample ranged between 2 and 19. So we were comparing back the same age groups from the 2023 survey back to the 2017 survey. So we've got comparability in terms of the age groups that we were looking at.
Thank you. Any other questions? Yes.
Just a quick one. I think I've asked you this question before, Tamsin, which is obviously your screening questions need to be very sensitive so that all those people are examined by the clinical raters. But there is the risk that people will deny at that initial stage, and so you miss out on, you've got false negatives. Have you done any work to look at that, or any other approach to that?
Yes, actually, if you look in the technical report for the 23 survey, where actually instead of being a whole separate study, the eating disorders diagnostic assessment, we just used that module, and we, as far as we could, repeated what we did in 2017. In fact, some of the raters were the same people. We did get some screen negative. We asked a random sample of screen negatives to fill them in. I have to say they were a joy to rate. It is not healthy to rate 1,000 people with eating disorders. It's quite a relief when you have something more simple to think about. We did find a couple who then it emerged, and that's one of the reasons why there is a difference between the young person cut point, where if they endorse anything, we scoop them in for more questions, as opposed to raising the cut point to 2 for parents. So it's not perfect because no screening measure is, but it's, the negative predictive value is very, very high. It's in the high 90%.
Thank you, Terry. So I just have a question, thinking about the questions asked as part of this conference around implications of the research for practice. Is there anything in the data, maybe as part of this or any other, that you've seen around any kind of treatment gap growing, or anything about, the numbers of people experiencing eating disorders is growing? What about those who are being treated? Is there a treatment gap opening or closing, or sort of staying the same?
One of the reasons we pushed hard to do this was because services were suddenly inundated. And the question then is this because during COVID, people who were known to services decompensated and needed more input, or perhaps weren't as able to get early support, so things got worse and they needed to come in, or is this a population shift? And I think what we've demonstrated is a population shift. What has happened in the interim to referrals in this country is they shot up, services absolutely buckled, but they've clawed their way back. So the rate of referral has not dropped back to pre-COVID levels, but it's dropped back to a bit, and services are coping magnificently. I think they've really risen to the challenge. But the challenge for services and for all of us is that eating problems, but also eating disorders, are more common in our population, and that's really worrying.
Thank you. Really, really interesting. Are there any other questions? Well, thank you so much, Druti and Tamsin. Everyone, round of applause. So now we're moving on to the section where we look at mental health through a life course. So I'm really pleased to introduce Francisca Marcheselli, who is Research Director at NatSen, who'll be talking about trends around CYP mental health, followed by Kadra Abdissinair, Kadra, I've completely mispronounced that, who's the Associate Director of Policy at the Centre for Mental Health, who'll be talking about a roadmap for action. Do you want to come up?
Okay,
Okay, thank you, Lucy. Hi, everybody. So I am Francisca. I work. I'm sorry, I just need to change this. There we go. So I work at the National Centre for Social Research. I've been part of the Mental Health of Children and Young People surveys since 2017, and I'm here today to provide some of the evidence on what the current state of children and young people's mental health is in England and how this has changed over time. So this is the same survey that my colleague Driti just talked about with regards to the findings on eating disorders. So I'm just going to be touching really briefly on how we measured mental disorders in the survey, and then it's also going to be another stats-heavy presentation, and I'll give you some of our key findings from this survey. So how did we measure mental disorders in the survey? As Driti mentioned, in 2017, the main measure of mental disorder used was the Development and Wellbeing Assessment, the DORBA. So the DORBA is a package of interviews, questionnaires and rating techniques designed to generate ICD-10 and DSM-5 psychiatric diagnoses on children and young people. It covers a huge range of disorders, and each module covers a lot of detail. Due to the nature of the DORBA, it wasn't possible to include that again in the follow-up studies, as it wouldn't be suitable for an online and telephone approach. However, the 2017 survey also included the Strengths and Difficulties questionnaire, otherwise known as the SDQ, and this is the main measure of mental health that has been used in all 4 of our follow-up surveys, and therefore allows us to compare results with 2017. So just a little bit about the SDQ. It's a behavioural and emotional screening questionnaire that contains 25 questions on the child or young person's strengths and any difficulties with peer relationships, emotions, behaviours and hyperactivity. Parents in our sample were asked to complete the SDQ about their child. Children aged between 11 and 16 self-reported, and so did those aged 17 and over. And then the SDQ algorithm combines all of these responses on symptoms and impact, and depending on the scoring, it then estimates how likely a child or young person is to have a possible or probable mental disorder. And all the estimates of probable mental disorder that we present in our reports from all 5 surveys are based on this same algorithm. So I'm now going to show you some findings that look at the prevalence of having a probable mental disorder and how rates of this have changed over time. These are cross-sectional analyses that I'm showing. So due to the fact that our participating sample have got older each year, as Driti mentioned, we're only able to compare findings across the years for 8 to 16s and 17 to 19s. Okay, so there's quite a lot of information in this chart. So the left-hand side of the chart, this side, is showing us children, 8 to 16-year-olds. And on the right-hand side, I'm showing you the 17 to 19-year-old rates. So for both age groups, we saw an increase in rates of disorder between 2017 and 2020. So you can see it increased from 12.5% of children in 2017 to 17.1% in 2020. And for young people, this increased from 10.1% to 17.7%. For children beyond 2020, rates of a disorder have since remained stable, and we didn't see any increases or decreases that were significant. However, for the 17 to 19-year-olds, we saw another increase from 2021 to 2022, and this increased from 17.4% to 25.7%. So that's around 1 in 4 17 to 19-year-olds having a disorder. And again, we saw that continued higher increase in 2023 at 23.3%. So it kind of marries up with some of the findings that Mari and Sally have spoken about with the younger adults. To look at it in another way, in 2017, 1 in 8 children aged 8 to 16 had a disorder, and in 2023 that had increased to 1 in 5. And for young people, 1 in 10 had a disorder in 2017, and by 2023 this had doubled to 1 in 5. So really quite stark increases there. So I'll now talk about some findings that are specific to the latest follow-up survey in 2023, when the participants were aged between 8 and 25. So in 2023, we found about 1 in 5 children and young people had a probable mental disorder. Again, there's a lot of information here, so I'm showing you rates by both sex and age group. So the dark blue is showing boys and young men, light blue is showing girls and young women. If we look at all 8 to 10s and all 11 to 16s, we can see that it was more common for 11 to 16s to have a mental disorder than the younger age group. And rates of a probable disorder were similar between boys and girls in both age groups. However, when you look at the older age groups, we can see that rates for young women were approximately twice as high as they were for young men. So for example, in the 17 to 19-year-olds, 31.6% of young women had a probable disorder compared with 15.4% of young men. So these findings show that young women in particular are a high-risk group. So as well as collecting the SDQ, the surveys asked a wide range of questions that cover different topics throughout each year. And I'm just going to show you a few that I've selected today. So we also asked children aged between 11 and 16 whether they'd been bullied and whether that was either in person, online or both. In total, about 1 in 6 children reported they had been bullied in person in the last year, and 1 in 20 had been bullied online. When we compared children with a disorder against those who were unlikely to have a disorder, they were much more likely to report any form of bullying in the past year. So you can see from this chart, they were 5 times more likely to have been bullied in person, 4 times more likely to be bullied online, and 7 times more likely to have been bullied both in person and online. In these surveys, we also asked a couple of questions on self-harm. We asked parents whether their child had spoken about harming themselves in the past 4 weeks, and also whether they had tried to harm themselves in the past 4 weeks. And we also asked this to young people aged 17 and over. We found that children and young people with a disorder were much more likely to have tried to self-harm in the past 4 weeks. So that's 10.6% of young people with a disorder, compared with 0.8% of those unlikely to have a disorder. We also asked about help seeking, and this included both formal and informal services. So out of parents who were concerned about their child's mental health, 3 in 4 had sought help or advice, and the most common sources of help was through education services. And out of young people who were concerned about their mental health, half had sought help, and the most common source was family or friends. The next most common source was using online or telephone support, which highlights the ways that young people access help will most likely be through their phone or online. We also asked a set of questions about people's financial situations and circumstances due to the cost of living crisis. And we found that children with a disorder were more likely than those without a disorder to have parents who couldn't afford for their child to take part in activities outside of school, couldn't afford to buy their child the right clothes and equipment for their daily life, and also couldn't afford to have access to transport. And they were also more likely to have a parent worried about money. And similarly, we asked a similar set of questions to the young people about their own financial situations, and it was a similar story. So those with a probable disorder were more likely than those unlikely to report not being able to afford taking part in activities, having the right clothes and equipment, and also being more worried about money. Okay, that was a super quick snapshot of just some of the findings that we've collected over the years. It's a huge, huge range. This is the same slide that I've taken from GTs, just to again plug the data sets, how valuable they are, really rich data sets. So please do some secondary analysis, access them. They're on the UK Data Service now, which we're very pleased with. It's been a bit of a journey to get there. And 2023 data set is also going to be available soon. And as Driti mentioned, the reports are again, they're online and there's much more detail in there. Thank you.
Good afternoon, everyone. I'm Kadra Abdinasar from Centre for Mental Health. I'm really pleased to be here with you all, and it's been amazing just hearing from such epic speakers today. So thank you, everyone who's gone before me. And thank you also to NatSen and British Academy for organising today. So I'm going to be talking about Future Minds, which is a national campaign that is making the case for urgent and sustained investment in children and young people's mental health. Andy already told you a little bit about who we are, so I'm going to skip this slide. So Future Minds is a collaborative campaign that we launched in February of this year, working with our partners at Young Minds, who are in the room somewhere, Centre for Young Lives, and the Children and Young People's Mental Health Coalition, which we're privileged to host at the centre. The campaign is also supported by a philanthropic funder called the Prudence Trust, who are dedicated to improving mental health outcomes for children and young people. And also, just to say, since we launched the campaign, we've garnered widespread support from across the mental health sector, but also from various researchers and academics who've also supported its aims. So just firstly on the challenges, and we've heard lots about the challenges in the world of mental health today, but Future Minds basically was set up to respond to a very real and growing concern. As you've heard from Francisca, we're seeing rising numbers of children and young people presenting with distress, and despite incremental investment in support and services, they're struggling to keep up with the pace and respond in a timely fashion, if you like. But at the same time, we are seeing young people's mental health slipping off the policy agenda, and this is being experienced across the political spectrum. So I know, Lucy, you touched on earlier about some of the questions we're getting about, is there an overdiagnosis of mental health problems among young people? And we're also hearing a lot of skepticisms around over-medicalizing of mental health problems, and you know, is it because young people today are not able to kind of deal with everyday challenges because they're lacking grit, resilience, or as one politician put to us recently, they lack bounce back ability, whatever that is. But actually, no, I think you've heard consistently today that the data is telling us that rising prevalence is real, and it's not unique to young people in the UK. But what is unique is actually the political choices our government takes to act or not act. And I guess another point I wanted to make, the effects of this are felt far and wide. So we know that the impact of mental health problems that aren't addressed in the education system are playing out in some of the debates around non-attendance, where mental health is cited increasingly as a factor. Lots of conversations around youth unemployment and workforce productivity as it relates to young people. And this current government also has ambitions to halve serious youth violence and violence against women and girls as well, which is laudable, but you have to think about providing mental health support as well within those contexts. And, you know, yeah, with all of this in mind, economic pressures are what they are, and the government is dealing with this, but it makes it harder for them to act decisively. And some of the questions we're getting back is, you know, where would funding be reallocated for if it were to go into children and young people's mental health services? That's not something we're really willing to engage in. We have to support young people across the spectrum and across all services. Lastly, on this slide, I also just wanted to highlight ongoing sort of gaps, fragmentation, which Olumide kind of spoke to in her point. Postcode lottery still continues to be a feature in terms of the availability and quality of provision across the country. And of course, we can't make the changes we want to see without having the workforce in place. So we really need to address the workforce pressures that we see. So onto the sort of economic case for investing in children's mental health. The consequences of inaction are already visible in many aspects of our society at the moment. So we know, for example, lots of live conversations about universal credit, PIP, and the social security system. Mental health is now a key factor behind, you know, the projected rise of the welfare budget, which is looking at 29 billion for disability benefits relating to working age adults over the course of this parliament, and young people are being, you know, overrepresented in some of those increases there. I think from our perspective, this really reflects systemic failure to prevent mental ill health and provide timely support. So rather than contributing to stigmatizing narratives we're seeing at the moment around benefits and social security, we should really be working towards creating a society where everybody's basic needs are met, including their financial security as part of this. And then using some previous figures from UCL and the Institute for Fiscal Studies, my much more clever colleagues crunched some numbers and adjusted for inflation and all of that. And they estimated that childhood mental health problems, if left unaddressed, could cost £1 trillion in lost lifetime earnings across a generation. And I understand that this is even a conservative figure, so really making that case for investment in early support. And some of the analysis also shows that school absence, as I mentioned, relating to mental health, is now costing over $1 billion each year. What we're asking for in terms of investment is a drop in the ocean compared to some of these figures. Yet mental health services, we know, receives just 9% of health spend, and children and young people's mental health is even a fraction of that. So it still sadly continues to be the Cinderella of Cinderella services. Far too often, I hear from young people I speak to that they only get the support they need once their needs escalate or they reach crisis point, and this is even more pronounced among young people facing inequalities, as has been a bit of a theme today. Yet the evidence tells us early intervention can make a huge difference in children and young people's lives, and is far more cost effective. So I think I've got a stat here. Community-based support for young people is up to 100 times more cost-effective than inpatient provision. So we're not just talking about moral imperatives here. There's actually a really clear, concrete economic case for early intervention. Having said all of that, there are a number of opportunities that are currently underway. So in June, we had the comprehensive spending settlement, which apparently the NHS did supposedly fairly well out of that. I think there's still detail being agreed, and we're really pushing to make sure that children's mental health gets its fair share of the slice. There's a number of long-term strategies that the government is also developing at the moment. So last week, I think it was, there was the 10-year health plan that was published. We also have a child poverty strategy and a youth strategy, which will seek to take a long-term view. There is a risk potentially that children's mental health can fall through the net. So, we do appreciate the government's sort of mission-led approach, and we want to make sure that mental health, children's mental health, is really properly considered as part of these initiatives. We also have some legislative opportunities, so the Mental Health Act, and we've been doing a lot of work to make sure children and young people's voices are reflected in that, but that crucially we also seek to expand provision in the community, and that also relates to children and young people struggling with issues such as eating disorder, because we know there's huge sort of pressures in the system there. We've got a children's wellbeing and schools bill, and there's a sort of mass campaign at the moment looking at embedding wellbeing measurement within the education system so we can better understand trends. Oh, 2 minutes. All right, let me move on to our policy asks. So we've got 6 clear evidence-based policy asks, and these were areas we identified where there was the most sort of compelling evidence, consensus from the sector, and where we thought that we could gain some good traction with the government. So firstly, the previous government, as part of its long-term plan, had a really wonderful objective in 2019, and that was to meet 100% of diagnosable need by the end of the decade. We are at about 39%, as we understand it, and perhaps given the financial constraints, it might not be possible in this parliament to meet 100% of needs, so we've sort of ambitiously set a target of about 70% of need. And as an example, for this year, that would require an additional £167 million going into services. But this doesn't mean going into specialist CAMs. We need to look at reform and changing the system and, flipping it so we have more community-based alternatives and are able to sort of innovate within this timescale as well. Secondly, we know that the education system plays a critical role in shaping young people's mental health. And in recent years, it's also, for some young people, been a source of pressure. So Young Minds have launched a really great campaign recently called Missing the Mark, looking at overhauling the assessment frameworks, because that causes a lot of distress for some young people. So there's lots of conversations there. But it's great to see the establishment of mental health support teams in school settings. This year, the government is on course to provide this service to about 52% of primary, secondary, and college pupils. We want that, we want the postcode lottery for that service to also end. So we're asking for 100% rollout by the end of this parliament. Thirdly, we want open access mental health hubs. So Andy mentioned early support hubs in his presentation. This is something the government has committed to as part of the Young Futures program, which means that young people can readily access the service 7 days a week, are able to immediately get advice, support, and low-level interventions in familiar settings. We want to see a really comprehensive workforce plan, supporting some of the aspirations of the 10-year plan, and hopefully we get to have a mental health plan someday soon, but really thinking about a wide mix of roles from psychiatry, counselling, youth work, peer work. And it was really great to hear from a lot of people today about the value the third sector also brings, so not forgetting about staff working in those settings. And also young people, why not create opportunities for young people to get into the mental health profession if we've got a big youth unemployment crisis? We really need to rebuild prevention by increasing funding for councils. So we know that public health grant is, basically at the levels as it was about 15 years ago, which is not good enough. Thinking about the role of children's social services for children in care and care leavers, and lots going on at the moment around special educational needs and disabilities. And we know there's huge overlaps around neurodiversity and mental health for young people. And finally, we've been calling for an independent commission, a rapid review into what the drivers are behind the rising prevalence of mental ill health amongst young people, because there's a lot of speculation at the moment. Is it social media? We hear from some young people how much of a force for good it is in their life. Can we actually explore what this looks like, but crucially put young people at the heart of that? And I just wanted to flag that next Wednesday, our friends at Young Futures Foundation and University of Manchester, they're going to be publishing a paper looking at all the evidence base around some of this, testing a number of hypotheses, so watch this space for that. So yeah, just my final reflections on this. I guess, we really can't afford to wait to act on children and young people's mental health. The cost of inaction financially, socially, and personally is far greater than the cost of investing today. And if we want to see a healthier, fairer, and more productive society, we must treat our children and young people and their mental health as a national priority, not a secondary concern. So thank you for listening, and happy to take any questions.
Thank you so much, Kadra and Francisca. I think that was such a good double act of being able to hear the prevalence and look at the data, and then what practically really needs to happen. What do we need to call on government to do, and governments around the UK to do? I'm very aware that at the start of this conference, children and young people's mental health was the biggest part of that bubble. So we do have actually a really good 8 minutes for discussion. So let's open it up, see if people have questions, but also comments as well. And also if we've got any online, then let us know.
I guess this is for the last speaker. You seem to be recommending, as an approach to increasing rates of mental health problems in young people, increasing availability of treatment. You've not really mentioned prevention. I'm sure you've thought about it. What are your thoughts? I mean, given that the government is going to be promising to put more resources into this, do you have thoughts about how that might be accomplished? Because otherwise it's not clear how we're going to control this increase in rates if we're just responding, in other words, firefighting rather than, preventing.
Yeah, no, very good question. Thank you for that. I would definitely say one of the sort of big sites and initiatives that happen around prevention tend to be in educational settings. So alongside the rollout of mental health support teams, something that we want to see is the adoption of a whole school and college approach to mental health. And that really takes a more preventative lens, if you like. So looking at, the school curriculum, looking at teacher training, and beyond that, I think just in society, green spaces came up, thinking about children's access to green spaces, physical health. There's so much more, definitely, that needs to be done around prevention. So it's an area we need to explore.
And we, as Centre for Mental Health and Rethink, are part of an amazing coalition of mental health charities called the Mental Health Policy Group. We all kind of balance each other out with what we look at. We've also got the Mental Health Foundation, who do a lot around prevention. So I'm sure there's lots more that other organisations have on this as well, and I know we're talking to government about.
Can I just add one quick thing? Sorry, just to really emphasize the child poverty point. I think that is huge. So, you know, the child poverty strategy for it not to consider measures like scrapping the 2-child limit will be, you know, something that is driving poor mental health for young people in the first place. So we hope to see that included.
Thank you. Oh, we'll go here and then we'll go at the back over there.
Hi, thank you. That was really interesting. I was just wondering if there's any data or research that looks at kind of 0 to 5 in early years, and yeah, what data is being seen there, or like what trends, and then what interventions need to happen there. So kind of the early intervention and prevention side of things for the 0 to 5.
Francisca, do you? The 2017 study started. There was started at 2, so we did collect data for 2 to 4-year-olds who broke them into. But unfortunately, there isn't much data that we've been part of younger than that. I think there are other studies like SEED, study of that does start younger than that. I don't know too much myself personally, but there is 2 to 4s as in terms of 2017. I haven't reported on today, but more detail 9. If anyone else is aware of any, then let us know. At the back there, thank you.
Hi, I'm Anne Kazimierski. I'm an impact consultant. I used to work at Impact on Urban Health on a lot of social determinants of health work, including children's mental health. But actually more with my parent hat on. One of my sons had a lot of issues with anxiety and school attendance a couple of years ago. And we had definitely had some difficulties with the school threatening council fines before any mental health support, which I know is a very, very common issue. So thinking systemically, what hopes do you think we have of the Department for Education working with schools and putting the right kind of pressures on schools that enable to support children and put their mental health first before attendance figures?
Yeah, I really like that question. Thank you. I guess in recent years, and especially since the pandemic, we've really taken such a punitive approach and a contradictory approach when we're talking about well-being and mental health versus behavior and attendance, which, you know, I think we haven't really been asking ourselves, why is it that there are groups of young people who are finding it difficult to re-engage post-pandemic? And quite frankly, it's because we don't have an inclusive education system. But there's opportunities now, so we're expecting a schools white paper in autumn, where they're going to be considering a lot of these things. And we were with the department yesterday, and one of their commitments and aspirations is to better align some of their aspirations in the space. And they certainly were talking about achieve and thrive being 2 sides of the same coin in their vision. So, yeah, I think take that opportunity to feed into some of those developments, I'd say.
We have a couple of online questions. The first one says, what potential do you believe health education lessons as part of the wider PSHE, RSHE curriculum have to support and improve children and young people's mental health?
Do we have an answer to that on this panel? Or do we need to put that into the system and see if we can widen it out to other people who are here today, and then we might be able to respond? Unless, Kadri, you've got...
Yeah, I mean, I think I would say it's a positive step, but at the same time, if we don't have the support in place for young people, and if we're putting in place policies that are creating distress in their lives, what use is it to know about spotting the signs of mental distress? So that's my take on it. I think we need to take action across all those different levels in order for it to be as useful and effective to young people in their lives.
Thank you.
The second question is, well, first of all, thank you for acknowledging that neurodivergent children and young people often have not had their needs met, which leads them to crisis. Many cannot access generic services like CAMHS because those services aren't designed with their profiles in mind. Can you please ensure that your hubs will be accessible for neurodivergent children and young people? I'd like to understand how you foresee this being delivered in practice.
Yeah, so with the hubs, just to say they are already in existence. So the longest standing one in Liverpool has been around for 50 years. So we're not reinventing the wheel with a provision. The issue is that we've got a postcode lottery. So there's not one available to every child in their local area. And in fact, the Australian government saw this model, took it and adopted it as a national program. So all Australian children and young people have access to that. So we're stealing that idea back, essentially. But crucial to the model for us is co-production with young people and designing from the margin. So absolutely thinking about what access looks like for neurodivergent young people will be key.
Thank you. I think we've got time for one more question. Just here.
Thank you. Given that the surveys took place across the period of the pandemic, and looking at the data, what general lessons do you think we can learn from that sort of natural event of the pandemic in terms of young people's social lives, social connections, isolation, and so on? I'm not asking about the pandemic per se, but what do we learn of a more general kind that can be applicable, thinking about the source of the vulnerabilities in relation to mental health that have policy implications?
Well, I think it's a really, really good question, and I think it's something that we're all thinking about, isn't it? And I think it reflects a lot of the stuff on what Mari said in her presentation this morning, that ultimately we're seeing, and we've all spoken about, it's getting worse. We did ask some questions specifically about COVID and the lockdown as part of the survey. The first follow-up survey specifically focused on feelings about the pandemic, anxieties, if lockdown had made their lives worse, and the answer to that was predominantly yes. So I think there's been a lot of impact that we've seen from COVID, and how long-lasting that is, I think, still remains to be seen. Do you want to follow up? Any thought?
Sorry, what was the question again? Because I've just forgotten the last part about the pandemic.
Yeah, and impact. Do you want to cover?
Yeah, not so much the impact of the pandemic, but what did we learn from the pandemic about young people's sources of mental well-being? That's to say, the kind of connections that they have with friends, the value of a school space, and so on. Obviously, you've got internet, phones, and stuff on top of that. But just what are we learning that can be applicable in terms of preventative work? Not just looking back to explain what happened with the pandemic, but what lessons can we draw of a more general kind from the fact that this cohort has gone through that experience? Extraordinary.
I think absolutely. Well, I think, Francisca, you've answered that a lot, and I think everything you've just said answers that. And I think this is one for the break, because I think that's a very important question, where it is about what is the data showing us, and then what are the implications that we can learn from that for practice. So we are now at time for a break. We've got 15 minutes, so coming back here for 3:10. Just a huge thank you to all the speakers after lunch. After this break, will be handing over to Jo to take over the chairing. So thank you so much. It's been an amazing opportunity to chair this and speak to you in the break.
Oh, good.
Yeah, it's right.
Sorry, everyone. Hello. Okay, so we're on the home straight now, everybody. It's been a long day. Thank you for sticking with us. We're going to continue into, I think we're closing about 5, so we are going to, I'm introducing myself, because we're now going to talk about midlife, and then I will do my talk. I'm first up, and then I'll introduce my colleagues. Okay. Sorry, just trying to get myself organised. Right, oh, good. Okay. I make this happen, do I? Brilliant. Okay, so thank you, everyone. I'm going to talk to you just now, just for 10 minutes. Natasha's got her eye on me. About midlife women
And I think what I'm going to be doing is just, it's not, I mean, the evidence base is huge. I'm just going to be trying to pick up some highlights, some key messages from the evidence and talk to you about some priorities going forward. But I'm going to start by going backwards. And also to let you know, I am talking from a place of lived experience. Not just of menopause, but some of the horrible things that come with it, not for everyone, but for quite a lot of us. So the last time I talked about this was around about 10 years ago, maybe 8 years ago. And the fact is that the mental health and well-being of midlife women has been long neglected in both research and policy. And that's despite there having been in some of the big surveys that NatSound runs, Scottish Health Survey England, APMS, clear evidence that there's a midlife dip, particularly for women in terms of mental health and well-being. With rates of depression and anxiety amongst women higher than men, and also, towards, around about 2012, 2013, that's when the rates for around young people started to get much higher. There was a pretty strong policy response at that time, but the women's midlife mental health had been worse, if not, the worst, and it continued to be as bad as it has done since then. So, frankly, when I looked at this and presented on it the first time, I looked across all of the policy documents in Scotland, where I was at the time, and there was nothing at all about midlife women and mental health. There was basically a policy vacuum, and as a group, they weren't considered worthy of policy attention. We know now from Mary's presentation that things have got worse for everybody. It continues to be an issue in midlife, but particularly what's notable, and I'll come back to this, that there's been a steeper increase amongst younger women, as we've heard this morning, and that's moving into the older age groups of young women. Suicide rates continue to be higher amongst women in midlife than other age groups in both Scotland and England. However, and my colleagues here who are specialists in suicide prevention research may have something else to say, but in my opinion, this hasn't been picked up in policy in any of the strategies, particularly focus on midlife women and what uniquely impacts them in terms of their suicidal behaviour. I know that some colleagues of people here today, Clements et al., have looked at some of the unique factors associated with self-harm among women in midlife compared to younger women. However, they didn't have the data to explore the link to menopause. However, they recommend further research. Okay. So women in midlife face unique mental health challenges driven by a wide range of biopsychosocial factors. I'm not going to go through all of them. A lot of them are the same factors we've talked about today. However, they are experienced differently. These include things like increased responsibilities at home and work, financial dependence or greater financial dependence, financial strain than men, and caregiving roles. And caring responsibility, I think it was Tamsin, no, it wasn't Tamsin, it was Stephanie this morning mentioned unpaid care. So caring responsibility is a particular challenge for midlife women who are most likely to providing unpaid care, usually for ageing parents, but across the whole family. And there's a clear link to poor mental well-being and negative impacts on the ability to continue work. And menopause, of course, is uniquely experienced by women and for most in midlife. So I'm going to pick up on menopause for the rest of my talk. And some facts for people who are not familiar. So according to NHS England, around 13 million women are currently perimenopausal or menopausal in the UK just now. The transition is kind of 3 stages, from perimenopause, menopause, and postmenopause. So menopause is when you haven't had a period for 12 months. And typically this lasts around about 7 years. 75% of women experience menopausal symptoms and 25% experience severe menopausal symptoms. And although the most commonly known about are hot flushes and night sweats, there are up to 30 recognised, well, when I say recognised, known about, I don't think they're fully recognised, symptoms that women can experience. And a lot of them are mental health related, including low mood, anxiety, low self-esteem, problems with memory and concentration, which is why I've got my notes here. So it's important to understand, however, and some of this evidence comes from a recent systematic review of the qualitative evidence of people's lived experience. And research shows that women experience menopause really differently. For some, it's a really positive experience, a kind of gentle evolution, whereas for some, it's the worst and indeed the most horrific time of their life and taking them by surprise. So many women experience a significant decline in their mental health, along with extreme mood shifts and amplified emotions such as sadness. And interestingly, from that research, which isn't as talked about as much, as a lot of women at this time of life also experience negative body image and feeling worse about themselves. They become more socially withdrawn, potentially intensifying the mental health challenges that they face. There's also a large body of evidence on the experience of women accessing support. And a key problem around this is that women are woefully underprepared. So many struggle to identify their symptoms as menopausal, especially if they're not experiencing more commonly recognised symptoms like hot flushes. And that happened to me. I had extreme tingling at my extremities. And I also had numbness, and it didn't go away, and I didn't know what was happening, and it did lead me to start to think I was going to die. And I had extreme health anxiety linked to that, going onto the internet, trying to find out what's wrong with me. I've got a neurological disease, blah, 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 blah. It can be horrific. In 2022, the Fawcett Society survey found that 45% of women had not discussed with their GP their menopausal symptoms. 31% reported needing multiple appointments before diagnosis, and when they were diagnosed, only 39% were immediately offered HRT. It's not the only thing that women need, however, it's pretty important, and there are huge barriers to accessing it. And that's exactly what happened to me. I had many, many, many appointments before, I won't go into the details, we haven't got time, before this happened. Oh, 2 minutes, gosh, I'm going to have to go much faster. Okay, so, yeah, so there is the evidence shows that many women experience this as well. It's not just me. And there's a reluctance amongst GPs to prescribe HRT, and often it's done as a last resort. And interestingly, or not interestingly, pretty badly, a lot of women are misdiagnosed at this time and misdiagnosed with depression and offered antidepressants. Again, that happened to me. And especially because there's still a huge lack of awareness amongst healthcare professionals about the less common symptoms of menopause. Okay, so it has also a detrimental impact on work, and the evidence around this is really stark. I'll skip through it given time, but estimated about 14 million working days are lost per year in the UK to menopausal symptoms. The majority report a negative impact on their work. Half of women, this is from a survey by the Chartered Institute of Personnel Development 2023, majority of women feel or half of them have felt unable to go to work. However, very few tell their bosses why. I think in that survey it was only 11%. The reasons for that is stigma, like 3 stigmas: ageing, menopause, mental health, being judged, and fear of being judged in the workplace. I'm nearly there. So despite numerous studies based on longitudinal cross-sectional data sets, there's a huge longitudinal study in the US called SWAN, UK Health and UK Biobank, Health and Her, data set, and also the APMS in 2014 had menopausal data in it. The key takeaways are we don't really know. The evidence base is really varied. Studies are contradictory. It's really difficult for us to make comparisons across them for me to give you any really conclusive findings today. And also the big problem is disentangling the multiple psychosocial risk factors from the effects of hormones. But there is relatively consistent evidence of a higher risk of depression symptoms in the perimenopause and postmenopause phases compared to premenopause. And I did want to just highlight to you some work being done by the Cardiff University and Bipolar UK that has found an increased risk of first onset bipolar amongst perimenopausal women. So they're twice as likely than premenopausal women to have first onset bipolar. And the other really interesting stuff coming out of that study is diagnostic overshadowing. So women who are living with not just bipolar but other mental health diagnoses, when they do start to experience menopausal symptoms, it's put down to their mental health condition and it isn't picked up. And there, again, it's another way that they are delayed, and it's another health inequality that we're dealing with. Very quickly, there are big gaps in national statistics. We don't collect statistics. APMS did it in 2014. We don't collect many statistics on this, so it's very difficult to do research, although these big longitudinal studies do help us. I think what's been most impactful, however, is evidence around women's lived experience that's impacted policy hugely. We do have a menopause module in the Scottish Health Survey in 2024, and in that we're looking at women's experience of menopause and their help-seeking behaviours. So that's coming out in the autumn. There'll be opportunities for secondary research on that and also qualitative follow-up. Just to flag, it's not as if nothing's happened. There has been significant advances in policy. We have, for the first time since, I think, 2021, Scotland led the way with a women's health plan. And there's significant policy work being done in the workplace to improve it. NICE guidelines have also been recently updated. So the issue with this is that civil service and NHS have led by example in terms of workplace, but we've still got a lot to do. I'm not going to go through all of these because of time. However, the one thing I would like, if there's one thing I want to highlight today, is the fact that we are seeing this increase in mental health and poor mental health amongst younger women. And it's really important that these women are equipped, and we do much more in terms of raising awareness and making sure the right supports are in place so that they don't experience something like I did. And if we can do that, potentially improve women's life experiences in the workplace and their ability to access the kind of support that they need and to recognise the kind of support that they need and demand it, that maybe we'll be able to see a lowering of that midlife dip or an increase in the mental health and wellbeing amongst midlife women in the future. Thank you. Now I forget that I now have to introduce the next person. I don't have details on here. Oh yes, I do. Terry Bruga, Professor of Psychiatry, University of Leicester. And Terry's going to talk to you today, not specifically about midlife, a bit more about APMS and some of his thoughts on advances in terms of people accessing treatment.
Okay, thank you very much. 10 minutes, let's go. Yeah, you'll see if you look at the abstract that I was going to talk a bit more about the second part of the APMS, but because that's not out now until the autumn, I'm going to focus instead on what I think are important implications of what we've already been looking at today. And so I'll be showing you a couple of slides from Mary's talk. That's where I have been based for many years. It wasn't a life plan, but it's been a very happy outcome for me and the family. And these are just some declarations of interest, no particular ones to admit to. I think know quite a bit about the background to the survey. I think I'm probably the one person in this room who's involved in designing the very first survey with Howard Meltzer, who was the architect, who sadly is no longer with us. The other person who should be in this room is Rachel Jenkins, who drove that through government, and we wouldn't be here talking about it otherwise all these decades later. So the findings that Mary raised this morning, which I particularly want to highlight, because I think we need to, and we've focused a lot today on the prevention need. That's the thing I want to talk about, because that's been another track in my career over the years in between the surveys. And these are some of the kind of socioeconomic factors behind which we've been talking about today, huge implications. And you'll remember this morning, the first one here is really looking at the increasing common mental health conditions over the years since the very first survey. It's very difficult to argue against the suggestion that this is a real increase. Some of us who are very methodological orientated might want to argue a bit with that, but it'll probably take us another few years to play that one out. This is the good news. I mean, all over the world, we've had big general population surveys showing a very high proportion of people, say, with depression, were not seeking help, looking for help, receiving help. And we seem to have really gone a huge way forward towards overcoming that. In the early years, there was an increase in antidepressant medication, but more recently, a huge increase in access to psychological therapies. Although those are very short-term accesses, and we know from the data that NHS Digital have been collecting that many people are actually going back for second and third spells of therapy. And another tranche of research we're not going to talk about today is actually revealing that if you look at trajectories in populations, there's a small but very significant subgroup of the population who have lifelong depression. And I'm afraid short-term therapies don't seem to work. In fact, we have no evidence base for that group. So I'm not just interested in treatment in the long term, I'm interested in prevention as well. So, okay. And this is one of the press releases that followed in the sort of 24 hours following our report coming out a few weeks ago. I was very pleased to see somebody in the sector actually advocating for prevention. Prevention and mental health promotion have been part of government policy since I was working there in the 1990s, so I'm not telling the government that they need to have a policy on this. My focus is really on how we do that, and as you'll see in a moment, I've been working in that area for many years now. This was the first paper I produced, which was after the second survey, so it was in the early 1990s, sorry, the early 2000s. And we were already seeing there that rates were going up, that antidepressant treatments were going up, psychological therapies had not been rising, but there was no drop in prevalence. So the argument was treatment alone does not solve the problem. That argument is a much more powerful argument now. It's unavoidable. Much more recently, one of my colleagues in Australia picked this up with myself and colleagues in the only other countries on the planet that have had more than one general population survey looking specifically at mental health, and that's Canada, Australia, the Netherlands, and of course the United States. And building up the evidence around this, although there's very little in that article about prevention, but it's very much, Jorm's argument was that we need to be improving treatment. There's actually a very strong argument for that. And that was my point about short-term psychological therapies. I'm sure they're hugely valuable for some people, but they're not the whole solution. The next message I really want people to take away, particularly those of you who are advocating for the introduction of prevention approaches or more rapid access to treatment, is we don't know whether what you're doing is doing good. We don't even know whether it's doing harm unless we bring experimental methods into the framework. And you can do that with policy change, and I'll give you one or two examples. So, for example, if it's true that the government is going to be investing more in mental health expertise in the school sector, that is going to take quite a long time to roll out. You just need one medical statistician to tell you how to roll that out in an experimental way, so you will actually know, if you're collecting baseline and follow-up data, whether what you're doing has actually done some good. So I think there's a lot of mental health promotion and prevention going on in the UK. We simply don't know whether it's doing good or indeed in some cases doing harm. This is a study, I'm grateful to Sally McManus for pointing this out to me, I didn't know about, which is
an ecological study. It's a study that involves multiple sectors in an urban community in Great Britain, in which various economic changes are introduced. This require a lot of cooperation with the various independent sectors and commercial partners, and that's the kind of model I think we should be thinking about. Sorry, that's the second study there. The first study is one looking at the impact of universal credit rollout region by region. So that's a nice example of a sort of step wedge design, if you like. And we'll just skip that one. That's on the topic of suicide, which is a different outcome, obviously, but not to be too confused with depression, which is the main focus of what I'm going to talk about. Now, interventions can work and sometimes don't work. There is actually quite a substantial evidence base on randomized controlled trials of depression prevention interventions that didn't work. And if you're going to start doing this, you need to know about the ones that have failed as well as the ones that have been successful. So I'm arguing quite strongly, a huge body of evidence, particularly from Australia, but also the United States and New Zealand. A major centre in Australia, I'll come to in a moment, that have been leading on some of this work, including producing systematic reviews of the literature. Now, the problem I'm concerned about, I've actually alluded to already, is that, and I see this happening all the time, that when you get to the point where commissioners and policymakers say, yes, we're going to do something about this, their first thought is to make it cheaper. Now, we've seen this with the Ponder trial, which I may come to in a moment, which is a hugely successful study on 2,500 women in what used to be the Trent region of England. And it took 5 days to train health visitors to become very effective at treating and preventing postnatal depression. The policymakers want to reduce that down to 2 days. We've no idea whether that would work, and indeed one of us argued that that could be dangerous. Okay. So this is a project I particularly want to mention before I have to shut down. It's a regional study project program going on in the north of the Netherlands, very well funded for reasons I can talk about during the next break if there is one. And it's multi-sectoral, it's region-wide, and it's being evaluated. In fact, they're lucky enough to have a birth cohort there that's already established, which they're using to collect data. And they're collecting biological data as well as psychological, social, economic, educational data, and so on. So my recommendations are, if you're going to get involved in prevention, please choose an intervention that's already been shown to be beneficial, just as you would if you're rolling out a vaccination program or a new medical treatment. You wouldn't change the prescription. And particularly important is who's actually delivered this. The first time you roll this out in your part of the world, I would strongly advise you to use the same professional group doing that task and to make sure they get the same training. In my career, I've been involved in 2 replication studies where I took exactly a methodology used in another part of the world and implemented it. And it's astonishing how similar the results were. And of course, each time we do an APMS, we're replicating the first APMS. And evaluation, rollout. So if you're doing something new, and some of you may already committed to doing something new, please collect data before and after and use randomized rollout. And collect similar outcome measures and indeed additional ones. So I'm absolutely in favor of qualitative as well as quantitative analysis. So I think that's sort of my time. I'm perhaps the only person who stuck to my 10 minutes, so I'll sort of stop on that high point. Thank you very much.
Thank you, Terry, for sticking to your time, and apologies for not sticking to mine. Okay, Navneet is Kapoor, from Professor of Psychiatry and Population Health, is going to speak to us now, again, focusing back on, specifically on midlife.
Thanks very much, Joanne. The only person that calls me Navneet is my mum when she's going to tell me off, so I'm feeling already slightly unsettled. I'm going to talk to you about suicide and self-harm in midlife men. You've had some suicide and self-harm stuff this morning from Rory, from Sally, from Socrates. You've had Joanne's excellent talk on midlife women, and she is spot on. You know, it's a massively neglected group compared with midlife men. But I'm particularly delighted to be here because this is a conference on research, policy and practice, and that's what one of the things we have been up to for about the last 25 years. I work for a project called the National Confidential Inquiry into Suicide and Safety in Mental Health. We take data, in this case, complete national clinical case series. We make recommendations, and that's one of my favourite images because it summarises 25 years of research in a single slide. In fact, half a slide this time. You know, some of the things that are effective, some of the things that make mental health services safer, reduce suicide, crisis support, involving families, safer wards, but actually also the importance of staff. Low staff turnover, organisations which have happy, settled staff are safer. So we take the data, make recommendations, and then we are able to demonstrate that implementing those recommendations have resulted in positive outcomes. So a reduction in patient suicide, and if you like, one of the most important settings for safety is mental health inpatient care, reductions in inpatient suicide. And that's a safety success story that we sometimes don't hear about. So taking the data, implementing it, making a difference. But also, this conference is about policy. And some of our work has informed the Online Safety Act, as it is now. Really, I think, potentially important mental health measure. And also, our work over the years has informed the new national, it's not so new now, 2023 National Suicide Prevention Strategy for England. And that's particularly pertinent today because the bit we kind of almost most influenced was the bit on males in midlife. And really pleased to see that suicide mental health gets, you know, a prominent mention in the 10-year plan. So that's a bit about us, but today I'm talking about men in midlife. Why am I talking about men in midlife? Here's a histogram of suicide rates, and the reason I'm talking about men in midlife is because they're the group with the high suicide rates. There's also a kind of peak, if you like, in women in midlife, so, you know, definitely an area of researchers in the audience, definitely something, you know, that's really worthy of study. What's particularly interesting about this slide is if I'd been talking to you 20 or 30 years ago, that peak would have been different. It would have been 20 or 30 years earlier. It would have been young men I'd be talking about. Now I'm sat here, I'm stood here rather, talking to you about men in midlife. What we're talking about here in epidemiological terms, it's a cohort effect. Okay, it's that group of vulnerable young men who have got older. We can talk about why that might be. It's not just suicide, so self-harm. Sometimes we think about self-harm as a problem of young people, but self-harm occurs across the age span. This is a paper led by one of my colleagues, Caroline Clements. The top line is the rate of suicide, okay, going up gradually, men in midlife. The other line is the rates of hospital-treated self-harm in 3 sentinel sites. And you can see this big peak around, you know, big acceleration in the rate around 2008, 2009. That also translates into other groups. So this study now is about patient suicide, and we've done a fancy bit of statistics, joint point regression, to tell us where the natural changes in trajectory in the data are. Where are those natural changes in the data? For men in midlife, again around 2008, 2009. What's that about? We've heard about it. It's the recession, it's the economic factors pushing up suicide rates. But suicide is about more than just economic factors. You know, it's complex. Rory's kind of touched a bit on some of that. And if we want to untangle the complexity, we've got to know about who the people are. And this is a very simple, elegant kind of study led by my colleague Cathy Rodway in Manchester. It's basically a case series. So every man in midlife who died in suicide in England, Scotland and Wales, 1 in 5 samples selected, and Cathy and ourselves, we got all the information we could on those individuals, went to coroners, went to health services, etc. The other thing just to quickly say is obviously there's lots of statistics. I'm bombarding you with statistics. You know, in our unit, we never ever forget that behind every one of these numbers is an individual person with families, with friends left behind. Again, I hope that doesn't sound trite, it's true. But the statistics are important. What did we find? Who were these men? Well, some of the things you'd expect. So, about social isolation, living alone, etc. That was a prominent factor. Alcohol and drug misuse in about half of men who died by suicide. Affective disorder, primarily depression, in about 30%. That's probably a bit lower than you might expect and a bit lower than some of the classical studies. But some things we were a bit surprised about. 1 in 5 men in midlife who died by suicide were perpetrators of violence. 10% perpetrators of domestic violence. A third had experienced bereavement. 1 in 6, there was suicide-related internet use, primarily kind of searching for methods rather than social media use. But again, sometimes you think, the suicide-related effects of the internet are young people. No, in midlife as well. And half had a physical illness comorbidity. So this role of physical illness, psychiatric illness in, the etiology, if you like, of suicide. The immediate precipitants, here you go, economic factors again, in about a third of people with financial problems. But the other thing is a kind of interpersonal precipitant, and that combination of, economic or social factors and the personal, the interpersonal, can be quite dangerous, can be quite toxic. So those are some of the immediate precipitants. But this was the most surprising thing. Men don't talk, men don't seek help, do they? But in this study, representative sample of men in midlife who died by suicide, 90% had seen some kind of service at some point. Over 2/3 had seen those services in the 3 months before death. And over a third of the whole of this sample had seen someone in the week before death. And when we looked at the reasons for those contacts, in half of those third, the reason was a mental health reason. Okay, so do men seek help? Yes, they do, and that was echoed in the findings of the morbidity survey this morning. But one aspect I think that is neglected is the role of psychological treatment. We were limited by the records, but we only found that 1 in 20 had some were receiving some form of psychological treatment. And if I've got it right, Mari, the figure from the survey this morning was 18% in your survey of adults receiving psychological therapy. So that's something we could do. So look, men do seek help if we're thinking about implications. Yes, the kind of thing we're familiar with, reaching men that don't access services, we're all familiar with that, going through kind of sports, going through other initiatives, awareness raising, that's important. But actually one of the things our study told us is the services really need to be fit for purpose. Okay, they need to be fit for purpose because men are seeking help, but maybe they're not getting the help they need. And primary care, I think, is a crucial bit of that. Other things, need bereavement support. Bereavement's an important factor. Thinking about online safety, not just for young people, but for across the age range. And thinking about this complexity, public health, clinical and socioeconomic interventions. One of the big challenges, it's the coming economic kind of turmoil. That's my mate, Mark Signor. He's based in Canada. This was a study we did a couple of years ago, kind of warning about some of the effects of economic factors on suicides. Economists will tell you that no two recessions are the same. Of course, they're right. But there are some things we know kind of work. So things like, you've got to measure, you've got to monitor the data if you want to think about the effects of recessions on suicide or mental health. Avoid unhelpful messaging, either in the media or public health. When these things happen, that can make things worse. Think about health and social care. Think about what teams do. Think about signposting. But the most important thing is a kind of overall policy message. It's about economic mitigations of recession. And the Stuckler work was quoted in the areas where countries' welfare spending was increased in response to recession, they were protected against the increased suicide. So this is a quote stolen from my colleague David Stuckler in Oxford. Recessions can hurt, but it's the austerity that actually kills. So just to summarise then, rates of suicide in men in midlife have risen, and now they're the group with a high suicide rate. Remember that possible cohort effect. Self-harm and mental health patient suicide has also risen. the causes and antecedents of suicide are complex. We need a wide variety of different measures. Services need to be fit for purpose for men in midlife. But those wider societal and economic measures are key. And the last thing I like to do is put up a slide of all our hardworking staff back in Manchester who do all the hard work. I just get to talk to nice audiences like you. Thank you very much.
Hi. So we've got until 4 o'clock for some questions. Chris, go. Chris, down here.
Hi, thanks for that, Nev. I was thinking when you were presenting there, particularly that kind of cohort of and the changing pattern of male suicide. Do you feel that we have an issue that we have to explore of what happened to men who were born in the 1970s and 1980s, and is there an issue there for men and identity?
Yep, there's several theories out there. One is about a kind of stoical post-war generation, a individualistic now generation, and this group of men who fall in the middle. A more convincing explanation is back to some of the factors we've talked about before. It's the economy. So it's the scarring effects of the financial difficulties in the 1990s. In fact, there's a paper on this by Scottish colleagues that you may know. They blame the neoliberal policies of Thatcher, which I'm very much kind of in favour of. The blaming rather than the policies themselves, just to be absolutely clear. So I think, you know, that cohort effect is, I mean, everything seems to be coming back to the economy, doesn't it, really?
Nothing to add to that. That's very good. Good answer.
Thank you. Do we have somebody else? Oh, okay.
Thank you. I have a question for you, Joanne. One of your slides, you mentioned that there were cultural inequalities in access to menopausal care. Do we have any evidence on what those barriers might be culturally?
I'm sorry that I didn't. I put in too much to say, so I didn't have a chance to highlight that. So thank you for picking it up. It's really important. So, I think that the main barriers are around cultural. It's so varied. So it's not. There's not a one explanation I can give, but it is around language barriers, different ways of talking about menopause, and just the healthcare professionals. You know, there's just that barrier in terms of communication between healthcare professionals and women from ethnic minorities, as far as I could tell from the evidence, in terms of help seeking, and also I think. Although we have the women's health plans in all their various shapes and sizes, that is something that's been picked up as that there's not been enough attention paid to making sure that those barriers can be overcome and understanding them properly.
Hi Nav, hi Terry, thank you very much. I think it's a question or two questions in one that both of you perhaps will have an opinion. The being seen by services people being seen by services with mental health problems, perhaps we do have the data, I just don't know what the data is. But something that is worth exploring is, so we keep asking for people, waiting lists to be shortened, more people to be seen as a way of tackling what is happening. What is happening on the other side? So when someone comes through the services, perhaps in many cases they will get 6 sessions of CBT. I don't know at which severity eventually someone will be sent to be seen by a psychiatrist. But even that, then on the back, you know, people come through and leave from the back door, whatever. What is happening behind the back door? Are all these people then that are waiting to be seen or need to be seen, people who have already been seen, and eventually they can be, perhaps a lot of them are caught into a cycle of mental health that are not properly seen by services, or services have responded but treatment has not been successful, or that in many cases we know that mental health is not just, oh, go to the doctor, that's it. It's perhaps something that you need the tools for a lifetime to be able to tackle that. So what happens on the other side? And are these people the same people, or you know, a large number of them are the same people? And for NAV, the men situation, who are these men in terms of, you know, are there any different ethnic, cultural differences? And it's interesting because there is this whole backlash around men, heterosexual, especially heterosexual white men, that, oh, men are lonely, or men, you know, need help, and there's this whole thing, you know, that is viral on TikTok and everywhere, like people are like, boo-hoo-hoo, we're not gonna cry for men, white men who are actually the perpetrators of a lot of the ill health that society is kind of. So who are these men, and why, if as a society we think that they have all the resources, all the strength in a patriarchal world, then, you know, there is such a problem? So there are two questions.
Shall I take the suicide one first? I think in terms of ethnic differences, actually, it was a nuts-in kind of linkage, actually, wasn't it? So the highest suicide rates are actually in individuals of white ethnicity. The only group that has higher rates are people from mixed ethnicities, but other minoritized groups have lower suicide rates. That could be an ascertainment issue, though, because you know, we talk about how suicide deaths are ascertained, go to coroners, coded by ONS. It could be an ascertainment issue. You know, your other comments are really interesting, quite provocative, and I don't think I can answer them from a research perspective. But clearly, you know, I'm a kind of epidemiologist. What we're looking at there is some of the kind of, you know, sociological kind of empirical research to kind of, you know, think about that. And I know, you know, Samaritans in England have been involved in some of that. You know, it's the changing role of masculinity and masculine roles. That does not explain the higher suicide rate in men, okay? That does not explain that. The higher suicide rate in men always used to be about, oh, they don't seek help. I think they do. But there are other unequivocal facts. You know, unfortunately, when men hurt themselves, they do so using more dangerous methods. That's part of the reason for the higher suicide rate. The other reason is you know, some of the risk factors that Rory talks about. So some of the things that are associated with suicide are more common in men. So that's the primary explanation for male suicide rates, I think. Terry, the other question was fascinating about, you know, revolving doors and whether we make anyone better.
Yeah, and Nav, you've got 50 seconds to start running for the train, so...
Well, I'll do that. That'll entertain the audience.
That's why I gave you a first bite of this. Yeah, nothing to say about gender, but I want to kind of just echo something I did say during my talk, which is that now that we can look at trajectories of depression over many years in cohorts where people are followed up and these things are measured repeatedly over time, what we're seeing very clearly is good news is about 50% of the population never have these problems at all. Probably the next really important thing, though, is the fact that there's a small subgroup. It's typically around about 5% of the population have enduring problems with depression and anxiety. We know from the increasing access to psychological therapies data that people are coming back for second and third spells of treatment. I don't think they know which of those subgroups they fall into, although they are amongst the only people to actually publish research looking at trajectories within a treatment cohort. But I suspect that's the case. But the thing I really want to emphasize is we have no idea what to recommend for treating long-term depression. There are no trials of medicines, there are no trials of psychological therapies that go beyond 18 months, 2 years. And if you're working in primary care as a GP or a practice nurse, when you know somebody's been depressed for the last 15 years, they're probably going to be depressed for another 5 or 10 years, you have no idea what to recommend. There are no trials, there are no plans for trials. So if there's any funders in the room, anybody has leverage with funders, can you please ask them to start looking for, because we do this in cancer research, we do this in diabetes research, no hesitation in setting up trials with 5-year outcomes and longer. Why can't we do that in mental health? And nobody's talking about it.
Thank you, Terry. I'm afraid no more questions, but do you know, we're going to move on now. Thank you very much, Nav and Terry. Okay, so further into the life course, we're now going to focus on older adults, and we have Claudia Cooper, who from the Centre for Psychiatry and Mental Health, Queen Mary University of London. Thank you.
What's going on here? Mentimeter. Right.
Use your slides that way.
The green button. Oh, there we go. That's much better. Right. Hello, everybody. It's lovely to be here today. It's been really interesting discussions. We're now moving to older adults, by which we tend to mean people aged 60 and over. And thinking about them as a particular group that policymakers might want to focus on. So I currently co-direct the Policy Research Unit for Dementia and Neurodegeneration, so have a keen interest on that overlap between research and policy, as I think many people in the room. But I've been part of the writing group for many years, looking at the adult psychiatric morbidity surveys, and it's been fascinating to see what has come out of them. And one of the consistencies in my work looking at older adults has been that this is a group who consistently get less care and support than other groups relative to their needs, and we've published on this over the years. And here is a graph from the latest report recently released, which shows that still, this graph shows the proportion of people who we believe need help that get help. And you can see that clear drop-off in older age groups. And it's interesting, as Terry said, because we ask the same questions pretty much in each cohort, you can see some trends, and some of the inequalities, such as around gender and ethnicity, might be narrowing with some of the policies around IAPT, for example. But there's something about the older age group that has been quite persistent. So in the time that I have, I just thought I would just glide over a few areas that we might look to understand that. And one of the key factors, I think, if you think relative to other inequalities, is there may be a genuine anxiety amongst mental health providers, health and social care, about feeling skilled or feeling that there is something different about this group, perhaps feeling a sense of sort of clinical impotency in how to address the needs of this group. And this is a recent systematic review meta-analysis that we brought out, looking at resistant depression. So people that have depression, which doesn't get better with the first therapy or the first course of antidepressants, and what do we do with them? And what's interesting is that older people are more likely to have resistant depression. Well, you could arguably say they've had longer to have the depression and to try and have it treated. They respond just as well to treatments, but they're less often offered those treatments. And that might in part be because there is a genuine anxiety. It may not actually be based in fact about the side effects and about what's going on when older people become depressed. To completely come from a different angle, but hopefully you'll follow my train, why else might older people be this group that's resistant to the work that we're doing that might have reduced other inequalities? And there's something really entrenched, I guess it's called ageism, in society that means that older people feel treated differently and perhaps embody that difference. And we did a really interesting study looking at the extent to which older people were affected by cybercrime. You'll hear more about crime from the next speaker. But what was interesting is that there might be a perception that older people are vulnerable to cybercrime because they aren't as tech savvy, maybe. That would be a perception, wouldn't it? But actually, what we found was that they probably weren't at any greater risk because as a cohort, they tended to take great care. They were less likely to engage in risky behaviours. But if it happened, if they were a victim of cybercrime, they were really reluctant to report it. And there's a stoical generation argument that we hear a lot, isn't there? But I think there's also something about not wanting that stereotype to land on you of, oh, maybe you should be less independent. Maybe it's time that you weren't using the internet, which of course is really key, isn't it, now to independence. I'm not saying that was the reaction, but that was the reaction that was feared, and consequently people were reluctant to go for help. And a second one that leads me into some of our work in the Policy Research Unit for Dementia and Neurodegeneration is that as people get older, the morbidity, the situation is more complex. There's rising rates of cognitive decline. This is a terrible graph. I do apologise for many reasons, unspelt out acronyms, etc. But fundamentally what this shows is that, say at the age of 80, 20% of people will have dementia. Over 50% of people will have observed some cognitive impairments that they notice themselves or that others notice. So if you have a mental health problem in older age, it may well be complicated in terms of diagnosis and treatment by a comorbid cognitive disorder. And similarly, of course, physical problems accumulate in older age as well, don't they? So often what you have is somebody with a complex mix of mental, physical and cognitive disorders. So that's the problem. What can we do about it? Let's be positive. This is some pictures from my NIHR-funded dementia prevention program, Apple Tree. We did a trial. The trial results aren't out yet, but let's just say we're feeling very positive about them. And we looked at, can you get people together in groups on video call and give them some support around social elements, reaching how to access mental health support, how to access social care and community support. It's called a psychological intervention, but actually, arguably, it's helping to breach that gap to access other treatments as well. And as I say, it was very positive findings. What was lovely about it too was that we put some community action in there too, and actually talked in our intervention arm to the groups about what were the images, what were the photographs, what were the messages that they wanted to share with policymakers. And you can see in the picture one of our participants from the intervention with talking to Daisy Cooper, MP, about some of the findings in an exhibition that was co-designed and was shown in the House of Commons. Because it's really key to get the messages out. The other fundamental message, I would say, from some of the work I've done, these are two of my programs. NIDUS was a dementia care program, and Apple Tree, that I just talked about, was dementia prevention, is the need to be goal-focused. As things get more complex, you can actually ask the client what their priorities are, and you can base your work around that. And if you co-design and you start with what do the communities say they need and how do they need it in order that this is useful and used, diagnosed, you will do well. And that is how we've ended up with some interventions that have been very successful. So the NIDAS goal-focused care intervention, this was our finding. It was a rare positive trial result in dementia, and it was not only effective in terms of people achieving their goals, but it was cost effective. And in the trial, the intervention group cost around £9,000 less than the control group, because of the fact that prevention is not just better than cure, it's actually cheaper than cure. And I suppose I would just comment that you will have seen a lot about dementia in the news at the moment. It will all be based around the drugs, which have not been funded by NICE due to the high price, effectively, meaning that there's low cost effectiveness. There's interventions available now. NIDAS is an intervention that I developed with the Alzheimer's Society. It's available for free, and I think sometimes we perhaps don't value things that are available for free. But we are doing some intervention trials and so implementation trials to look at how we can roll this out and how it works in practice. But I would encourage policymakers to think about the psychological interventions and what is most cost effective for people now. We've reached out to our colleagues in Australia, and perhaps part of the interesting debate here is that there's very similar work going on in different countries about developing accessible interventions to get some messages out there consistently so that everybody has the right intervention delivered in a supportive environment, not just a leaflet, but actually a facilitator who doesn't need to be a clinical professional, but needs to be trained and supported to provide consistently good care early in the dementia illness or at a point where people need prevention. So finally, just to say a little bit about our policy research unit. This was started in January 2024 at Queen Mary, and our focus is on looking at reducing inequalities for people living with dementia. And interestingly, dementia in itself is a reason for inequality. People with dementia tend to get less good care than people without dementia, and then there's a lot of intersectionalities on top of that. I'll be around after. I'm going to fly through these, and if anyone's interested, happy to chat after. But some of the questions that we have been commissioned to look at with policy makers are, how do you deliver good prevention? Is the general public ready to think about prevention, not just for dementia, they probably are for dementia, but for Parkinson's, for multiple sclerosis? We've had a conference and we're now doing some work to think, we now know what the modifiable risk factors are for dementia, but how do we get the message out on a more granular level? Can we talk to local authorities? We've all probably seen the Lancet Commission saying 45% of dementia is modifiable. But actually, if you give people at a local level some information about what's happening in their area and perhaps some of the strategies that might work best, think about rolling out some sort of low-cost but practicable solutions like Apple Tree. What can we actually do to reduce dementia risk? Because some of the calculations are, okay, 45% reduction in risk is based on removing all diabetes and depression forever, but you know, we could probably perhaps achieve around 12% with what we know. We're looking at national provider, we're looking across the NHS at the services where people with dementia get treated, to think about what they're doing now to ensure that services are equitable. There's something that I heard which makes sense, which is mind the variance. So although everybody's in incredibly challenging contexts, some people are nonetheless doing excellent things, which mean that they're delivering preventative advice, they're developing equity in their services. What can we learn from them? So we've spoken to most of the memory services in England and most of the CMHTs, and our memory service survey is out. Delirium is, I think they say, a wicked problem. It's very complicated. This is when people are very confused because they have physical health problems, often on a background of cognitive problems, and develop behavioural problems. And it's very complicated to think how to look after them in hospital, and it's an area that policymakers are very interested in some evidence about what to do. And finally, how should our workforce be trained so that actually when people with dementia and neurodegenerative disorders people come to hospital for any reason, not just the index illness that they have, how do we ensure that they are treated well? 22 seconds over. Not bad.
Okay, thank you very much, Claudia. I'll just, you come back up to the stage when we've got questions, if that's okay. And I'd now like to introduce our next speakers, Dr. Anastasia Fadeva, a research fellow, health sciences at City University London. Thank you.
Okay, so I'm going to showcase a study that we done together with Claudia and Sally McManus, who was presenting earlier today, and my colleagues from the division, Laden Hashemi and Rob Stewart. And to showcase, this is just an example of how we use APMS to look at the mental health of older people, but in the association with violence. So this research was funded by UK PRP, but it doesn't necessarily mean that our views represent the views of a founder. So a bit of a background and rationale for this research. So we experience an aging population in pretty much all parts of the world now, and that means that the number of older people who might experience violence also and potentially increase. And we know that older people, they might experience increased vulnerability to violence due to some characteristics, due to poor health, due to potentially social isolation and loneliness, increased financial challenges due to retirement and loss of health, and dependence on others. Despite the fact that potentially there is a higher number of older people who can experience violence, there is very much like kind of a big gap in terms of data on violence in older age. And this is due to the fact that violence still remains like sort of unrecognized problem in older age, and a lot of like wider people, general public, and even professionals who work with older people, including health and social care professionals, do not recognize that the issue that might affect older people. So there is like a lack of data, administrative data, for example, on violence in older age, but also data from surveys, and that includes crime survey for England and Wales, which is like the most detailed source of information on violence and abuse in the UK. For a long time, a crime survey for England and Wales excluded older people from their self-completion part, which is a domestic violence part, so we were not able to get the statistic from that source either. Also, because of that lack of data, we actually were not able to look at the associations with, between violence and health, and including physical and mental health in older age as well. So that's why we decided to do the study using APMS, and APMS is quite a good source for that, because it has both includes people of all adults of all ages, including all the adults as well. It also collects quite detailed information on violence, and also very good indicators on health, mental health. So the study looked at the risk factors for experience of violence in older age, specifically in the last 12 months, and also look at the associations between mental health and violence. So I'm not going to focus much on the APMS, it was discussed a lot today, but it's just to say that we look at the comparison. So as violence prevalence and mental health associations between violence and mental health in older adults age 60 and over, in comparison with the younger age group. So the measures we look at included demographic, socioeconomic, and area level deprivation factors. We also account for loneliness and isolation, for physical and cognitive impairments, and the main kind of outcome variable, dependent variable was common mental disorders. And we also look at violence and abuse, and that included physical, sexual violence, economic, emotional, and bullying. From intimate partner, from other family members, and also from others, that includes strangers and acquaintances. Analysis were done was so kind of descriptive profiles for older adults in comparison with the younger population, and also prevalence of violence in both age groups. And we also used logistic regressions to look at the associations between violence and other risk factors, and between CMD and violence and other factors. So results showed that basically, but in terms of the kind of in comparison with the younger age group, older participants were significantly more likely to be white British, married or divorced, or separated or widowed. They were more likely to be retired, expectedly also wealthier, more likely to be homeowners, and had homes of better quality. They had worse physical health, but had better mental health than younger people, as also was mentioned today. They also had less loneliness and isolation. Prevalence of violence was also lower in older age group for all types of violence than in the younger age group, but the patterns of distributions of violence were quite similar actually. And similar to the younger age group, intimate partner violence was the most prevalent form of violence, and that's quite interesting itself because based on the previous research, domestic violence from other family members was found more prevalent than intimate partner violence, but our study shows that's not necessarily the case. In terms of risk factors associated with violence in the last 12 months in older age, so one of the risk factors was age actually, but in a reverse way, so people, the oldest age group, 75 and over, were less likely to report violence in the last 12 months. But people from non-white ethnic groups were more likely to report violence. Also, people who are divorced, separated, or widowed experience higher risks of violence. Isolated and lonely people as well. And also child abuse was associated with a higher reporting of violence in older age as well. For factors associated with CMD, so we found out the most interesting one was was violence. So violence was positively associated with CMD, but also childhood abuse. Was another factor, and interestingly, so independently from other risk factors. So even if people who experience childhood abuse were still at risk of worse mental health even at older age. So to sum up, what we found that obviously all types of violence were still found to be less prevalent in older people than in the younger age group, but they were all they all existed. And it might seem kind of quite low number, but it's like around 1.5% for intimate partner violence. But if you account for the whole population of England for that time, it was over 200,000 people, so it's quite a significant number of people only for intimate partner violence. Also, intimate partner violence remained the most common form of violence, unlike what previous research showed. Non-white people, as well as divorced, separated people, people experiencing widowhood and lonely and isolation, were at higher risk groups. Violence presented an independent risk factor for common mental disorders, but also experience of childhood abuse also presented independent risk factors for worse mental health and exposure to violence in older age. So for future research, I'm quite excited about a new wave of APMS because it gives us more opportunities to look at the prevalence of violence in the more recent wave of older people, because it's an aging population, so it's very interesting to look at it and compare with the previous waves as well. Also to look at the associations with a wider range of violence experiences as well, so because a new wave now collects more detailed information about perpetrators, for example. Also to look at the use of mental health services and treatments in this age group. And in terms of just some policy implications as well, I think it's worth saying that we definitely still need more sources, more data on violence in older age, and that includes both surveys, such as the APMS, but also it would be good to have more longitudinal data on it as well. Violence in older age needs to be better recognized by health and social care professionals and people who work with older adults, because as you saw that older people were actually less likely to have bad mental health, but that means that if people experience violence, that patient presents with violence, maybe healthcare professionals should consider that violence was one of the risk factors for, like, for example, depression or anxiety. And so, yeah, thank you. Thank you. I think that's it.
Claudia, do you want to come up? Are you okay to come up for a few minutes? We've got time to do some questions. Yeah, we'll just take a couple. Thank you. Thank you, Anastasia. Thank you, both of you. I was just struck by, the work that you're doing and how, you've highlighted how ageism has impacted not just the availability of services, but research, and that your work is doing something to address that. So great. Okay, do we have questions? Katie?
Hi. This is directed at Anastasia's presentation, but I might look at my APMS colleagues. What I was interested in was the sample of the older people, whether we can differentiate between people in their own homes, or I don't know if we interview those in care homes or sheltered accommodation, and if some of these older people have an impaired cognitive function, that their memory, and then how that links with the violence, whether they remember these instances. So is there a risk of underreporting?
Yeah, I can try answering that. Very good point, actually. So should have mentioned about the APMS only collect dates from household. So people in institutional care settings were excluded, which is a limitation, of course. And we expect that people in institutional settings might experience higher rates of violence. But it's quite a challenge of collecting data in these settings. And in terms of cognitive impairments, another problem as well. So potentially that's why I think there might be lower lower prevalence of violence in the oldest age group as well. But also there's so-called healthy survivor effect as well. So people who experience violence, they are also less likely to live longer as well.
The APMS doesn't have people living in care homes, but we've done other surveys in care homes. If you look at the MARQUE care home, we went to 86 care homes across England and included a version of the modified conflict tactics scale. I think what's clear is that violence is modified by having dementia and being in a care home, but when we've looked at levels of elder abuse, they are worryingly high, and a minority of that is violence. A lot of it is neglect or psychological abuse, but certainly it's a very interesting and wider question than we can have here about how you can tackle that, but often a lot of the answers are at an institutional level. That care home study by Mark actually got picked up in Hansard and was picked up in Parliament. It's got a lot of political attention.
Okay, thank you. I think I'm going to move to our panel discussion where the audience can... So thank you very much again, Claudia and Anastasia. Okay, so would our panel members mind coming to the stage? We've got Graham, Andy, Stephanie. I heard that, okay. Thank you. And Rory, thank you. Okay, so we just wanted to take a few minutes at the end of the day with our esteemed colleagues here to reflect on what we've heard, what we've learned, thinking about going forward. So can I open up to the audience, or do we have anything online? Do anyone have any questions, or do you want me just to start it off? Yeah, great. Thank you.
Andy Jones, University of Hertfordshire. I'm going to ask a naive question because this
isn't really my research area. But I'm interested in moving from the data to action. We've seen lots of compelling data presented today to show, you know, some things are getting better, a lot of things are getting worse. And I guess there's always a risk, isn't there, that, you know, the latest survey comes out, everybody says, oh, this is awful. Academics get super excited because they can get their ref papers written, and then the cycle repeats. And I'm interested in where panel members think we're at in terms of translating what those large population surveys are telling us into policy and action. And, you know, should we be hopeful, or are we stuck in a situation where the cycle repeats but the lines keep going up?
Okay. Who wants to go first? So I'll start. I mean, one of the things I didn't have a chance to expand upon in terms of how I think we could be doing the research, mental health research better through partnership is by working with policymakers very early on. And this is right across the board. So you know, in my group, even our student MSc projects, we often try to use the same model that ESRC uses with their case studentships and have non-academic partners, mostly people who are decision makers. So I won't even say policy makers. We try and identify where are the levers for change, who are the decision makers, whether that be very locally, regionally, nationally, and then try to engage with them in the process of co-designing the research itself. And that for us, and particularly with the work that we've done on the impact of discrimination and racism, but discrimination more broadly within health services, has been where we've seen our biggest impacts, so that we have engaged in those discussions at the point at which we are, you know, thinking of those ideas, and we're asking, what are the pressing questions within services? Where are the barriers, and where's the resistance? You know, so say you've got this fantastic policy that resulted from the evidence, and it gets implemented, or some program or a framework or anything like that gets implemented, we're still seeing resistance, right? So that's within services, but we also work with local councils and communities. So the work that we're doing in our ESRC Center for Society and Mental Health, for example, our Connect study, that was born out of community consultations that were carried out by 2 of the local councils within the area. So we think about prevention a little bit differently. So not just thinking about the interventions that have gone through trials, but also thinking about prevention in terms of, like, population-based and what communities are saying they need and what they're already, in fact, doing in terms of you know, communities of care, like the actions that communities are taking in their own right, what we call sort of informal support. So looking at all of those things taken together, but it's really about engaging the people who are the decision makers, who have the ability to change things, where the power is sitting very early on. And that's where we need to see this information getting to, but oftentimes, like you suggested, it's like we write the paper, it gets out, like that's at the end of the line. And by then, we don't even know if we've even asked the right question.
Right. Is it okay if I go to Andy next? Andy's time limited.
Oh, right,
so then we'll come to you, Rory. Thank you.
Limited in many ways. Fantastic question. A couple of years ago, we published something called A Mentally Healthier Nation, which set out an action plan for government. It was signed up to by 70 organisations across the country. So we've got a very clear sense of what we need to do, and that's just the start of it. So I'd really encourage colleagues to have a look at that, get behind it. I get hope from seeing what happens in communities and in local areas. Many local authorities are taking action, but they'd really like national policy to support them. One good thing, because I think really we should be pretty cross at the lack of government focus on mental health. We shouldn't just accept that, you know, we shouldn't accept second class or second best. But sometimes we do get accidentally good government policies. So things like legislation around workers' rights and housing, that will help to boost mental health. It's not designed to, but nonetheless, it should bring some benefits. So there are some things that give us hope, but ultimately, we've got an enormous way to go. But I do think we have a clear set of asks of national government, and we need to be absolutely resolute and determined in not taking no for an answer anymore.
Well, I agree with that. I would probably be slightly more optimistic, I hope, right? I hope I'm right, I hope, but maybe I'm wrong. I suppose going back to your question, I think probably 25 years ago, or 20 years ago, we were just about describing the problem, right? Another paper coming out, there's an increase in mental health problems. But I'm more optimistic now because I do think in government there is, and we as all of us involved in the sector are much better at implementation science. So 20 years ago, we would never have thought about implementation science. How do we tangibly translate that research evidence into changing people's lives? So I think there is a greater emphasis on that now at all levels, at local government, national government, and the whole range of partners. But I'm not naive, right? The biggest challenge we have is getting governments to properly embrace tackling inequality, right? So seeing mental health within this broad spectrum of public health. So they talk the talk, but I would like to see them walking the walk. Because we could tackle inequalities, we would wipe out so many of the mental health problems, and in suicide in particular, we would definitely see a marked reduction. And part of my reasons for optimism is in part because I'm heavily involved in what's happening in Scotland in suicide prevention. And so for the first time ever, the first and only suicide prevention strategy published anywhere in the world, we have front and centre a vision. Not only do we want a world without suicide, but we want to tackle the drivers of the inequalities that lead to suicide. And now we have huge pressure. We're working closely across government to see what can each government department do, in this case, to tackle those inequalities. So I think that wouldn't have happened 15 years ago. So that's why I'm a bit more optimistic. So hopefully. I can't speak for England, obviously.
Yes, I'd like to say I can only speak for Scotland. I would say over recent years, any democratic or any other form of lived experience voice has progressively lost any funding or support to be heard, even though policy says we should be involved at all levels. I would change that, but I would also think that in times of austerity, you will hear more and more talks like mine where I get angry about the way we're treated. And I think there is a need to treasure and support all the people who work in mental health and research in mental health, people with lived experience and their carers, and ideally to join together, to get the small community organisations, like you said earlier, speaking out like they do with the one I'm with in Helensburgh, but also to get professional bodies speaking together and realising that for whatever their antagonisms and preciousnesses, they've got very much a common vision with all of us. And if we could stop being so competitive, and if we could talk about joint cause between professional bodies, between third sector, between all, then maybe we can create a more informed government and set of policymakers.
Nav, in his presentation, pointed out that people he was talking about, middle-aged men, do seek help. But he said that services weren't fit for purpose. So my question to the panel is, what would fit for purpose look like for services, and who would we ask? How would we find out? What knowledge would we need to discover what that fit for purpose would look like?
I can maybe say something about the suicide bit. So there's two bits to what Nav said. Right? One is, so men do reach out. They still reach out less frequently, right? A colleague of mine, Susie Bennett, we reviewed all of the evidence looking at qualitative and, her work was qualitative evidence, and asking men to find out what men are telling us, what they want and need. And it touches on different representations of masculinity. It touches on services. It touches on facts that when they engage with services, they leave the service feeling worse than when they arrived. they feel that but it's not just the services' fault. They often feel that they don't have the language to discuss the way they think to communicate what they want to communicate. It links in with their experiences historically have been so negative that they won't go back again. But in terms of what those services should look like, it's asking. So there's no one answer, right? So it's asking men, in particular, and men are not a homogenous group. It's looking at characteristics of working class men, other groups of individuals who are men, and part of it is going to where men are. There's great examples of basically going to football clubs, rugby clubs, whatever it is, places like that, because that's what the men have told us that they want and need. So the key question is co-creation and co-production, but there's a lot known out there. We just aren't putting it into practice.
Can I add to that? This sounds like a strange way of answering a question. I was speaking with some young people recently who were saying they felt completely let down by young people's services because they were patronised and dismissed and people didn't understand their world. And I have a feeling that can happen with men too. This is to grossly stereotype some of the things that happen in hospital. And I love the creative writing and the artwork and all these things, but I don't think these are necessarily always the traditional activities that men get up to in their lives and on a hospital ward. And we might want to tailor the different things we do within mental health teams and in hospitals to some of the things I think men probably like doing, although I must admit I'm not entirely sure what they do like doing, so this is a bit difficult, but I do think we sometimes get it wrong a bit.
Do you want to say anything about women?
Oh,
whatever you want.
I do want to say, and thank you for bringing up middle-aged women being one of them. I feel it's a conversation that I'm glad we're having more and more of. And I think one of the things that you mentioned was and there was a question from the audience, was around the sort of cultural assumptions and assumptions around those from racial and ethnic minoritized groups, women in particular, when they go to the GP at that time of life with perimenopausal symptoms. And in some cases, it's even worse. So we know that the services, the experience of services for a lot of people from racial and ethnic minoritized groups is not great, full stop. But, so you're going in and you've got these symptoms and you're not seen as, let me put it this way, your body is not valued in the same way as your white counterpart, right? So we don't, all of the stereotypes come out. We should be more tolerant of pain. We should be more tolerant of, stress. We carry more, all of these things. And, it's just to my mind and what I've seen, just a sort of perpetuation of some of the racist ideology that, a lot of people experience within health services. So I think I go back to that need for that cultural safety in those situations. The other thing I wanted to touch on, which we haven't talked a lot about today, if we want to improve services, we need to look after our healthcare professionals better, much better. They're struggling. We've got one of the highest rates of bullying and harassment within the NHS in England, and it has a tremendous impact on their mental health. They're also working in we heard about the strain on services, but we never stop to think, what impact is that having? So when I'm working with policymakers, NHS England, others, I'm asking, and leaders of trust, I'm asking, how are we expecting this, excellent delivery of care by people that we're not looking after? So how do you expect, so much of people delivering the care when they're unwell themselves? So I think we can do also a lot better at looking after them.
Yeah, look after one another, co-production, probably as simple as that. Here's a Blue Peter moment. In 2022, we published a report called No Wrong Door. That was based on asking people who use mental health services and work in them and work around them, what should mental health services look like in a decade's time? It set out a really clear agenda, 10 principles. I'm not going to read them out now because I won't remember them. But please do have a look. It's called No Wrong Door, and it sets out a really clear, co-produced and jointly created set of principles for what good mental health care could look like. That includes looking after staff well-being and prioritising co-production, because there isn't a single cookie-cutter thing. You can just say, do it like that, always, every time. It's going to be different in different places and for different communities and groups within different communities. But let's have that commitment to do it. Let's not just sit back and say, well, we just need to be doing more of what we're doing now. Apologies, I've got to disappear early.
Thank you so much for stepping in. It's wonderful. Okay, yes, Terry.
Simple question. Who should lead a project, a 30-year project, to improve our mental health?
Was that 30 you said? 30 years, okay.
Can I just
We could be here for
sort
some
of
time.
reframe that to who should co-lead a project? Because I think that's the point that we were trying to make earlier about working across sectors and, you know, moving this out of just solely being an academic exercise. I really do think that it requires us to take that systems approach and to make sure that we have representation, that we're centering the lived experience, but have that representation. And I mean lived experience in a very broad sense as well, because there's so many, if we think about the social determinants, those people have, they sometimes may or may not have experience of mental health services, but they've got the lived experience of the exposures that we know are driving some of these inequalities that we need to attend to, but also making sure we've got representation and that there's better parity in terms of the value of expertise coming out of academia, and thinking about the skill sets that should be valued, that go beyond our sort of traditional research methodologies and approaches. So I think it should be a joint effort. I think, I imagine this sort of hub and spoke as well, and that we learn from each other. We heard a lot of, really great work coming out of Scotland. Is England listening? Is Wales, are we listening to Wales? Like, are we, even across the UK, I don't think we have that, sense of joined up thinking and approaches. It shouldn't take it going to Australia for us to be remembered that we thought of it first. So it's just, I think it's really got to be a much more joined up systems approach.
I agree.
Graham, do you have anything?
Yes, so do
I. Okay, we have an online question for the panel.
Yes, exactly. It says, what role do you see AI taking in prevention, assessment, and tax of mental health issues, and is it a direction you are optimistic about, and if yes or no, why?
I think I kind of missed the middle of the question. Did everybody get that? Do you want to read it out just one more time? Thank you.
What role do you see AI taking in prevention, assessment of mental health issues, and is it a direction you are optimistic about, and if yes or no, why?
Well, maybe I'll kick off then. I don't think there's a straight yes or no answer. I'm optimistic of the opportunity, the potential opportunity, but I think the challenge that we still haven't worked out is there's a whole range of ethical issues around AI, and there's one is in the assessment. Do we want to move forward to a world which we're prioritising non-human assessments? I think there's a fundamental question there, and I don't think there's a right or wrong answer. Certainly, I can only speak in the field of suicide prevention specifically. We're moving forward with baby steps in a way. We're trying to harness it both for understanding its role in assessment, but also the delivery of interventions. But it's a really tricky one. So actually, I organised an event recently, and we had a number of questions from the audience asking us on this, and actually, there's huge concern from the Global South about the growth of AI because they're suffering. So when we think about the growth of AI, right, we can, in the high-income country settings, we can maybe benefit in the short term, but we need to look at, there's a load of issues that I hadn't properly thought about, is how this harnesses globally. So I know I'm sort of woolly waffling a bit because I think it is a difficult issue. We have to harness it. I think we have to try and embrace it, but we need to do it in the safest, but crucially for me, the most ethically secure way and the safest way possible. I'm taking into consideration these broader, the cost, the resource implications as well as vast.
I'm not going to properly answer the question. I'll just do a slight plea as a writer who gains a small income from writing that I really don't like AI. But otherwise, I don't really get much about AI. But I am aware that many of the people I've consulted over digital health, which may have a perspective on that, really find that very difficult. Many people with severe mental illness are extremely excluded from the digital sphere or even from using phones. And although DBI in Scotland uses phones and is useful, a lot of people don't use that sort of communication method, as do many people not use the internet or laptops or computers or anything else. And I do worry that with our need to become more efficient and to cut down waiting times and to use staff better, that people don't really get the care they really want and could deserve, and should really have that choice when given these sort of therapies online or in any other form. For some people, being very old-fashioned and rather old myself, face-to-face is what people really do want. So AI is an extreme a bit further than that, so I think you can think my inference on that.
Do you have any AI views, Stephanie?
I've never used it, so I'm going to stay out of this one.
Okay, fair enough. Yeah, I was just thinking about it just on the media, hearing it more and more, and it's ramping up faster and faster in terms of the wider impact on young people. They're already making estimates around the amount of sort of entry-level jobs that are going to start disappearing. How do we, and that's going to impact us in research. How do we train young people if we don't, if we get a robot to do things more efficiently, and what are the risks in that in terms of the inherent bias. But yeah, so as well as it potentially having a way to help us in health services, it's also got a huge potential to create a lot of havoc and damage, and potentially, especially for young people. Yes, we've got another question.
Hi. My name's Paul Orcock. I'm a newly qualified suicide first aid trainer. I appreciate everyone in this room that is dedicating their time, energy, effort and lives, I think, to this sort of field, and I feel kind of privileged to be in this room. David, I think, took my question really around fit for purpose and sort of actions we're taking beyond research, but I guess my question to the panel and perhaps to everyone wider here is, from a future research perspective, how do we balance the need for research and action? Because we talk about the feedback loop almost, don't we, in terms of the ability to do these programs, to do the process evaluation and get that feedback. So certainly from a suicide first aid perspective, intervention, postvention, and we're trying to really look at prevention. So the fit for purpose and the mental health services, what can we do more of in terms of balancing the need for action and sort of the prevention side of it?
Want to start?
Well, I think the direct answer to your question is implementation science, basically, and I think that, so it's just making sure marrying up the link between research and action. So for too long, we were surprised, and I think in the mental health field, going back years, why interventions didn't work. And the reason they didn't work often is A, they weren't co-produced, B, there was no theory of change or logic model or theoretical underpinning, and then we're going, why on earth didn't they work? It's because we hadn't targeted the correct mechanisms, or we hadn't looked at the conditions and the context which facilitates that evidence or that intervention working. So for me, the key challenge moving forward is no piece of research, doesn't matter how small or how big, if it's an intervention, it should never, ever be funded without a proper process evaluation or evaluation embedded. I mean, that has to be fundamental. And I think that we're moving towards that. So for me, that's the biggest challenge. If we describe the last 25 years as describing the phenomena and problems, I firmly believe we're in the decades of translating that evidence into action. But that's a whole different skill base that we didn't have. I think when I started out in the field, we certainly didn't have this.
this is a not very helpful answer. I've been speaking out about mental health issues for 40 years and worked with many people who've been doing so for a number of decades. And over recent years, I've been working with a group of them who've been saying what we were saying 30 years ago was pretty much what we said 20 years ago, which was pretty much what we said 10 and 5 years ago. And they've got to the point where they're saying, we'll talk about it because it's sort of fun to talk about it, but we really have lost any faith that anyone's going to do anything about making a difference. And so they're on a semi-strike saying, please stop consulting us because you can go back to papers we wrote, like I said, 30 years ago, and you could just use those results. So that's not a helpful answer at all. And I would hope that we would have a better world, and I would hope I would go home and feel more positive. And I probably will do after this conference.
Stephanie.
Can I just say, I mean, I agree, and I've had that conversation with people many, many times. But you know, everyone keeps saying we don't need any more data. But then I ask the questions about, then what do we do about the groups of people who are missing from the data that you're relying on? So I think so much more can be done there in terms of building the trust back in research, if it ever was there. But building that trust, making sure that we have identified, who are the missing voices in a lot of what we've been talking about today. Because I've sort of noted, we've had many presentations that have noted data gaps. So one output of this conference, which would be excellent, would be to sort of summarize across all of the talks what were those data gaps, and then talk about the implications of us not knowing. So what do we not know? We focus so much on what we do know, we forget to think about what we don't know. So I think it's really about us challenging what we know at this point, and then thinking forward, as you suggested, about then what would be, what needs to happen to gain that knowledge, and then, what would be the actions. But thinking about them all together, not just in terms of an intervention, but just, even observational epi, maybe it's me and my sociology hat, but what is stopping us from thinking in that way about, all of the research that you all are conducting?
Can I just add one gap, which came to me when you were speaking, Stephanie, is, so a major gap which many people don't know, right, is, and it's both in a descriptive way as well as an intervention way, is, so we talked about male suicide and middle-aged men, right? So one of those reviews I touched on already, which was a review of the world's literature on the last 20 years of qualitative research looking at men's suicide. And we published a systematic review of the world literature ever conducted on longitudinal or retrospective studies looking at quantitative studies looking at male suicide risk. In the qualitative literature, there were 78 studies ever conducted on men. In the quantitative literature, I think it was 105. 3/4 of all suicides in our country are by men. So a key gap is, we think we understand males. So just your point you're saying about the things that the people say we've got enough data. For example, we don't have enough data in men, right? That's one example, and that's only one population. Minorities populations, another group. LGBT, there's loads of groups, but the one that I just think stark, given that 3/4 of all suicides are men, is men, right? And there's a whole host of political and sociological reasons for why that's happened. But going back to your question, David, that's what we need to get at that.
Okay, we have just a few minutes, so we'll take Chris's question. That'll be the last question for the panel, and we'll try and finish up in the next 2 or 3 minutes. Thank you.
Thanks, Joanne. We talk a really good talk about co-production and involvement, and looking at the people who are missing from our data. But when we make decisions about what we're researching, what we're funding, how we will conduct that research, are we always standing by those principles?
because it often feels that a lot of those decisions about research priorities, about what we research, how we develop solutions, a lot of those decisions are made way before any stage that we involve people. So how do we start to live up to that principle?
So I talk a lot about it being open to being wrong, being open to making mistakes, but most importantly, being open to sort of agile ways of working in research. So I think that we can develop a set of guiding principles that include the things that we've been talking about the co-design and the co-production. But does it happen always? No, that's not a realistic expectation. But what we can do is recognize when it hasn't happened at the point at which we would agree is very important, which is very, very early on. What do we try and correct that at the first opportunity? So for me, a lot of times, always, I feel it's incredibly important to pay people for their contributions. I don't take volunteers. I get lots of email requests about, can I come and volunteer with your group? Can I come? If I don't have the money, I'm not going to take you. So I've got to write something to get the money. So, I often have this conversation with early career researchers. It's like, give me an idea and we will work together to try and find the money. But that's the reality of the situations. It's this cycle. So there's a lot of things that, have a price you need resource for. So that to me is just the reality of the situation. But I do think that, when I don't stand up and say I've always got it right and we're always doing, we bring in everybody, because oftentimes that's not possible or it doesn't work out. When I engage in a partnership with people as well, I'm very upfront. If, just like any social relationship, if we need to break up, we need to break up. It's not working, right? So you also have to give people that opportunity to get out of that situation when it's not working. So that's part of that co-production and that design that we don't talk a lot about, or where it fails, what goes wrong. And if we had more of that, I think people would be a little bit more open about, how we can get to the point where it is just that natural, and that we're training the next generation to sort of think in that way. This has only been going on for a short period of time. Relatively speaking, like if you think about it in a meaningful way. So we're just in the sort of beginning phase of this, and what we need to be thinking about is how do we improve our practices, do the best that we can, and then how do we train the next generation of researchers where their expectations are that happens at the point at which you start thinking of an idea.
I've got a bit of a wee-twee story to tell you. I wrote poems in my final exams at university and not surprisingly failed, and have no qualifications apart from my A-levels. Although over my career I've consulted thousands of people and written many reports, but I've always felt that they've lacked, that they've not been of any value, because I suppose people such as you are very clever and have proof you're very clever. And very recently I've started getting involved very vaguely with academia, and at the moment I'm mentoring for 4 hours a month a professor at Glasgow University, and getting my staff card with my wee photograph, which I promptly lost, was a really nice feeling, and it made me personally feel that I had some value in an area that I've never really been very used to. So it's quite a nice feeling. The more that happens, the better it would be for me.
Say, Graham, that, all ways of knowing and all kinds of evidence, we need to equally value all of them. And I would say that today, your contribution has been, if not one of the most powerful, ways to provide evidence to influence change. So you deserve all the credit you get.
just saying, I mean, I agree with everything that's been said. I think there's just, like everything, there's good and bad examples. Martin Jones, who was here earlier, who's a lived experience of gambling harms. And he was speaking at an event, we were both speaking at it a couple of weeks ago, and he was talking about his experiences, and he was saying exactly that. He said he named examples of where he was involved as a lived experience individual, and he didn't feel that he was respected, involved, and it was a box ticked. But then he was able to give other examples where he felt fully involved. So as you say, we have to, so it's learning, and we are learning, and so, but the other, I mean, in terms of drivers to change, so one of the really positive development I see in the academic field, for example, Lancet Psychiatry now, the journal, require you to talk about your lived experience involvement, and it's not, and they're very clear, this is not, we don't want tokenism. So, and again, over the last 10 years, it's just remarkable that it's not quite a transformation, but it's getting there. And again, the last thing to say about Scotland is, in government policy, in suicide prevention, we have 3 evidence bases, and they're all valued equally. Lived experience, academic evidence, and then service evidence, and nobody gets priority over others. And I think that's the way forward. So I do think we are moving forward. But you're right, Chris, and Graham says as well, we still have a long way to go.
Thank you. Stephanie, do you want to add anything?
No, I think we're past time, and people probably want to enjoy whatever's out there for us.
It's been the theme of the day, yeah. So I won't take up too much of your time. However, if you do have time, on the theme of actions, we'd like you to just take a couple of seconds to help us to understand how we've influenced maybe some changes that you might make going forward. So I have a whole load of things. In fact, I almost started writing a poem, co-create, evaluate. I'm not going to go any further. But yeah, I think that really powerful message about the next generation of researchers, and let's not just keep doing the same thing, let's start doing things differently and work together to embrace the complexity. The panel has summed up beautifully some of the real key messages that need to come out of today, so thank you very much for taking the time to do that. I also need to thank all of you and all of our people online somewhere out there in the ether for staying with us today, and all of the speakers for your magnificent contributions. I've been so excited how it's really kind of all come together. We've tried, it's a huge thing to cover, but I think just mixing it up a bit has made things just a bit more exciting. This isn't, and also to thank the British Academy, of course, for supporting us today. This isn't the end of it. What we would like to do is, or what we will do, is we'll produce an output from the conference. It'll come out in the autumn, and that's going to include an account of what everybody's been talking about today, some of the ideas. Maybe we'll do some stuff around the gaps, some more work on it, and also picking up on the audience participation, what you've been saying today, and everything you've put through here. Online, people online, we will make sure that all of your questions are answered. So speakers beware, you may get emails with questions. What else do I have to say to sum up? I think that's all, actually. Yeah, let's go and have a drink. There's some booze outside. Thank you very much, everybody.
Thank you, Joanna.